birth and death registration, computerization. I can name many areas where Dr. Gohanandam set the standards for others to follow. He has also worked as CDC project director in the Public Health Management Institute. He has worked with UNICEF and currently he is the HOD of Social Medicine and Infectious Diseases at SIMS Hospital. I'm very happy to invite you, Doctor, to talk of your personal experience as a field practitioner in the area of public health in urban areas. Dr. Pankaj B. Shah, may I invite you to the stage, please? Dr. Pankaj? I'm very happy to invite Dr. Pankaj to the stage. Again, a known academic, an expert in the area of public health. He has been on various committees for curriculum development, deeply involved and committed to the cause of improving the public health of the state. When I spoke to him over the last 2 days, it did not take me much time to realize his both expertise as well as commitment to the cause that we are all going to be talking about here today. Then I invite Dr. N. Chitra, our officer on special duty in the cadre of Directorate of Public Health and Preventive Medicine. As I said, all of them have grown with me in this department. So when I see them, I see the younger person that I knew when when I initially joined the nutrition department. They all worked with me as young people, and they have all grown with me, struggled with me, learnt with me. And I'm really happy to invite Chitra to the stage to share her deep experience and expertise on the area of the public health cadre which they have been managing and the various issues they are facing. Last but not least, I would like to invite, this is my own addition, I take the liberty from the organizers to invite Dr. Mathivanan, retired Deputy Director of Public Health. He has already addressed this audience yesterday on the topic of the Public Health Act, but I was really amazed at the expertise and the knowledge that he has on the Public Health Act. And when I learned that the minister will also be present, I thought that we must have the best at the top. So I took the liberty of adding him to our panel. So with this and without further ado, I will request, as I said, the order is slightly different, Mr. Sunil to take the stage. Yes. Yes. The format will be that each speaker will speak for about 5 minutes, after which I will summarize, and then we will throw it open to the audience for question. I request the audience to be highly attentive so that you will have lots of questions and fill up the session with more interest and more enthusiasm. Thank you.
Honorable Health Minister, Chairperson and distinguished panelists and delegates. I would just like to raise some of the macro issues, not touching about public health, Tamil Nadu Public Health Act, because there are a lot of experts there, but talk about more the national level and what are the major issues of concern which I have seen in the last 30, 40 years. I think public health has suddenly become the flavor of the season, especially after COVID, okay? What is happening at the national level, if I could share some of the concerns, is we had a National Health Bill of 2022, and till now we have really not seen any of the draft, at least in the public domain. There has been a lot of discussion, but we really haven't seen that. It was supposed to be introduced in the monsoon session in 2022 of the Parliament. And this actually covers not public health per se, but it talks of management, epidemics, bioterrorism, and disasters. Now, each one is different, and they need to be addressed differently. And that would be my suggestion, to look at it in terms of that. It had suggested a 4-tier health administration, both at the national, state, district, and public health at the block level. It also suggested a National Public Health Authority to be headed by the Union Health Ministry, chaired by other health ministers of states, creation of public health cadres at national and state level. We still really don't know what is the present position at the national level, but my views are slightly different. What has been happening at the state level, ma'am referred to that already some states have public health acts, including Tamil Nadu, Maharashtra, Bengal and others. But remember, this was in the context of the British period, which had really thought of public health. in that sense. And these were something that they left over to us and we continued with them. And other states like Kerala has this public health bill which is being drafted, discussed, Punjab, Orissa, Meghalaya, everybody's talking about it. And there is an upsurge on having acts and legislation about this. Recently, the MOHFW brought out a booklet which calls itself the Public Health Management Cadre, Guidance for Implementation in 2022. That is another area. Now, I'd just like to, a reflection on how did we handle the biggest pandemic in our times? We did it with a more than 100-year-old act called the Epidemic Disease Act of 1897 and the Disaster Management Act, which actually primarily dealt the pandemic with the police department. At the time when IDSP was required, we closed it down. We didn't look at IDSP, many of the states. Tamil Nadu may have looked at it. I think one of my suggestions are, if we really want to look at the Public Health Act and the Public Health Cadre, I think the primary healthcare model is more than 75 years old, needs to be revamped, reconfigured in view of the changing environment. I think I also would like to suggest there is an urgent need to review the functional review of the Directorate of Health Services. Many states continue to have cadres that are redundant today. Some states have 800, some states have 1,700 cadres. You know, and we are keen on adding another thing called public health cadre. I think we really need to relook at how does this public health cadre function. Between center and states, we really need to look at what is the role of the center and what is the role of the state. I think if you really want to give importance to public health, you need to look at a separate department of public health, both at the national and state level, with a secretary, full-time secretary, dedicated to public health. That is the need. I just like to come up a controversial issue of the National Health Mission. It did a good job in the beginning, gave the system a kickstart, but subsequently we ended up having two different bodies at the state level, Directorate and NHM, and now we are competing with each other. We need to look at, there are serious capacity constraints. The introduction of National Health Mission and creation of parallel systems has contributed to these constraints in many states. And I'm talking about in the context of public health and public health cadre. It's not something. The National Health System Mission was built to improve the system, but over the period it has become the system itself. Programs like NRHM, NHM, Urban Health Mission are were supposed to be run in a mission mode. They should have had a finite existence, but they just still continue. Public health cadre needs to be examined into, we really need to relook at this primary, secondary, and tertiary. We have been banging ourselves with these three things. In the emerging needs, are these really relevant or need to really relook? Public health cadre needs to be placed in the continuing challenges of shortages, recruitment, deployment. We continue to have shortages of our doctors, nurses everywhere. Retention, education standards. Another area I would like to bring, we have really not done any assessment on the demand for doctors, nurses, staff. We really don't know how many we would require in the next 10 years, 20 years, other than that one figure of WHO mentioned this ratio of doctor-patient ratio, forget that. We really need to do a good assessment. Health human power policy, every industry has a human resource policy. Do we have a human resource policy in health? Yesterday, sir mentioned 75,000 health workers. Who's taking care of them? What is the policy? Public health cadre has to be placed in that context. Very important, very great to have public health cadre. We can all go around. How does it fit into the civil service rules along with the pay? Because otherwise we'll have contractual staff being appointed and calling them public health. Tamil Nadu has addressed it, but other states I'm really looking at. Need to look at actually that public health card is not restricted to clinicians and medical professionals. It is important to bring in non-medical professionals building multidisciplinary skills. Some last points, ma'am. There's suddenly an upsurge of masters in public health. I teach some of these institutions. Some of my students are here. Right now, there are about 80 institutions conducting masters in public health. I think there is a need to establish a self-regulatory body to look at standardization of curriculum and code of ethics. And what is it? Last point I would like to bring, we all talk about accountability of ASHA workers and public health, medical officers. I would just like to bring and say we need to strengthen accountability and regulatory controls amongst the health workforce, starting from the highest level, Health Secretary, Government of India, to the peripheral staff. Let the Health Secretary be accountable for their actions. Because I find every time one Health Secretary comes, starts a new scheme program, and then disappears. And then the next Health Secretary comes, he changes it. I mean, sorry, we need to have kind of some accountability systems, especially from the Health Secretary level. Forget the ASHAs, they can be, you can keep asking them targets. Finally, any public health act or public health cadre needs a demarcation of responsibilities between different tiers of government, capacity, administrative infrastructure, human resources structure, monitoring accountability, and last but not the least, rights and duties of the citizens. Thank you, ma'am.
I will now request Dr. Guhanandam to make his talk. I will be using a bell. Unfortunately, I didn't get the bell long enough. But if nothing, I will just shout out saying the time is up. I request everyone to keep within 7 minutes, 5 to 7 minutes. Thank you.
வணக்கம், வாழ்த்துக்கள், மகிழ்ச்சி. 100 years of DPH வந்து ஒரு பெரிய சந்தோஷமான விஷயம். I think we can all give you a healthy clap for it. Wonderful. I actually belong to the Chennai Corporation cadre as a city health officer, director of communicable diseases hospital. I have the privilege of actually participating in this program because you know Chennai Corporation is the second largest municipal corporation in the world. Number one. The first municipal corporation is London Municipal Corporation. The exact point of Public Health Act started in 1834 by Edwin Chadwick, who started it as a poor man's law. Poor law. To make you understand, it is called poor man's law. Yazhaigalin Sattam. He started like this. The Yazhaigalin Sattam, as you think now about UK, in 1830 and 34, it was ditches, dirty, slush, filth, everything. அவ்வளோ மோசமான ஒரு லண்டன் சிட்டி. அந்த சிட்டியில் ஜனங்களுக்கு வந்து ப்ராப்ளம் வருது. They go for a cholera outbreak in 1842, and this Chadwick is presenting a paper on how to really improve the lifestyle of the laboring class, the poor sections in London. Then it becomes, his publication is Public Health Act like submission he is making it. Then in 1948, he brings out with the support of the local councillors in Sundraland as British Public Health Act. In 1875, the act was converted through the legislation as the first Public Health Act in London. Then how it travels to India? It travels to India in 1919. 1919ல சென்னை மாநகராட்சியினுடைய ஆக்டை கொண்டாடுறாங்க இங்கிலீஷ்காரங்க. செகண்ட் ஆக்ட். அந்த ஆக்டில் எம்சிஎம்சி ஆக்டில் பப்ளிக் ஹெல்த் ஆக்டுக்குன்னு தனியாக வந்து ஒரு 50-60 செக்ஷன்ஸ் கொடுக்குறாங்க. அட்லீஸ்ட் 50-60 செக்ஷன்ஸ் வேர் allotted in MCMC Act. Then in 1919, that act was conceived by the people like Ronald Ross, கேள்விப்பட்டிருக்கீங்களா? Ronald Ross is the person who discovered malaria. He was working in Chennai. He was working in Secunderabad. He was working in Assam, Jharkhand, all these places. He born in Jharkhand. He's an Indian born British person. He was an IMS officer. This you must understand. When you talk about public health cadre, you should understand about public health cadres, how it developed in India. My ma'am is there, secretary is there, our honorable health minister is there, everybody is here. I want to raise this issue as my participant. Ronald Ross was an Indian medical service officer. Okay. அப்போ இன்னொரு சர்வீஸ் இருக்கு, இப்போ இருக்க ஐஏஎஸ் இருக்குல்ல, this IAS was called as Indian Civil Service, and that was called Indian Medical Service. If you see the name board of deans of Stanley Medical College, MMC or Madurai, you will see the first 5 or 10 people are all British deans with IMS degrees. And after independence, unfortunately, the rich people who are there in the medical field, they didn't bother about taking up this IMS, and it is actually vanished. Or because of the IAS people dominated, this IMS are lost. So my point here, when you are developing a public health cadre, you have to always think about bringing back that Indian medical service into in India. And this, I want to present it before the health minister. Health minister is not only my good friend, he was my mayor. So I wanted to make it pertinent to make him understand that this IMS should come in India through the legislation passed in Tamil Nadu Assembly. And also, the Tamil Nadu government can also start the cadres, like the DRO cadre is there, deputy collector, sub-collector. You have to develop a cadre like this, at least to start, even not in India. Even now, the influential government can start this cadre as the Tamil Nadu Medical Service cadre, and which will go as a Indian Medical Service cadre. So that 1919 MCMC Act, which had Public Health Act, then came to Tamil Nadu Public Health Act in 1939. It is not Tamil Nadu Public Health Act, Madras District Public Health Act, 1939. Then it has merged into Madras State Public Health Act, which is now the Tamil Nadu Public Health Act. So the entire transmission of this act has come from the poor man's law up to this law. The other question I would like to raise is, this Public Health Act, should it remain only with the public health people, health officers, DPH, and sanitary inspectors, village health nurse? Is it not having a very big area? You have seen COVID virus. The COVID virus made the entire world understand what is public health system, public health department is. The entire world was able to realize, my friends from US or UK, they used to say, your department is really highlighted now for the past 2.5 years. Public health is being highlighted by Corona. And rightly, DPH has congratulated every one of you. I would like to join you as a congratulating person that the doctor community and the public health people, they struggled a lot to control this coronavirus along with the government. And we are successful. And this public health is to make you simply understand. I heard there are some medical officers, a lot of medical officers are also there. My understanding about public health is taking control of the disease, preventing the disease, not for a group of people, but for the millions. If I take classes to my people, I think there are many of my students are here. If I talk about public health, I will say, public health physician treats millions. A physician treats hundreds or thousands. I don't decry about him, but the role of the public health person is reaching the masses, taking the science, medical science in a simple way that it reaches large number of people. Another example, in coronavirus, COVID infection, 10% of them got admitted in the hospital throughout the world. 90% of them are in the field, in the villages, in the urban cities, everywhere. Who took control over them? Who prevented them? It is public health people. I don't, a lot of appreciations for my own colleagues in the government sector who struggle hard to really save the lives, but the people who struggled on the roads slogged in the streets and dirty streets of Chennai or any urban cities, going house to house, identify the cases, follow, preventing it, isolation, vaccination, all these things are done by the public health people. And that's why I say the public health people really control the disease among the millions, and the physicians control the disease among the lesser number of people. And now, where is the limitation? Where is the demarcation line between the public health people and the curative people? This all should really mingle together. I was a student of John Hopkins. I was just recognized here. My dean of John Hopkins is a public health professor. And London School of Hygiene, where I studied, the dean is a public health professor. I was wondering why these public health people in Tamil Nadu and India are only in the public health cadre, and here the public health experts are the deans. ஒரு டீன் கூப்பிட்டு அந்த பப்ளிக் ஹெல்த் ஆள் கூப்பிட்டு ஒரு ஆடிட்டிங் நடத்துறாருன்னா the physicians will really at their feet to answer him. He will question it. அப்புறம் தான் then I realized the city health officer of Chennai Corporation used to conduct death audit meeting in GH in the pre-independent era. Ronald Ross was identifying the parasite of malaria in the gut in the eye hospital, Egmore. He confirmed it in Secunderabad. He declared it in Uttarakhand and then in London with the help of his mentor Patrick Manson. So the point is, so much of thing is there. Please understand, public health is not just one group of people. It is also the clinicians. Now the public health has advanced to talk about public health for cardiac illnesses, public health for non-communicable diseases, any disease for that matter, whether it is infectious or non-infectious.
Dr. Gohanandam, one minute.
Yes, ma'am. If it is going to prevail upon large number of population, it gains the importance of public health. Heart, இப்போ பாருங்க, corona, COVID infection, I was doing an analysis. I was in the advisory committee of the Chief Minister, Honorable Chief Minister. I was repeatedly telling 70% of the deaths in corona are mostly diabetes and hypertension. To control that, in public health day, what we did, we suggested the Commissioner Corporation of Chennai as well as other people in the committee, identify all those cases of NCD, diabetes and hypertension, each house, treat them with their anti-diabetic drugs, put them on drug, and also hypertension because public health. And public health is the mother of the entire spectrum of health sciences. And the public health is an attitude, not the degree or the position. A politician can be a public health person. Edwin Chadwick was a public health person. He's a social worker. He was a public health person. There are economists who become public health people. I think with this introduction, I think Madam will give me some more time also afterwards.
I can give you any amount of time. Only
Thank you. Thank you for listening.
Dr. Gohanandam, it's a pleasure to listen to you, and I'm sure the audience will agree, but I have the unenviable
Yes,
task
ma'am.
of running the session. So could I request Dr. Shah to take the floor?
Respected HM sir, and I'm thankful to Selvinayakam sir, Somasundaram sir, madam, for this opportunity. Actually, madam, what is happening, public health is running in our blood and genes. That's why we are overflowing with emotions and time. As all of us know, we are talking about Tamil Nadu Public Health Act 1939. Many of us, including me and many youngsters, probably not born during that point of time. And the act is so strong, even after 100 years and more, is able to stand the test of time when the COVID came. Lot of use of those provisions are used during COVID time. If you see, in the true sense, everybody since last couple of years is worried about fever. You hear fear, your ears start. Today also there is a fever in India. Cricket fever or football fever. And if we see how the Public Health Act with the cricket and football, when the first man comes into cricket, goes opener gone, volume reduced, further people gone, TV shut off. In football, similar thing, 1 goal, 2 goal, then your favorite team gone. Everybody has to act. If you see, the way in cricket and football, every team member counts. In public health, every team member counts. As sir was talking about the driver, each and every person becomes very, very important. And when we talk about the cadre, the skill development is very, very important. Without skills, nothing can work. Each and every person has their own skills when it comes to public health. Skill building has to be there in all levels, including the grassroots level to the highest level. And when it comes to health, health is not only health. Health is multidimensional. Each and every person in the world or India has to contribute towards the health. Otherwise, the public health will never improve. And that's why community ownership has to come. We talk about ranking the cities, cleanliness, public health, etc., etc. Why they are successful for years and years is because the ownership of the population has come. And Tamil Nadu, when it comes, it always stands at the highest level of model. And that's why we talk about Tamil Nadu Public Health Act. This conference is the biggest achievement. We can see hall is full, people are standing, there are many people standing outside. That's the success of public health in Tamil Nadu. And usually we attend so many medical conferences and all, but this kind of conference, DPH Icon, is a memorizing moment for all state governments, not only in India, but also in the world, to say that how the conference where the public health can come together for the skill development. Partnership is important. When we talk about this act is a very strong enough, but being 1939 and now the things have changed. Need to have some kind of rules, regulations, or some kind of provisions where we can make skill building as part of it. Partnership as a part of it. We always talk about public-private partnership. That's the only we look at it. But there are many more partnership has to happen. Public-private partnership. Two government organizations have to talk to each other very nicely. Two private organizations has to talk to each other. And then public-private partnership can occur. Always, if all of us understand English, we write I as a capital. But when we write V, W is never a capital. V has a more power than I. And this can be shown here with the example of the COVID. COVID gave us a lot of examples, and probably that learning will never go. And that's the biggest skill development which is being done anywhere in the world for public health is concerned. And we should not lose that workforce. Many times we hear different kind of stories, but amount of the workforce, not pure public health, even the voluntary people who came into picture really make a big difference in that control. Second important aspect where the act has to move forward is the digitalization. Artificial intelligence, machine learning, a lot of things are happening. When you entered probably Mahabalipuram, your Android phone or the WhatsApp or the iApp told you more things about Mahabalipuram than what you know about it, because we are being tracked. Digitalization, privacy and confidentiality really plays an important role. I don't know how many of you have seen that video which moves in the social networking site. A person says, I want to order this, and the artificial intelligence tells what to be done next. And finally they say, you know everything about me. I want to change the city and go to the another country. The artificial intelligence machine says, your passport is expired, you cannot go anywhere. The time has so much involved where internet is going to be each and every part of our life, is going to be in blood, is going to be in our genes. We have to use the digital health system in a systematic way so that privacy, confidentiality is maintained, as well as the national security, cyber security, so many things comes into picture. And each and every public health cadre has to be aware. We are working on mobile phone, apps, iPad data entry, so many things are happening. If these rules and regulation with skill building as well as intelligence and involvement of IT-based technology comes in the rules of or some kind of provisions of Tamil Nadu Public Health Act, it will really make more and more things more better way to look about it. And finally, you must have seen one statement moving in the media since last couple of times. The acts are well understood by lawyers, not the common people. We need to make our rules and laws which can be understandable by general people. So probably we can have some kind of provisions where the act becomes the part of the ownership of the population and it is followed. Thank you very much.
Yeah, thank you, Dr. Pankaj, and kept within time also. Request Dr. Chitra to make the presentation. This will be followed by Arushi and then finally by Dr. Madhu.
Good morning to all of you. I just wanted to highlight about the challenges we are facing in delivering health services to the community. It's mainly our HR issues. Actually, our main HR and male health worker. They all come under, they are originally from our public health department. They come under public health cadre. Actually, our population long back in 80s, population was divided into HSC. For the 5,000 population, we have one HSC and one VHN and one HI. Actually, that time they were looking after only the MCH activities. But even after 50 years, we have not increased the creation of number of HSCs, we have not increased. And also our VHNs are looking after not only MCH activities, but all the 12 services which comes under universal health coverage. That is non-communicable and communicable diseases. And also we have, previously we had one HI per HSC. Now it has come down to for 3 HSC we have one HI. So it creates a lot of problem in giving services to the community. Our VHNs are not able to go to the field. They are not able to do a house-to-house field work because most of the VHNs are looking after more than 10,000 population. So we wanted to bring all these under public health cadre. In a public health act, we wanted to cover all these people in a public health act or the public health code. And also it is worse in urban areas. So for each urban PHC covers 50,000 population. For that we have only one medical officer. Even though they see daily more than 150 OP, we have only one medical officer. When compared to rural area we have 2 medical officers. As per IPH standard, one medical officer, they can see only 75 patients. But in our urban area, they are seeing more than 200 patients per day. And also, previously, our local body was taking care of the health services. But after NUHM introduction, after 2013, the whole thing is taken care by the DPH and PM. But for the staffs also, they are not giving, even though they are getting a grant from Government of India, they are not paying the staff. So it creates a lot of issues in implementing our services because we have a very limited number of urban health nurse in the urban area. And also we don't have any supervisory staff like rural area. Only one medical officer and UHN. There's no in-between second level officers in urban area. Actually, these are all the things we wanted to take care of in public health. So we want, even in under this Public Health Act, if this gives power for the HIs and above the cadre, like BHS, PA, health officer and DDs. But we don't give power to the medical officer or any other cadre below, like VHN, CHN and all. So we like to combine all these things and bring it under one umbrella. And actually, these are all the issues we are facing regarding HR. Thank you very much, ma'am.
May I request you to speak, Arushi?
Can you hear me? Yes. Okay. First of all, I would also like to offer my congratulations to my colleagues in the government of Tamil Nadu for this remarkable milestone. I think it really does deserve a very solid round of applause from everyone here. And I think it is very pertinent that we are discussing the Public Health Act at the start of the conference itself. And thank you for your invitation for allowing us to introspect and perhaps offer some reflections on what may be future steps in strengthening both the design as well as the implementation of the Act. I'd like to offer some thoughts on financing the Public Health Act, especially, and I'm glad I'm speaking after Dr. Chitra, issues around financing the health workforce and perhaps particularly the public health workforce and those who are at the forefront, in the front line, at the community level, and in the state constitute essentially the bulk of those who are providing public health and primary healthcare services. These comments are based on some analytical work that we had done at the World Bank, looking at different frameworks for governance as well as financing modalities for the health workforce, especially again those who are working at the forefront. So to begin with, and I'll try to be very brief because I think we should have a round of discussion after these really great insightful comments. I'll make very quick 5 points. I think first is public health programs and especially public health cadres are not cheap. Right? There is a large amount of financing that's attached to it, and most countries struggle in finding long-term solutions for financing their public health cadres. So I think this is a problem across the board. In fact, in many low and middle income countries, the financing for especially the frontline health worker programs often come from external sources. And in that sense, actually, India is a success where the public health, the frontline cadres are domestically financed. So I think we should take pride in that as well. The second thing, while they're not cheap, they're extremely cost effective. And I think there is now ample evidence to show how the frontline health workforce has made a remarkable difference in improving health outcomes, health service delivery outcomes, especially pertaining to maternal and child health services. I think immunization being the forefront example of how community health workers can make a big difference. But there's also now a growing body of literature that's showing that similar models for preventing and controlling non-communicable diseases, including mental health, is really the need of the hour and perhaps the future direction for the public health, particularly the public health frontline workforce. I think in that context, it is important to also note that in our work, we found that the most effective model for a public health workforce, especially those at the front line, is in the form of public health, in the form of primary health care teams. And Dr. Selva mentioned that it is important to reconstitute how public health teams are formulated, the roles that they are playing, and from essentially down the cascade, essentially looking at the entire care cascade for all specific kinds of diseases that they are often dealing with. There are lots of examples, especially from countries like Brazil and Thailand, which have had a long history of implementing primary healthcare teams. I think closer home, the Ayushman Bharat Health and Wellness Centers is also implementing the concept of a PHC team. In Tamil Nadu, we have the Makkalai Theri Maruthavam scheme, which is also looking at using a PHC team to provide a package of services for non-communicable diseases. So while this is a really good model for the future, I think its financing mechanisms, which are of course context specific, do need to sort of come in the forefront of policy dialogue as well. In that regard, I think it's important to also talk about the governance mechanisms for the frontline workforce. I think while we look at the frontline workforce has come up as a programmatic solution for many of the disease programs that use frontline workers. But there is also a merit in thinking about a relational lens, because your frontline workforce are often actually from the community that they are serving. They are the ones who are forming these trusted relationships within the communities, which are really what could inspire behavior change for preventive and promotive care. So in that sense, they are slightly different from a medicalized workforce, but they are really embedded in the community, and hence also need that framework of a relational lens, which basically means understanding the context better, understanding the work that they're doing, the context that they're working within, the engagements, the relationships that they have, providing them a platform to also have their voices heard. I think these are all important components that need to go into a public health policy dialogue, and especially in context of the remuneration. I think in many cases, the frontline workforce is often compensated using performance-based incentives. In fact, there is now a growing body of literature that says that this is not a very effective model in terms of both overall costs to the health system, but also for how it is motivating the health workforce that is actually receiving these incentives. So there is, I think there is, as we introspect, there is an opportunity to think about what could be other modalities of payments for the frontline workforce. The WHO in its recent guidelines has also actually come out to very strongly recommend not using performance-based incentives, but thinking about longer-term contractual agreements with the frontline workforce. And of course, how they are designed are dependent on the communities and the context within which they would be working. So I'll pause for now, but I think we hope that we can come back to this discussion. And while I did speak about the frontline workers in particular, I think the issues around financing the Public Health Act and other cadres within the public health cadre are equally important. And I hope that when you do re-look into future avatars of the Public Health Code and Act, there are built-in mechanisms for financing these with solutions for longer-term sustained financing. Thank you.
Thank you again, Arushi. Very insightful. Dr. Madhivanan, last but not least, and time limit of 5. I have requested him specifically because while everyone we have got a lot of inputs on the cadre. I think we have shared across a very interesting thing. Dr. Pankaj has spoken about the need for improving the act, but I think I wanted to hear the expert. And I wanted all of you to once again, in this morning session, listen to the expert.
Respected chairperson, respected director, other dignitaries and friends, very good morning. First, I must thank chairperson for calling me as a special invitee, because this is I am a surprise inclusion. That's why I was scribbling something on the stage. Thank you for calling, madam. I thank COVID-19 for making me as a specialist. Actually, COVID-19 made the whole of public health in the forefront of all specialties. So I really thank COVID-19. Still, Public Health Act is a powerful act because I am an example, because madam is calling me as a special invitee. As far as I am concerned, still we have got environmental sanitation is actually the Public Health Act is almost 90% deals with only environmental factors. Environmental factors are the most important, still continuing in spite of from 1939 we leave it. But after independence, we are still struggling with open air defecation. We have got let me take 1 minute, madam, on that aspect, because under Public Health Act, Section 37 says all local bodies are responsible for public toilets, establishment and maintenance. And Section 38 says every new building in the state should have sufficient sanitary toilet. And we are giving schools sanitary certificates under Public Health Code. So every school must have sufficient number of sanitary toilets. Then where comes the open air defecation? So the Public Health Act the environmental factors should be given, still we have to give more importance. And my request to the madam, to the chairperson is, we have to remove the urban bias in the act first, because mostly the act says urban local body under building and sanitation, everywhere water supply, everywhere it says only about urban local bodies. Remove that word, include local area. So it covers the whole of Tamil Nadu. Next one is about the department administrative aspect. It is the HI, the origin of public health is by the, historically it is by the male cadre, or I won't call it as male cadre, even female can become health inspector, HI cadre, because district health officers were the first person with only a few health inspectors for every public health activity in the field during British regime when it was formed, when it was first formed. So all other components of public health are auxiliary, whether it is birth and death statistics or MCH program. Every other thing is an auxiliary component of public health. It is the male cadre is the main public health, core of public health. So we must give more importance. NHM should fund more for this aspect, the male cadre improvement, by strengthening the number first and their capacity. So in these two aspects, we have to pay more importance. And then all my request, this is my suggestion, all public health officials should have some basic legal training, at least at the inception, and present officers also should need. Because it is my own experience, the person who knows law is more powerful than any other person. During my service also, I have literally seen that I seems to be more powerful than the person who is not implementing the act. So that's why I have got something. The law should be, I must learn something about law. So I stress the Director of Public Health to give a periodical reorientation on legal aspects, and they should be exposed to the judiciary proceedings, not the subject. The theory, instead of theory, they must be exposed to the judiciary proceedings first. Madam, can I talk about the? Yes, madam. So what are the new things to be included in the Public Health Act? Or first one is we have to need some provisions about the NCD, that is newly coming up, non-communicable diseases, because they are the major mortality and morbidity causing issues nowadays. Next one is about the wellness concept. And the other is right of the individuals. It is much talked about subject. All developed countries are talking about giving more importance to the rights of the individual in the Public Health Act itself. And then we have got present Public Health Act has got the emergency provisions under one section. Actually, it is 76. But it should be elaborated, and we need more sections to deal with public health emergencies. The bioterrorism aspect has also to be included. Some provisions we must have on bioterrorism. And another aspect is we have got many number of health-related provisions in various acts. All provisions, health-related acts should be consolidated into single Public Health Act. Actually, this is not my new concept. It was old. The Boer Committee itself in 1946 said all scattered legal health-related provisions should be consolidated and made a single law in state and central. And the public-private partnership concept is a new one. We all know everybody is doing in solid waste management, in toilet maintenance and other things. Okay, madam. Actually, what I said was already, most of the things are already discussed in Tamil Nadu because we are the pioneers, and we have also discussed, Government of Tamil Nadu has sent one proposal actually for discussion to the Directorate of Public Health. The bill is called Right to Health, Wellness and Right to Health Care aspect. They have sent a bill, that is Right to Health Care Bill. In that, what I said, except that environmental aspect, everything is there about digitalization, about addressing health threats from digital environment, and unhealthy lifestyle issues and everything, man. So I think I am really privileged. I am really honored by calling me. So I thank you very much. Thank you so much for everything you did, madam. Thank you all.
Thank you. I have to speak, all the panelists, at least I have been spellbound listening to all of them. I have 5, actually the session started at 10:30. We are to finish at 11:30, but I have my penny's worth to say, otherwise they won't give me my supper. I mean, I've already had my breakfast. So the point that come across clearly in this, and as all of you had seen, why did we put this up front? Most of the panelists spoke eloquently about the public health cadre, its definition, what should it be like. I think we spoke about what more we need to do. We need to skill them. We need to give them more legal training. We need to redefine who is the public health cadre. We need to make sure that, and we got points on how to finance them, how they should not be financed, how we need to make sure that they are. And I think the point of Dr. Madhivanan in the end, that originally it was just the district health officers and whoever was the health inspector, as he rightly said, men or women. The health inspectors were the core cadre. Now, there is a real need. One thing that comes straight across is there's a real need to relook at how do we redefine what is public health, who are the public health cadre, and how do we, and there is need not be place for this in the act, but there is definitely place for this in the code. And so one of the strongest recommendations, and I was discussing this with DPH before we came in, is that we put together a group to relook at the code, which will talk about many of the issues that got covered here in terms of who are these people who are discharging the fundamental field level public health work. And not only them, there was also a question across the board on are they the clinicians also? Who will be these people? For instance, there are young MOs here. Who are these? The MOs in the primary health center, PHC MO is a public health person. Till he is in the PHC, he should be a public health person. So not only the paramedical staff, but also the people who ultimately might turn out to be super specialists, when they are working in the PHC, they have to serve a public health function. So all of this points to my first point, which is we need to redefine who is the public health cadre, how they are financed. We need to clearly put down, for instance, we lost the male health workers because we lost Government of India financing. So it should not be like that. We should clearly define who is financing them, take full responsibility. Gostin says clearly in all his papers on Public Health Act, they say that we have to define duties, responsibilities. So both the duties and this again came across in many of your speeches, that duties and responsibilities need to be defined, and we need to relook at the Public Health Code. On the Act itself, I think again, all of us who have gone through it, and maybe this was an eye-opener for me, and all of you can spend some time reading that Act. It's not that big. It has got things on how to kill rats. It is amazingly forethinking for its time, 1939, to have thought about water and sanitation, the determinants of public health, to have thought of it in that time, to thought of vaccination, to thought of things today, as everyone said. Even I was not born at that time, so even the oldest people in this audience were probably not born at that time. But the Act thought of all these things. Therefore, it is time that though it is a very good act, it's a very good, strong, powerful act, we need to relook at it. We need to reframe it, and a lot of the new interventions that were talked about, the need for digital, talking about how digital will affect, what the previous speaker spoke about, health security. How do we build this? They have talked about animals. As a matter of fact, the One Health concept is strongly built into the act because there's a lot of talk about animals and zoonosis. But we need to rewrite it in the context of the International Health Regulations 2005. There's the IHR 2005, nobody mentioned. I think it's because it seems to have died some form of natural coma, not death. I don't want to use the word death, but it seems to be dying. But we need to put it back in the context of complying with IHR. We need to rewrite some of the sections of this act to put back today's developments, as all of them put it, skill development, the need for digital data, the need for relooking at the way work is done today. And I think just before I started the session, Dr. Madhivanan was telling me that even the amendment we carried out at the time of COVID, we should actually, many of them are in the form of things that have to be done as rules. But for that emergency, for that time, we needed to get it into the act, and we did get it in. So a lot of this revamping of the act, I think we need a small group to sit and, because even though the central government is, I think Sunil put it eloquently, trying to bring out a National Public Health Act, we need not wait for them. We have never waited for anyone. We are always, as I said, 100 years into the game. We need to re-look at I don't think it'll take much time because there's lots of evidence of what we need to do. We need to quickly not throw out the old act at all, but to rewrite it in the context of what we need for today. I think that's all I will say in view of the fact that there is a time constraint, and I thank you all for your patient listening. I hope some of you, at least the younger faces in the audience, are enthused to go relook at what are all these things that we seem to be proud about. What did all these people say? That's what we want in these panels. We don't, I know that we are very passionate about what we talk, but it may not carry the same passion to you. But please go back, read, and rightly it was said, go read and see what powers you have if you are part of this department. Go read and see what you should be proud about if you are part of this department. And I think it will make you all be better workers. Thank you again for this wonderful opportunity. Any questions from the floor? If there are still someone who has questions to ask, or is everyone looking for coffee?
Madam,
yes.
Can I take 1 second if it's with permission? Yes. I will start with the statement which is written on the website. It is once in lifetime event to celebrate the 100 years of Tamil Nadu Public Health. I request all of you to please give standing oration to the Tamil Nadu Public Health. No, it's not the end of the session. It's just the beginning of the life with public health. Thank you.
Audience? I think you had such interesting questions, including starting from London. I was very fascinated by that story.
Just I have only one request, madam, because as medical officers in government service, we write that departmental exam, we go through the books, all old editions, everything is there. So we can't even go through the entire book. So if you can bring the synopsis, what is really, with some references which we can do it later. So it will be a handbook to all the public health people, it will be very useful to us.
I think that is to Dr. Selva Vinayagam, but I downloaded it from the net. But that's why I'm enthusing at least this audience to go back and try and read what's in that act. You will find it fascinating. It was one day's nighttime reading. You will really find it fascinating. But I take Dr. Raghunandan's point that the legislation that you are implementing must be made available, because normally only your office staff will tell you. The powers irukku ungalukku. If you remember, and that's when you realize, we have all been through that, whether, as he said, they're part of the Indian Medical Service or the Indian Administrative Service, very often it is just the people under you will bring you an act and say, you have got powers. So I think if any one of you who is part of the system and academics who are studying the system, please do go through the acts. And the code. Code is equally fascinating. And it's not even on the net.
Yep. Thank you, ma'am.
Anyone else?
Yep.
Any
I
other
have one
question?
question. I was fascinated by Dr. Guhanandam sir's
prompt of introducing or reintroducing the IMS. So I have a question to the chairperson because she is an IAS officer right now. Is it possible to reintroduce IMS, that's the Indian Medical Service, and what would be the time frame of bringing it in, or should we pass it as a bill, or what should Tamil Nadu government or the Department of Public Health go forward in taking forward that idea if you think it's feasible?
I'll answer that. I was also fascinated. I think the central government has periodically talked about a All India Medical Service. And the point really is, even in Tamil Nadu, we do have Dr. Uma is a case in point of somebody who started from the public health service and has landed up as an IAS officer. But that's a different transition. Now, what is the difference between what we have now? That is a person entering as health officer and becoming rank of Director of Public Health to an Indian Medical Service. Now, earlier the Indian Medical Service, with the example of Dr. Ronald Ross, was both clinicians and public health people working side by side across. This was at one time, for instance, in the Indian Civil Service, judges and administrators were interchangeable. There was no judiciary. The ICS was both judge and similarly, what I can see from the example he gave in terms of people who are deans of Stanley Medical College who belong to IMS, as well as the international model where people trained in public health are heading clinical institutions, is that the IMS will be across the discipline. Today, there is again an assistant surgeon, there is a civil service for the, who becomes an administrator in the medical side now, is a person who enters as an assistant surgeon and goes up. But there is no separate administrative cadre. Again, even in my 40 years, my long 40 years, 3 times we have considered an separate administrative cadre for the clinical side. We have not at any time tried to touch the bastion of public health, which we felt was unalienable. We didn't want anyone coming and putting their hands or doing something to that. So we have retained, during the 2-3 times that we tried to create a cadre of medical administrators. For some reason, at every point when the choice was given, do you want to do clinical or do you want to move to administration? It became a bit of an issue. But there is nothing in theory that stops us from doing it. And there is nothing in theory that stops us from, there is some, to put, for instance, a director, we have had people going from the Directorate of Public Health to the Medical Education Department. So there is a lot of inter-movement. So it is possible. It is just difficult in practice. Sunil, you had something to say.
Yeah, my counter question would be, I have read quite a bit of the Indian Medical Service and how it started and a whole lot of. One question to the audience and to the chairperson. Will you include in the Indian Medical Services the nurses, the dentists, the pharmacists, or is it going to be a exclusively allopathy doctor-centric medical services? Sorry, I will not agree to having a medical service exclusively for allopathy doctors only. Because if you're talking about, and if you think Indian medical service is going to change the scenario of public health in India, sorry, I don't agree. We need, please sir. My question is, I already mentioned that public health is a multidisciplinary approach which includes various data analytics, health insurance, and it has become changed. It's no more a allopathy-centric medical approach. Please make the Indian Medical Service. I will support it, but please include nurses, dentists, pharmacists, allied health professionals in this service. Thank you.
I'll ask Dr. Guhanandam to respond, but before that, my penny's worth is today, many of the people who have moved into public health include the allied professionals. That is, I know a lot of excellent public health professionals who ultimately moved from dentistry, pharmacy, physiotherapy. So, Dr. Guhanandam, we just want to know your concept. I mean,
Actually, what Sunil said is right. We don't recur to how only doctors as IMS officers, because we are trying to develop a cadre. There could be nurses, there could be public health engineers, there could be public health economists, all these people.
data
can become,
people, yeah.
Definitely. But what I am trying to say is, in these sessions, always develop policies. Think of policies, not the intricacies. For example, finance, they say, purpose of raising it, the health funding should move from philanthropic mode to the right mode. When a person bridges, constructs a bridge and all that, many other things in civil works are being done. They don't compromise. Why do we compromise on only health, on manpower, or budgeting for drugs, or for the hospitals? It is a basic right of our individual. So whatever is required, this much number of doctors are required for so many number of people. It should be there. There should be no compromise. There shall be no compromise about engaging them in a substandard way of contractual laborers, contractual workers, contractual doctors. These are all looking the entire health system as in a philanthropic mode. Or
volunteerism, as though volunteerism
Yeah.
can answer, but volunteerism has a part to play, but it cannot substitute for, as he says,
Because
paying for.
Your constitution clearly says your health is your right, your basic right. Education is your right. When it is your right, you have to claim health facilities as a right, not as a philanthropic mode,
To
not
add-
as a beggary.
To add to what Dr. Guhanandam says, a good way to start the morning. We are claiming public health as our right. We should not, when we pay peanuts, you will get we will get only you know what. So I think my request was not on trivialities. It was on the fact that there is need for relook at the Public Health Code and Act in order to make this our right. That is, I am not going to the level of the Right to Health Act, which is the next level. I am still talking about the fact that in spite of COVID, we have only done cosmetic improvements to our own act. And I make a request, I hope, anyone else in the audience with a question? Yes. Dr. Madhivanan, Sonnonna, you can. Yes, Dr. Madhivanan.
The National Public Health Act during 2070 speaks about national and state level public health cadres. It is sent to all states, but majority of the states are yet to answer.
No, I'll respond to that. I know more about that. The fact is, one is there is also this controversy of should it be a national act or should the states have the right to have their own act? Lot of issues, concurrent subject vis-a-vis state subject. Adunaliye nariya per opinion, no, many people did not send their opinion or sent opinions saying we are okay. But that's a big issue. Someday we want to discuss national and I think we'll have to do it in a different forum. Can you go ahead with your question?
Thank you. I appreciate Sunil sir's comment on public health education. Now, masters in public health are everywhere in country, but there is no regulation. I would like to request DPH to start a school of public health and start a courses on public health. Not only master of public health, we need more people on managements. MBA in healthcare system management, healthcare finance management, healthcare accounts management, public health system HR management. There are so many lakhs. Because I have worked in different places like Bihar and other places, I have seen there is no public health cadre there, and there is no manpower. Most of them are from
Your point is one taken. You want government to start it, but I think Sunil's point was to regulate the institutions that are now offering such courses, because unregulated people are paying money, especially in online learning, sometimes to get very substandard material. I think there are opportunities here at the national level also to look at what should be a minimum. But your point is that more people are required. More people need to understand what is public health, what is public health management, and what is public health law. But we need quality courses and quality institutions to do the same.
And we have to move beyond MPH, not only master public health. We should go to some more HR.
No, we need to do lots of work. But who will do this? Who will be the teachers for this? It will be in this audience only.
Actually, health epidemic intelligence studies course is started by National Institute of Communicable Diseases, which is equal to that of CDC Atlanta's EAS course. There are courses are ready, lots of there, and only our 4 states are really keeping up these public health standards: Tamil Nadu, Calcutta, West Bengal, Maharashtra, and all of the states are really backward, and they are picking up very.
Point is well taken. I think we can.
I sincerely thank the chair and the panel members for the enlightening discussion. and reinforcing on the importance of public health and propagating the uniqueness of Tamil Nadu public health cadre in this huge gathering of public health experts and pillars of public health system. And also for their valuable suggestions on the financing, bringing changes and regulations in the Public Health Act, and also the need for training on legal aspects of public health officials. Thank you, ma'am. And now I request our director, sir, to hand over memento to ma'am as a gratitude of, as a appreciation. I request our OSD sir to come on stage to hand over the memento to all the panel members. Thank you, sir. And I wish we should have a separate conference on Public Health Act and cadre with the same chair and panel members. Thank you. Thank you, sir. Okay, now we'll take a short break. Please help yourselves with the coffee and tea, which is being served in the new lawn, which is in the extreme left of the portico. And the next, thank you, sir. The next session will promptly start at 12 noon. I request all the participants to be seated by 12 noon. Thank you.
This. This. Chi. This. Chi. 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 Hello. Chi. This. Chi. This. Chi. Chi. Hello. Hello. This. Check. Hello. This. Check. Hello. This. Hello. Check. Hello. This. Hello. Check. Hello. This. Check. Hello. This. Chi. This. Hello. Check. Hello. 1, 2, 3. Check. This. Check. Hello. This. Check. Chi.
வச்சுறாங்க இங்கே தான் இருந்துச்சு ஆ பார்த்தீங்களா என்னது
Check, check. Hello, test. 1, 2, 3, check. Check, check. Check, check.
மைக் ஆன்ல வச்சிருந்தா வராது அதான் பண்ணுறேன்
Check, check, test, check, check. Hello, test, check, 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 check.
Hello, hello. Hello, test. Hello, test. Hello, test. Hello, test. Hello. Hello, test. Hello, test. check, check, test, check.
அது ஆன் பண்ணு போடு. நீங்க தானே ஆன் பண்ணு.
Check, 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 test. Check, test. Check, test. Check, test. Check, test. Check, test. Hello, check. Check, test. Check.
A small announcement for regarding quiz competition. We request your kind attention.
We have quiz competition arranged for 4 different categories: postgraduates bar undergraduates, medical officers, BHN staff nurse 1 category, BHS and HI 1 category. Those who are interested, please register outside. We have a separate registration desk for quiz. We'll have the prelims in the afternoon. For postgraduates or undergraduates, we'll have the prelims at 2 o'clock. For medical officers at 3 o'clock. And BHS, HI, staff nurse and VHN at 3:30. Kindly register in the registration desk outside. Thank you.
Dr. Sudarshini. Dr. Sudarshini, please come to the dais. May I request all the participants to just call your friends for we need to start the session and we are going late. A kind request to all the participants to request your friends to assemble back to the session, please.
Sir?
Check, check. Check, this. Check, this.
I request all the delegates to please settle down. Those who are doing poster presentation, there is an announcement for you. Poster presentation will happen in the Port Hall venue, Portico. And please contact the help desk. Each poster will be allotted a number. Participants are requested to be ready by 2:30 p.m. at their panel for the presentation. Judges will visit for evaluation. And all the delegates are requested to view the posters which are on display in the afternoon. So I request all the delegates to please be seated, sir. So welcome you all back. The next session is a panel discussion on climate change and human health, an unfinished agenda. Please join me to welcome Mr. Deepak Srivastava, IFS, sir, to chair and moderate this session. So, welcome, sir. Sir belongs to the 1992 batch of Indian Forest Service of Tamil Nadu cadre, and he joined the Indian Forest Service in 1993, and he had been worked as Director, Ministry of Social Justice and Empowerment, Government of India from 2004 to 2008, and as a Project Director, Hill Area Development Program, Ooty Planning Development Department, Government of Tamil Nadu, from February to August 2011. And he had been Chief Vigilance Officer, Mahanadi Coalfields Limited, Sambalpur, Odisha, under the Ministry of Coal, Government of India from 2011 to 2016. And as a Dean, Forest College and Research Institute, Mettupalayam, Tamil Nadu Agricultural University under Ministry of Agriculture and Farmers Welfare from 2017 to 2018, Government of Tamil Nadu. and Special Secretary in the Department of Environment and Forest, Government of Tamil Nadu from 2019 to 2020. He has also represented the Government of Tamil Nadu in COP25 and the recent COP27. And now Sir is currently serving as Additional Principal Chief Conservator of Forest and Member Secretary, Tamil Nadu State Wetland Authority, and Additional Principal Chief Conservator of Forest and Mission Director, Green Tamil Nadu Mission. We welcome you, sir. I request the chair to introduce the panel members. So over to you, sir. Sir, can you-
A very good morning to all of you. So, this is all regarding the public health and climate change issues. So, I would like to invite our esteemed panel members. The first is Dr. Marion Jan Cross, is a senior health specialist with the World Bank. And I welcome you on board. Yeah, and Dr. Marion has got a very wide experience in the, you can say, the area of air pollution and climate change agenda. And she's providing the technical support to the technical working group on air pollution and climate change, which is very intricately linked. And she is also, has got immense experience in the field of climate change and air pollution. So I welcome you again. Thank you for being with us in the panel. The next panel member is Dr. Chitra Grace. She is an associate professor, Global Institute of Public Health, Trivandrum. I welcome you on the stage. And she has a, you can say, the dual masters in environmental science and public health, which is, I think, which is very, very helpful for today's panel discussion. And she has also contributed immensely as a consultant to the Ministry of Environment, Forest and Climate Change on management of hazardous substances for Indian Institute of Technology, Chennai, which is posing a serious health risk. And it is a, you can say, a very great risks to the public health in toto. Next panel member, Professor Kalpana Balakrishnan. She is Dean Research and Director, Sri Ramachandran Institute of Higher Education and Research, Porur, Chennai. I welcome you on board. Dr. Kalpana Balakrishnan has obtained her undergraduate degree from All India Institute of Medical Sciences, New Delhi, and subsequently her doctoral and postdoctoral training at the Johns Hopkins University, USA. I think more than that, I should not be commenting much on your profile because this speaks a volume on your expertise in the field of environmental health. Next panel member is Dr. Purnima Prabhakaran, Director of the Center for Environmental Health, Public Health Foundation of India. I welcome you as a member of the panel. And she has you can say, the honor of heading activities at the Center of Excellency for Public Health Foundation of India for green and climate resilient healthcare facilities. Because normally we climate resilient agriculture, climate resilient forest and trees we come across, but climate resilient healthcare facilities is the need of the hour. So it's, I welcome, and you are also working on the, to make advancement in transition to the climate smart healthcare system also. So I welcome you on the board. The next panel is Dr. Rameshwaram Sorokhaibam, Deputy Director, National Program on Climate Change and Human Health, National Center for Disease Control, Delhi. And I welcome you on the board, and you are working, your keen interest of work is in the process of developing a mechanism to address the climate health concerns of the climate change, which is a very, you can say that, way forward for addressing the climate change concerns, health concerns arising out of the climate change. And last but not the least is Dr. K.C. Seran, Additional Director, NHM, Directorate of Public Health and Preventive Medicine. I welcome you on the board. Dr. K.C. Saran is a MBBS graduate of 1984 batch from Tanjavur Medical College, and now presently he has worked in Community Medicine Department, Commissioner Food Safety. So I welcome you all on the board. Slightly I am finding me out of place here because all are doctors and all are having very, you can say that, great profile. Only commonality between you and me is my son is pursuing doctor. He's a PG, he's pursuing his PG. So therefore I am finding some kind of similarity. Otherwise I am totally out of the context in the terms of profile. But however, the topic is very valid and topic is very relevant to my, you can say, the area of work. And I hope that this you will enjoy, the audience will enjoy, the August gathering will enjoy the panel discussion. We can start now. So, we will... So first of all, I would like to just, because it's a climate change and human health, it's a very, very, you can say, such an agenda which I still feel it's occupying a back seat when we talk of the climate agenda in the, I have attended two COPs, COP 25 and COP 27, but somehow I candidly admit that yes, the health agenda was slightly on a backside, though the climate change risks are directly, you can say, affecting the health situation of, health condition of the country and a globe as a whole. So, I would like to make you aware that though the health agenda may be having a kind of, I will not say extreme backseat, but yes, of course, it is not in the mainstream, but still in government of Tamil Nadu, it is being given very high priority as far as our overall climate goals are concerned. I would like to highlight on the first that the risk analysis which has been done by the United Nations Framework Convention on Climate Change, in that risk assessment, the three risks are directly related to health. One is risks to health and ill health and death due to extreme climate weather events. And then there is a risk to mortality, morbidity due to extreme weather events, intense precipitation, heat effects which is rising due to the global warming because of the use of the fossil fuels, and then risks to the systemic risks to the infrastructure, and you can say the adverse impact on the critical health systems and critical care systems and critical infrastructures, which is also getting directly impacted by the climate change. Now, you all know that nationally determined contributions which India has submitted is updated version in the before the UNFCCC also mentions critical three areas which are specifically related to, indirectly or directly related to health aspects. One is that we promote, means we as a citizen, we have to promote sustainable and healthy way of lifestyle. This is a mantra given by our Honorable Prime Minister of India, that lifestyle for health. So this is very important that we live in moderation and reduce the risk of the, you can say, impact of the climate change on the health. And then we make investments in you can say the sectors which are vulnerable to the climate change. In the sectors which are vulnerable to the climate change is agriculture, it's a water resources department, it's a health, and it's a disaster management. So health, we are taking care of in improving the investments, and one of the most vital thing is that you can say that mobilize the investments, because when you are going to meet the climate agenda, fulfill the climate goals, you need investments from the domestic agencies, international agencies. For that, you should have some kind of institutional mechanism at your level so that you can rope in the investments. So government of Tamil Nadu is the only government in the entire country, state government in the entire country, which has, you can say, that brought a very beautiful mechanism by making a Section 8 company, that is Tamil Nadu Green Climate Company, under Section 8 of the Companies Act 2013, which can mobilize funds, because in government sector, when you mobilize the funds from international agencies and domestic funding or donations, there is a long drawn procedure for that, and generally the funds do not come so easily. And you have to pursue, if you want to pursue your climate goals, climate agenda, then definitely a funding mechanism has to be very robust. And this is the first government I am very proud to be a part of that Tamil Nadu Green Climate Company has given as mandate by the government of Tamil Nadu to mobilize funds and to prepare a climate change mitigation and adaptation plan, because you know that these days the climate finance is becoming a very, very tight issue. It's being thought, it was discussed at length at the COP27, but still we could not materialize with the climate finance. So we have come to the loss and damage funds, and loss and damage funds has taken a, you can say, it has deviated from the, you can say, overall climate financing agenda, which the developed countries are not willing to still fulfill their commitments. So therefore, Tamil Nadu Green Climate Company has got 3 missions under it. There are 3 very crucial missions under this. One is Tamil Nadu Climate Change Mission. And Tamil Nadu Climate Change Mission already State Action Plan of Climate Change 2.0 has been finalized, which has an inbuilt, you can say, the mechanism for addressing so many health concerns of the climate change. Second thing is Green Tamil Nadu Mission. Now you will think that when I talk of Green Tamil Nadu Mission, mind always runs towards forest and trees, only greening. It is not about the greening. It is not only about the greening. It is about decreasing the impact of the urban heat island effect. And heat island effect is one of the killing factors. It is causing widespread damage to the health system of the country. Now, there are certain trees we have listed down under the Green Tamil Nadu Mission, that there are some 50 trees which takes care of air pollution. Air pollution at the global level, it kills 70 lakh people annually. 70 lakh. Out of that, 17 lakh population it kills in India, and 1.7 lakh people it kills in Tamil Nadu per year. So air pollution is a big killer, and there are experts on board. So we have identified 50 trees which can take care of carbon sequestration, that it can suck carbon directly from the atmosphere and sequester in that biomass, and it can reduce the urban heat island effect. And then third most important is that there are air pollution tolerance index capacity of those trees are very high. So we are taking care of, through trees, we are taking care of air pollution, land and air surface temperature, and we are taking care of carbon sequestration because global warming. And then there is a third mission which is called Tamil Nadu Wetlands Mission. Now wetlands are very ubiquitous ecosystem, productive ecosystem. Many people are dependent on the wetlands. Much of the livelihood is focused on the wetlands. Tamil Nadu government has embarked on a mission to restore 100 wetlands in a period of 5 years. Now you will see that how wetlands are, you will be concerned to know that how the wetlands are directly related to health crisis. Yes, it is related to the health crisis because the deteriorating water quality, because of mixing of sewerage, household waste, industrial effluents into the water bodies, and that is going to the fish, which is the most, you can say, the favored food for the coastal communities. Tamil Nadu is a coastal state with a geographical area of 130,000 square kilometers. Out of that, 1,076 square kilometers is a coastal line. So therefore, the fishing communities are you say that livelihood of the fishing communities get directly impacted because of the contamination of the fish which goes to the food chain. So mean to say is that climate change is leading to increased temperature, unpredicted weather, you can say that events like intense drought, intense flood, and you can say that intense precipitation, leading to lot of diseases which are coming out of this. So therefore, direct or indirect impact of climate change is becoming evidently clear in day-to-day health needs of the society. So therefore, I will request today's panel, I will be moderating in between, but I will request today's panel to enlighten all the audience on the, you can say the intricate linkage which we are having between the climate change and the human health. So I would request Dr. Marion Jan Cross, Senior Health Specialist, World Bank, to initiate the discussion. And I welcome you on this. You are as you are comfortable. And we have got, you should have reminded me also, I have crossed my time because 5 minutes for each.
Sure.
Kindly stick, I have eaten much of your time, so kindly stick to the
Sure.
time schedule. Thank you so much.
Thank you so much. I think actually you cover already a lot of topics that we are going to touch upon. So we are very grateful for such a great introduction. So good morning, everyone. I hope you feel not too tired. You had your cup of coffee. So what I wanted to try to discuss here in 5-6 minutes is more to highlight actually the global knowledge, about the effect of climate change and air pollution on health system and, and human health. And then take a step back and think about how to frame, climate change and air pollution as a public health issue. Because I think we all know that clearly we have been talking a lot about the sources of air pollution, climate change, and the Ministry of Environment and different sectors like agriculture, energy have already done a lot. But perhaps to take a step further, to be perhaps faster in the implementation of such policy, it's good to kind of link, the source of air pollution, with the effect on human health. So, just to talk a little bit about that. So, actually, I'm not going to go through all the slides, but very briefly, next, actually, I think I don't have I think it's here. Sure. Okay. Oops, it's not working. Okay, never mind. I think I'll do just my talking points. Okay, so in terms of the global evidence on climate change, so I think I would say there are really like 4, I would say, indirect effects of climate change on human health. So first of all, there is a rising level of temperature. What does it need for us human beings? It means there is a higher risk of having, cardiovascular disease, cardiovascular failure. And actually, recently there was a Lancet publication on public health and on climate change, which shows actually that, the population above 65 years old, there has been an increased heat-related mortality by 70% for people above 65. So this is really, this is really happening. Climate change is leading to more cardiovascular failure and to more death. That's one thing. Number 2, what we see is that as well, climate change leads actually to, a change in vector environment. So that, what does that mean? That means that there are more outbreaks related to, dengue, malaria, chikungunya, Zika, you name it. And so this really is then, leading to more DALI and to more death. Number 3, climate change as well is leading to rising level of sea. What does that mean? It means actually that then there is a more water-related disease, so more cases of diarrhea, more cases of cholera. And number 4, climate change, interestingly, has an interesting relationship, I would say, with air pollution. So air pollution is contributing, to increasing the emission of CO2, and so, leading to more NCDs, but as well climate change, because of the extreme weather patterns, fire, etc., is leading as well to, the increase of PM 2.5 level. So, and all of this has actually a tremendous negative effect on health. So how do we measure air pollution? So air pollution is usually measured by the concentration of these, particle matters which have a diameter of 2.5. And WHO actually says that, as a standard, countries should have a concentration of 5 micrograms per cubic meter. 5. Oh, okay. Okay, very good. Oh, great. Okay. So that's where I am, on air pollution. And so, yeah, and so basically, the concentration of PM 2.5, so WHO, you know, suggests to have like 5 micrograms per cubic meters. And you know, today actually I was, you know, looking at my phone, and today here in Tamil Nadu, where we are, it's 60. So you can see we are way behind in some countries, in particularly, you know, I can show you the chart here. In South Asia, actually, air pollution is, you know, one of the worst than any other part of the region, right? And so why is this important? It's important because actually air pollution is the 4th risk factor to death. This is huge. This is actually leading to about 7 million deaths. 20% of these deaths are actually happening here in India. So this is important to have in mind. And then as well, I think what is even more worrisome is that, you know, you can say, okay, air pollution is leading to NCD, to respiratory disease, cardiovascular disease. It's only affecting the old people. Not at all. It's actually present along the entire life cycle. So it can start in utero, you know, there can be like pregnant women losing the baby because of an association with air pollution. 20% of neonatal deaths worldwide are attributed to air pollution. So this is real, this is really happening. And then, of course, as well, there have been many studies looking, you know, association between, you know, stunting and air pollution. So again, just to raise some figures so that, you know, you can see how it's important to frame it as a public health issue, because this is clearly an issue. And the last figures, 40% actually of the chronic obstructive pulmonary disease, you know, death are actually attributed to air pollution. So again, this is really real, and so climate change is leading to air pollution, which is leading to these huge catastrophic health problems, which have a huge cost. Again, if you just take in India, air pollution is costing, I think, $36 billion, and this is actually cutting 1.3% of the GDP. Remember, health is actually representing 1.3% of the GDP. But air pollution is actually cutting 1.3% of the GDP, reducing so the economic, so the potential of a country to develop itself. So this is huge for health, and this is huge for the economy. Now I think it's important to reframe this issue as a public health, and perhaps, you know, I think now it's, so there is the WHO target, the 30 micrograms per cubic meters. And if this was actually, you know, like reached by countries, in particular in the Indo-Gangetic region, where actually there is the highest level of air pollution, then there will be a total number of deaths avoided by almost 800, you know, thousand. So this is huge again. So this is really important to have these figures to see to which extent all this, you know, abatement policy, which can actually decrease the source of air pollution, can actually lead to save more lives. So really to translate air pollution as a public health issue. And I will just finish with that last slide. And actually don't look at it, but that was my last slide. I think there are 2 points I really want to make, so that it can be framed as a public health issue. As of now, if you take the South Asian region, there is a very limited routine data of the effect of air pollution, climate change on human health. And so if you have no data, there is no public policy problem. So how can it become actually a public health issue priority? How can health authorities address it if there is no, you know, routine data? So I think it's very important that all of us, you know, we try in some ways to support the health system to make sure that there is hospitalization data broken down by pathology, you know, that there are air pollution-related disease, hospitalization data, and that this gets correlated, you know, with the AQI, the PM 2.5, so that, you know, health providers themselves, hospitals themselves, can really monitor on a routine, on a daily basis, the effect of air pollution on human health. there are many studies, cohort studies, etc., but this needs really, there need to be more air pollution and climate change related data indicator in the HMIS system so that it really becomes a public health issue and that it can be addressed. The last point, I think it's the financing. Again, if you take the region, South Asia region, the share of government spending on health is low. Overall, it's 7% in the region. It's beyond the global region, which is actually at 11%. In India, it's 4-5%? So this is very low. So as long as public health is not a priority of the government, even if there is a great vision with several programs, there needs to be more resources put behind. And then this money can be actually used to have a public health response to address air pollution. Let me stop here.
Request the delegates to be quiet and don't distract others on the speakers, please.
I think that is a very important commandment. Yeah. So thank you very much, Dr. Marion. One last line, I also remember that you wrote that if you want to speak with confidence, something like that, you speak in numbers. So PM 2.5, what Dr. Marion has spoken, I will just add to the numbers to show you that, to make you realize that how critical is PM 2.5 from the point of view of climate change. Because in India alone, if I am wrong, if anybody can correct me, I will be very happy. 9 lakh deaths annually is taking place because of PM 2.5. That is human-made PM 2.5. And then there is a fossil fuel-based 2.5. That is coal-based PM 2.5. 17% of the 9 lakh is attributed to that. So PM 2.5 is a very, you can say that silent killer, which we are not able to even take now cognizance, but now henceforth we have to be very, careful in spreading awareness that why we should reduce this PM 2.5 in particular. So next, I would like to move on to Dr. Chitra Grace, Associate Professor, Global Institute of Public Health, Trivandrum. Kindly proceed with your talk or presentation.
So, good morning, everybody. First, I would like to congratulate the Department of Public Health for completing 100 years on public health, which is a wonderful achievement. And thank you for inviting me to talk on something unfinished. So, I'm here to talk about climate change and health and an unfinished agenda. So usually we would like something finished, like 100 years finished. But I'm going to talk about something which is unfinished, right? So next slide. So I would like to quickly touch upon what is climate change? So we have all heard about climate change. It's basically a phenomenon which has been there for centuries. And the worry that we have is we are now contributing more than nature. So it's mostly anthropogenic or man-made, right? So the unabated burning of fossil fuels and other factors actually contribute to rising temperatures. And once the carbon dioxide or the greenhouse gases like methane, carbon dioxide, oxides of sulfur, black carbon, they increase, there are definite global climatic change effects. So if you can see, the global surface temperature in the last decade has been the warmest on record. And this has actually led to extreme weather events. And we cannot forget the Chennai floods of 2015 or the Kerala floods from where I am from of 2018. And we lost many lives in those events. So it's not, it's something that we can very relate to easily. our monsoon systems, they don't follow the pattern. And when the monsoons hit, it turns into very extreme weather events. You know, there are floods, there are cyclones, the frequency of cyclones is on. However, on the counter side, there is a decrease in water availability. So, if you look at the maps, you can see that there are water deficient areas all over. And there are increased drought happening. Why? Because the freshwater availability is becoming low in many parts. And all this is due to global climate change. So it leads to, once the global climate change happens and the temperature increases, we know that a lot of ice is being held up in the poles. They start to melt. We have heard about it, but we are going to feel it in the coming next maybe 5 decades. So our coastal line, India has a long coastal line, and all of this is in fear of inundation, and all the populations, coastal population, they are vulnerable people. They are the ones who are going to bear the brunt of sea level rise. Another one is loss in biodiversity. If you can think about, I'm just trying to pull together many events that are happening in the environmental arena, where we talk about biodiversity loss at an unprecedented rate. Human beings, we are aiding in deforestation, desertification, land degradation. All of this is adding to loss of biodiversity, which leads to poverty and displacement and food security. All these factors are actually linked to health risk. So it finally ends up affecting all of us. It affects us as individuals, it affects us as health system, being part of health systems, right? So WHO in 2021 actually said climate change is the single biggest health threat facing humanity. While no one is safe from health impacts of climate change, they are disproportionately felt by the most vulnerable and the disadvantaged. And this leads to health inequities, right? So if you look at the picture, you can see many causes, right? And all of this leads to global warming. It has effects on the environment. It not just affects us, it causes ecosystem collapses all around. And there is a feedback loop, which again feeds into the causes. And later it will have effect on our human health, right? So, I just want to quickly add one more contributor which we are not addressed in a very long time, which is plastic pollution. So if you think, we don't usually bring plastic and maybe climate change together, but the production, consumption, disposal, the end of life of plastics are all based on fossil fuels. And a lot of energy, fossil fuel, is spent on all of this. Therefore, we need to reduce our dependence on plastic also. And when this plastic breaks down, you would be aware of microplastics in our food, in our water, even in our blood. Studies from India also show that we have microplastics in our blood. So all of this is linked to fossil fuel use. So we need to put a curb on that also. So coming to the health effects of health effects of climate change, it is linked to malnutrition because it is linked to food insecurity. It is linked to respiratory diseases, cardiovascular diseases, mental health, all because it is linked to air pollution, right? We have eminent speakers coming after me who's going to talk more about it. So all of this is linking greenhouse gas emissions, the change in climate, and health. So when we talk about vulnerable populations, we have to keep in mind the very young, the very old, and the vulnerable populations like the pregnant, women, the disabled, the people who have other comorbidities. They are at risk or at vulnerable to the climate risk. In this context, I want to make sure that there is a larger environmental change going on, of which climate change is one part. So we have the problem of stratospheric ozone depletion, land degradation, freshwater non-availability, and a lot of other systems. Ecosystem functions are decreasing. All of this affects health. So we have to have a larger picture. In the event of this, the nations have come together and added climate action as part of the Sustainable Development Goals, which is targeted at 2030. But according to NITI Aayog, our score is quite low in climate action. So it is around, we have a score of 54 and has a long way to achieve the target of 100 by 2030. So we need to step up our game. And I would like to say that, we need to reframe climate change not as an environmental problem, but as a public health crisis. So we have heard already that, disproportionately it affects the vulnerable population. And so all of this is ongoing. So we have certain tipping points set up, which if we don't control, we will be ending up in trouble. So I just want to say that we need to change the way we understand climate change. We need to stop thinking from a point of view of ORs and RRs and think more from a population level and at a global scale, how it is affecting us. So we need also, just a last point I just want to put, we need to think about health in all policies and health for all policies. So if if the health determines non-health sector factors like water and sanitation, transport, if they are developing a policy, we need to consider health. And just like that, when we are developing a health policy, we need to consider the other sectors too, so that we have a comprehensive model. So it is threatening our health, and it is the window of opportunity for stepping in is closing very rapidly, and we need to make a change. Thank you.
Thank you, Dr. Chitra Grace, for enlightening us. Go green, eat healthy, or what you have written in the last slide, eat healthy. Problem is that one more effect of climate change is that fast yielding crops, when to combat the heat and drought stress, is losing the nutritional value also due to the climate change. When it loses the nutritional value, then malnutrition becomes very evidently clear as a very important impact of the climate change. And one more thing which was mentioned here was vector-borne diseases. Now you see the dengue. Dengue, which was in 2002, 2003, as per my observation, was 2 to 3 months it was restricted. Now it has moved to 5 to 6 months. So these are all the impacts of climate change which we are facing on the health. Now the next panel speaker, I would like to invite Professor Kalpana Balakrishnan, Dean Research and Director, Sri Ramachandran Institute for Higher Education and Research, Porur, Chennai. Please.
With permission from the chair, I request all the participants to keep silent because we try to pull all the expert panel members over here for this conference. We want to rightly use this opportunity, and we request all you keep silent and listen to the delegations. Thank you.
Very good morning, Director of Public Health and Most Honorable Chair. And I'm really happy to accept this invitation. It is very, very unusual, not only for a Directorate of Public Health to observe 100 years, but even more unusual, and I think can only happen in our own state of Tamil Nadu, wherein all the risk factors, without any bias for where those risk factors stand, truly come together, and environmental risk factors in this particular session, which are at the heart of most of the burden of disease, have been accorded so much priority, and assembling such a distinguished panel of speakers alongside. So this is truly a privilege to sort of take. So this session, this morning we heard quite a bit about public health actions to combat the disease burden, and in this particular session, public health actions to combat climate change. I wish to draw all of your attention to just one action. Of course, there are so many actions that are possible, and provide the justification. I think this morning we talked about how we are going to really get the evidence for actions. And I want to make a case for Tamil Nadu in the honorable presence of our Director of Public Health, if Tamil Nadu can be this champion of transitioning 100% to clean household energy. If there was one state in India that is possible, it is in Tamil Nadu, because already we have transitioned quite a bit. And I say this because it is the lowest hanging fruit for realizing both health and climate benefits for the entire country. But it is not possible to do so across all states. And let me provide the justification for why we should be moving towards this. Household air pollution resulting from the use of cooked fuels such as biomass or dung or agricultural residues in traditional cook stoves. I think this picture tells it all. Is a leading risk factor. I think Mariam, buried in her graphs was not only the burden of air pollution associated diseases high, more than 50% of the burden is not from the vehicles or the power plants, is from this, what we think is an innocuous source buried in our homes, but it is certainly by no means innocuous. And they are labeled, as you can see, all the pollutants you wanted to look at, whether it is health or climate, whether it is black carbon or particulate matter, are just getting liberated from this everyday source of household energy. And we label them as, as unhealthy, mainly because they generate products of incomplete combustion. All products of incomplete combustion are bad for health, and the best example of a product of incompletion that we know is smoking. And if it is PICS, whether it is from smoking or whether it's from diesel exhaust or power plant emissions or wood smoke, they are all equally bad for health. But what is important to recognize is some of the PICS associated with air pollution are not just bad for health, but for climate too. And contrary to popular belief that no one really uses these household fuels. If you ask an average person, especially the youngsters sitting in the back of the room, where is are these household fuels even used? Most of them would not have seen it. But it is a reality on a nationwide basis that nearly 50% of India's population, or approximately 70 crores, still has to rely on these dirty sources of household energy. While health damaging exposures from urban sources is widely appreciated. Every Directorate of Public Health, I'm sure, will recognize that vehicles are bad, power plants are bad, diesel gensets are bad. But if you ask them off the top of their head, do household sources come to their mind? Perhaps not. So this is a very poorly understood risk factor even within the public health and regulatory communities. And given that PICS are the common enemy for cigarette smoke and smoke from all air pollution sources, it should not be surprising that with virtually every disease endpoint that we knew to be associated with cigarette smoking is now known to be associated with air pollution, specifically with both ambient air pollution and household air pollution. So household air pollution, as natural as it may seem, wood smoke as natural as it may seem, traditional practices as old as they may seem, produces the same risks that smoking does at the population level, perhaps greater. At the individual level, obviously the risks from smoking are greater, and therefore this perception of individual risk for the clinician is not going to be very, very easy to do. It can only happen at the level of public health communities. More importantly, so in fact, the WHO now declares air pollution to be the new tobacco. And it is also important to recognize that air pollution and climate, as Miriam was mentioning, to be treated as two sides of the same coin. And I just wanted to also allude to Chair's earlier comment. When we sort of looking at greening the environment through afforestation mechanism, and we wanted to really look at carbon sequestration, you have to recognize is that when we use wood fuel, it can impact climate in two ways. None of the fuels that we harvest is replenished fully. So we cannot put back all the carbon dioxide, we cannot completely sequester all the carbon dioxide if we decide to cut the wood for our fuel use. But more importantly, because some of the carbon dioxide will definitely be left over, but on the other hand, when wood fuel is actually burned, you not only leave out the carbon dioxide that you fail to sequester, you also generate products of incomplete combustion, and both of them together end up really looking at net climate forcing. So there are two parts to climate impacts, both products of incomplete combustion and carbon dioxide. Most importantly, if we look at acting on climate through afforestation alone, you are not, so basically if you are not going to be able to address the burning part of it. So therefore, we not only have to green the environment through afforestation, we have to look on the demand side of intervention by transitioning away from burning the biomass fuel into cleaner sources of energy, such as LPG and such as electricity. So I want to leave you with this thought. So what would happen if 70 crores of people in India currently who are relying on biomass were to move to gas or electricity within the next 30 years? We now know that mitigating household sources is the lowest hanging fruit for achieving the national ambient air quality standard throughout the country. Transitioning to LPG would reduce the ambient PM 2.5 concentrations by 25%, would result in a 29% reduction in the loss of healthy life, preventing nearly 348,000 premature mortalities every year, and full transitions would result in 17 to 47% lower carbon dioxide emissions with greater reductions, increase with shifts from LPG to electricity. And these are all studies that have been done in India by several Indian colleagues. And I think what we have now here is an opportunity to strengthen synergies in the current policy landscape. We all recognize that if we want to intervene on health, if we are going to intervene with air pollution interventions, it is hardly going to impact health in isolation. Multidimensional poverty, as the World Bank defines it, is a reality, and we have the ability to look at intersectoral cooperation facilitated by the Ministry of Petroleum and Natural Gas, Ministry of Health and Family Welfare, Food and Nutrition Board, Ministry of Environment, and Ministry of Women and Child and Development. If we have to phase out household air pollution and phase out reliance on household fuel sources, it is not going to be done by the Ministry of Health. We are going to need cooperation from all these ministries, and it is going to be done specifically with lead roles for Ministry of Environment, Forest and Climate Change, not just for household air pollution, but for all air pollution. And it is not going to be sufficient if the Ministry of Environment acted in isolation. We are going to have the Ministry of Health and Family Welfare and every other ministry that is associated with it go hand in hand. I thank you for your kind indulgence. It is not possible to certainly share the entire perspective, but I hope these visuals just provided enough ammunition for you to go up and look up this literature, especially for the youngsters, all of which is available in the public domain with the actual numbers that can actually inform policy. And these discussions are already happening both at the central level and at the state level. Thank you again very much, Director of Public Health, as well as the Chair for this wonderful opportunity.
Thank you, Professor Kalpana Balakrishnan. Very important point Professor has highlighted. Just I would like to add one point, very important, that she talked very nicely about indoor pollution. Indoor pollution, as per the WHO, in the developing countries is killing 3 to 4 million prematurely. And this is a very, you can say that, problem which can be only solved by putting to use clean wood stoves, clean stoves, clean energy stoves, which will convert biomass into heat without causing the indoor pollution. So this is also a hazardous health effect of the climate change where the lot of deforestation takes place because of, you can say, dependence on the fuel wood and then causing the health pollution and deforestation due to forest fires because of increased temperature. So these are all the issues which are being highlighted are too good from the point of view of to understand climate change and health issues. The next speaker, panel speaker, I would like to invite Dr. Purnima Prabhakaran, Director of the Center for Environment Health, Public Health Foundation of India. Please.
Thank you, Chair. I don't have slides, but as a public health person, it has been said that sitting or sedentariness is a risk factor as well. So I'll use my opportunity to walk up and stand over here for 5 minutes. At the outset, greetings everyone, and I want to add my congratulations to Tamil Nadu's Department of Public Health on celebrating your centenary celebrations. So I think the previous panelists have talked a lot about air pollution, ambient, as well as household air pollution. Professor Balakrishnan has talked a lot about the interventions that we can do over there. So let me zone in now on the issue that we are talking about in this panel on climate change itself. This is an existential threat. We talk about climate change today as the biggest public health challenge of the 21st century. But we also are saying now that it is the biggest public health opportunity of the 21st century. And why are we saying this? Unlike the global COVID-19 pandemic that really caught us unawares in a very short span of time and literally brought the world to its knees, the climate crisis is something that has been climbing on us very steadily. Increasingly, we are seeing more and more diseases like malaria, dengue, chikungunya, Japanese encephalitis in parts of our country where it was not seen before. And this is because the climatic conditions are becoming more and more favorable for these vectors to transmit these diseases. And let's not forget waterborne illnesses. Somehow we talk a lot about air pollution, we forget the waterborne diseases. There's a lot of things that happen post-floods, post-cyclones. We have stormwater overflow, and that results in a lot of waterborne illnesses that we don't pay attention to. And another most important thing that we definitely forget is the post-traumatic stress disorders, mental health issues. There's a whole concept of climate anxiety or eco-anxiety that is leaving not just us, but our children, the younger people in our populations worried about the future. So mental health impacts of climate change is something that we should not forget about. But I just want to shift track a little bit to what the chair started us on in the discussion today on this panel about the climate conferences. So for nearly 3 decades now, the annual climate conference or the conference of parties has been happening, and this was meant to take stock of this climate change situation. Countries, 198 member states are going to these conferences and talking about what is happening, taking stock, taking decisions about what they will do to address the climate change agenda. And sorry to say, sir, I'm happy to hear that you were at COP27 and so was I, but over the years, it is only delegations from the Ministry of Environment that are going to these COP conferences. How is health even going to be in this decision making? We need health at the center of all the climate policies. And even this time, we did have an India pavilion. I was there were multiple events that were going on, but not a single health voice. So if we are talking about climate change being an issue that is spanning across sectors, energy, transport, agriculture, food systems, where is the health in the center of all these policies? If we do not have the health lens in all this policy making, we are not going to move ahead in this agenda. So it's important for us to have this intersectoral lens. And today, as I stand here in Tamil Nadu and congratulating you on being a leader and a front runner in having a Department of Public Health so long ago, my entreatment now to you, sir, is become a front runner once again while the nation and the central government is doing what they are doing to address the climate change crisis. I think in Tamil Nadu, you can be a front runner by establishing an interministerial task force, headed by none other than the Chief Minister, to have these different ministries talk to each other. The Ministry of Environment, Energy, Women and Child Development, Transport, Agriculture, Food Systems, because all of these domains and sectors are contributing to the greenhouse gas emissions. And it's important for these sectors to talk to each other. Coming to the role of the health sector in climate change, what are we doing as health practitioners? What is our role in climate change? When we take the Hippocratic Oath when we graduate from medical schools, it says, do no harm. But how many of us in this room know now that the health sector is also contributing to the climate footprint? I work with an international organization called Healthcare Without Harm. They are present in several countries. And they put out a report in 2019 that measured the climate footprint of the health sector. It's about 5% of the global greenhouse gas emissions. So just think about it. We who are delivering care, doing no harm to our patients, are also contributing to climate change. By virtue of our buildings, our use of energy, water, our waste management, we are contributing also to the climate crisis. And therefore, it's important for us to stand up and take notice and make changes. And this is where we brought to India the concept of climate smart healthcare, which talks to two pillars of action. One is the climate preparedness or adaptation, which is empowering our health systems, our public health practitioners on the knowledge of climate change and impacts on health. The other pillar is about mitigation or greening. And greening, sir, you rightly said, is not about putting plants and trees in our healthcare facilities, not to discount that, that's very important as well for our mental health, but it is about becoming efficient in the management of our resources. So these two pillars of action constitute climate smart healthcare, and it's very important for us to become climate resilient and environmentally friendly healthcare facilities. We are working with the ministry, and I'm sure Dr. Rameshwaran will talk about it. There's a whole pillar of work that we are doing. We've also been talking to Tamil Nadu health practitioners about this concept of climate smart healthcare, which is both about building your adaptation response based on your climate vulnerabilities. You're probably a more flood-prone state, but you're also having droughts and heat waves. So you need to have your own climate action plan tailored to your state and take action from there. And I just want to take a minute to say on capacity building, it's important if our doctors are not being taught about climate change and health in their medical curriculum, or the nurses, or allied health professionals. It is important we have to make a change in our curriculum so that we are starting right there, empowering our practitioners on the knowledge, not just on air pollution, but also on climate change and impacts on health. It's important, and I'll end by stating one of my former president now, Professor Srinath Reddy, who said in one of the climate change and health conferences back in 2018, that never before have we been so forewarned about a doomed destiny, climate change in this case. But never before have we been so forearmed with the knowledge and the tools to alter the course of their destinies. We know today, WHO, the government, everybody has given us tools and resources to address the climate change crisis. So we have the tools, we just need to act together and act now. So I'll stop over there, and thank you for your listening.
Thank you, Dr. Purnima. You have, I also supported you in the beginning that yes, COP27 is not addressing the health concerns arising out of the climate change. You talked very nicely that energy sector is represented, forest is represented, environment is represented, transport is represented, but health is not represented, and I do truly agree. And one of the most important, you can say the one-liner will be that why we are talking about climate change nowadays, why we are becoming more, why our belief in climate change mitigation is increasing day by day, because of human well-being. And human well-being cannot be segregated from the human health and health systems, public health systems. So I truly appreciate your concern, and I will also advocate, I will also do advocacy for including this health into the climate concerns of our department so that we mainstream everything and move forward. Thank you so much. And now I take pleasure inviting Dr. Rameshwaran Soroghaibam, Deputy Director, National Program on Climate Change and Human Health, National Center for Disease Control, Delhi. I am sorry if I would have pronounced your name wrongly.
No, it's okay.
Thank you.
Thank you very much. Thank you, Chair. You have lessened our burden lots. You have, explained about climate change issues to all the, our delegates and to all our esteemed, who are present here. I'm very thankful to our, this director, Tamil Nadu, this public health, for being part of this national program on climate change and human health also, because climate change is speaking by the experts, listening by the delegates, listening by the, those who are the, I see them as the, potential solutions, givers to the, states of Tamil Nadu. Everyone here, they are the health workforce, health professionals, and the community level workers. All of them, they are to be, strengthened. They are to be enabled, to, address the issues of climate change in this state. I mean, we are working for the country. Climate change as such is addressed at the level, globally by the United Nations and the UNFCCC, And at this national level, it is dealt by the Prime Minister's Council on Climate Change, PMCCC. This was established in 2008. And during that time, they have, identified about 8 national missions on climate change. That's why in the latter review, health was incorporated. That's why we could see a lot of gaps on the addressings about the health concerns of climate change in the country. The National Health Missions on Climate Change was introduced in 2014, after about 6-7 years gaps. So we are still lagging into that. And, they have called it National Missions on Climate Change, National Health Mission on Climate Change. And this national program on climate change is the national mechanisms to, support this National Health Mission on Climate Change. And it is also to address the health concerns of climate change in the whole country. We are working with, all the states. We are working with all the, our, international and national, these NGOs. We are working with our identified centers of excellence who are really working into some of the identified climate-sensitive diseases. There are something called climate-sensitive diseases, and that includes broadly from this direct and indirect. And some of them are dealt directly by this program, which includes like air pollution-related illness, which include heat-related illness, which include development of green and climate-resilient infrastructures across the whole country. It also includes, understanding of the health vulnerability needs assessment in context of this climate change. These are some of the areas which we have to develop. The national mechanism is trying to, develop all these areas so that the health sectors are strengthened and, our health professionals and workforce, these are well-trained and on giving the well information to all the people across the country, particularly to the vulnerable group of populations, and so that we can develop our this preparedness and response mechanism properly from the health sector in partnership with all the relevant these sectors, from the non-health sector, from the health sector. What we are saying today is the health concern of the climate change. Climate change is dealt as such by the this Ministry of Environment, this Forest and Climate Change. This is the nodal ministries which is looking after the whole country. We are part of that. So being a member of this national program on climate change, human health, I request all of you. You are the real game changers. There are lots of these things which has been brought out. But under the Prime Minister's, under the PMO's office, under the eyes of the PMO's office, we understand that there is a development of this this steering committee on climate change and human health. There is between this Ministry of Health and Ministry of Environment, and under the PMO there is also overlooking of all these missions. They are incorporating about the health concerns also. It is not that it's not incorporating. They have already taken all the guidelines, even the National Action Plan on Climate Change and Human Health, which was developed in 2018 and it was updated in 2021 in February. We have developed that one. Since I have been working in 2019, it is a very recent this program, and this was funded. Its approval was funding this approved by the the funding was approved by the NHM in 2019 only. So we are quite engaged with the state of Tamil Nadu also in the last 4 years. I have been engaging myself, talking about the state nodal officers. Dr. Sampat is there. I'm working, we have been giving a lot of trainings across the country, including the district nodal officers of this whole, this Tamil Nadu also. Today only I have completed one of the district nodal officers module on air pollution related illness, and that will be conducted next week. And that will be, another physical will be conducted another week. All these things are taking, the government is really working into the, we are trying to bring up the experts. We are having difficulty is bringing out the experts. We want something that needs to be worked out on the ground to give to the healthcare facilities, to give to the people. That there is something, difficulties is, the challenges are there. We don't get the ready-made things so that we can give directly to the healthcare facilities, to the health professionals, to the community people. What should we give? We have to think that. So the experts across the country, we're looking out, the NGOs are looking out, they're helping us. We're trying to give all this, whatever that we make, we give to the states, to the district office, the district nodal officer, to the district level. So the program is trying to, address in that way. The only thing, the unfinished agenda, this can be only completed through the development of well-informed community, through the trained, this workforce, healthcare workforce, through the capacity of this healthcare sector, through the partnership between this non-health sector and health sector, and through the development of locally available Indian evidence on these issues. With this, I will stop, sir. Thank you to all of you.
Thank you so much, Dr. Rameshwar. And you are right, you have rightly pointed out, and I don't have a second thought on it, that without the healthcare professionals and enlightened healthcare professionals, and we cannot survive the climate emergency and climate crisis which is going on, and we need to make them more sensitized. Up to the PSC level, we need to make them sensitized on the climate change issues. And our last esteemed panel member I would like to invite is Dr. K.C. Seran, Additional Director, NHM, Directorate of Public Health and Preventive Medicine. Please.
Good morning to all. உடலால் அழியில் உயிரால் அழிவர் திடம்பட மெய்ஞானம் சேரவும் மாட்டார் உடம்பை வளர்க்கும் உபாயம் அறிந்தே உடம்பை வளர்த்தோன் உயிர் வளர்த்தோனே அப்படின்னு திருமூலர் 2000 வருடம் முன்பாக மிக அழகாக நம்ம தமிழ்நாட்டில் அழகாக சொல்லிட்டு போயிட்டார். ஸோ ஹெல்த் வந்து எவ்வளோ இம்பார்ட்டண்ட் அப்படின்னு ரொம்ப அழகாக சொல்லிட்டாங்க. ஹெல்த்தில் வந்து இப்போ என்னென்ன மாற்றங்கள் ஏற்படுது அப்படிங்கிறத பார்ப்போம். Now we'll go to the climate change. So climate change has more effect, more impact on health mainly. In this, I like to enlighten certain points. The first point is, certain groups are susceptible more by the climate changes, particularly in age, young children and old age peoples. Regarding gender, females, mainly pregnant ladies, and as usual the socio-economic groups. So you have to concentrate these peoples. And secondly, infectious diseases. There is an increasing trend of infectious diseases, and mainly the transmission period of the infectious disease are lengthened or extended, particularly for malaria and for dengue. And there is an increased trend of waterborne diseases, mainly diarrhea diseases, and increased trend of zoonosis also. So these points we have to concentrate as an effect of climate change. See, we'll see extreme cold, extreme heat, so many floods, drought, and melting of ice glaciers, rising of sea levels. How it happens? What's the reason for all these things? Global warming. That is the main reason. How it occurs? The release of the greenhouse gases, mainly carbon fluorocarbon and carbon monoxide, carbon dioxide, everything that goes to the atmosphere, and it put a hole in the atmosphere, and it allows the ultraviolet rays from the sun and also from the atmosphere. That rises the temperature of the earth. nearly 1 to 2 degrees Celsius raised in compare with 100 years back. So that's the main reason. Because of these changes in the atmosphere, there is a change in the genetic genes of the animals and humans also. There is some genetic drift occurs. Because of this genetic drift, there is a lot of disease occurs in the cardiovascular system and also respiratory system by air pollutions and all other things. So one study says nearly 250,000 people will die other than the normal death in 2030 to 2050. How serious is the thing? Just imagine. இப்போதான் நம்ம கோவிட் பார்த்தோம். கோவிடில் நம்ம எவ்வளோ கஷ்டப்பட்டோம். பட் அதில் வந்து தமிழ்நாடும் சரி இந்தியாவும் சரி எவ்வளோ அழகாக நம்ம வந்து ஃபேஸ் பண்ணி வந்தோம் அப்படிங்கிறது உங்களுக்கு எல்லாருக்கும் தெரியும். ஸோ சேம் திங் வில் ஹேப்பன். இதை நம்ம வந்து சரியாக ஐடென்டிஃபை பண்ணல அப்படின்னா டெஃபினெட்லி the study says 250,000 deaths other than the normal deaths per year will occur. So another thing, so the both government, the state and central government allocate nearly 64,000 crores in health sectors to improve the health and wellness centers and to combat the effects of the climate change. So what is another thing you have to need is training. You have to give training to all the people, particularly to a common man. Climate change ன்னு சொன்னா யாருக்காவது தெரியுமா? நம்மளுடைய ஊர்லேயோ இல்லை கிராமங்கள்லேயோ இல்லை எங்கேயாவது நீங்கள் போய் கிளைமேட் சேஞ்சு இதனால் வந்து உங்களுக்கு மஸ்கிட்டோவில் ப்ராப்ளம் வரப்போகுது இந்த மாதிரிலாம் சொன்னீங்கன்னா யாராவது புரிஞ்சுக்குவாங்களா? யாருக்கும் அப்படி கவலை கிடையாது. பர்னரில் எரிஞ்சு மேலே போயிட்டுருக்கு, வண்டியிலேருந்து ஃபயர் போயிட்டுருக்கு, புகை போயிட்டுருக்கு, நல்ல நெருப்பை எரிச்சு கொளுத்திட்டு இருக்காங்க. Just think about the Delhi. டெல்லியில் ஏர் பொல்யூஷன்ஸ் ஓவராக போய் இப்போ என்னாச்சு? நிலைமை அங்கே கைமீறி போயிட்டுருக்கு. ஸோ தட் ட்ரைனிங் அண்ட் இன்க்ரீசிங் ஆஃப் அவேர்னஸ் இஸ் வெரி வெரி இம்பார்ட்டன்ட் திங். District level, state level, central level, we should give some training to increase the awareness of the climate change and its impact on agriculture department and health department in almost all systems. Thank you.
Thank you so much, Dr. K.C. Seran. Now, before concluding, and I think there will be a question answer session also. Before concluding, I would like to do a little more advocacy about why the health sector should be incorporated into the climate change agenda is that. First, I would like to enlighten the August gathering that as per the National Health Profile 2019, the country spending per capita on the health is only 1,700 rupees. And in the climate, because of climate change compulsions, this expenditure is going to be around 4,000 per person in the coming year. So how the climate is going to impact the health cost also is to be seen, and therefore it becomes important. And secondly, the lack of workforce. As per the WHO data, 778 physicians we are having per million of population, which is required to be 1,000, so we are low on the workforce also. And third thing is that definitely we have talked about heat stress, waterborne diseases, vector-borne diseases, all those. So this is going to put a very strong impact on the public health infrastructure. And public health infrastructure and workforce need to be sensitized and need to be upgraded, because Tamil Nadu will be not an exception in the coming decade, 1 or 2 decades, where deaths due to heat stress will be more and more, and therefore up to the PSC level, that kind of preparedness should be there. Third thing is that I would like to inform you all that Tamil Nadu has formulated State Action Plan for Climate Change 2.0 version. I would like to request the health sector to kindly go through it and see that if more and more health concerns can be incorporated into SAP-CC, so that you can be well represented whenever there is some international or national conference on the climate change issues. And last but not the least, that I am extremely out of the three crucial missions from the environment side. She thought that since I have been dealing with 2 missions, I will be the person to be here. So thank you so much, Public Health Department, for giving me an opportunity. And thank you for the patient listening. And thank you to my esteemed panel members who have, I think, made this session very meaningful and fruitful. and I hope that there will be few questions because I know that there's a pressure of for going for the lunch also. So it will be not it will be forcing you to leave this hall early. Then, but I would like to have a few questions from you so that our enlightened panel speakers can answer you. Thank you so much.
First of all, thank you to our DPH. I am following him for the 11 years. I am the governor of Chess Council of India. We are having 4,000 respirologists and 9,000 followers all over India, sir, all over the world. Every Thursday we are conducting a CME program in 8:30 to 9:30, and it is very world famous. And I really appreciate our TSS sir. I used to call him my professor. This is the first time I am seeing a DPH icon equal much better than a NHS. I think madam would have been WHO madam. My question is only simple. They have been asked the numbers, and I am the first person who has been challenged the American chest that E6, that is eosinophilium 6, is a infective etiology. Now just think about it. When we all think, when we have been taken that CBC count, a simple count which we can do each and every corner of our PSC, if it is a E6 is an infective etiology, how can we think it's a COPD? All of us are E6 according to the WHO. And what is the real criteria now? Eosinophilium 6 is a infective etiology count, or what else, sir? Simple question. When you take a E6, eosinophilium 6, when it is an infective etiology, then the whole GDP will be fall down in India. I stopped the thing because it has been given by the criteria which has been done by both Americans and Australians and our own Indian people who is the professor, like our TSS sir at UK. So it has been stopped. What is the real number? What? It is a E6 or more. In Delhi, everybody are E10. Even all the IAS officer, now I can check, they are E10. Because we are sitting in a different AC mechanism.
So,
no, I am asking for the professor, sir. Professor is there. Our madam is there. Kalpana madam is there. So this is not the criteria. And another thing, sir, it is not only diabetic hypertension, IHD, hyperlipidemia. Nowadays it's osteoporosis. COPD is making osteoporosis each and every person. I am having kith and kin, 98 year and 90 plus. My thing is 90 plus active. I am happening more than 2,500 villages I invaded. More than 2,500 villages, sir knows, in CM scheme. Even because of me, he has taken out the COPD. Because it itself costs him more than 100 crores in a year. COPD is not for the private, it is for the only public sector has to treat. But still we are doing the COPD in another way. It is acute on chronic respiratory failure we are treating because it's going to be a butcher. It's more than a ARDS. But I really appreciate our CM scheme. We have given the COPD. We have given most of the people, almost all villages, more than 2 lakh populations. We have given the Seraflow, which has alleviated the number one killer for we have been alleviated most of in our villages. We don't have mild, moderate, severe critical care. We doesn't have any severe or critical who has used the Seraflow inhaler because the viral load will be less invariably. So my question is, if now China, Wuhan is stopping, if Wuhan the spread is 40,000 the day before yesterday, the Chinese president itself is going to get distorted. Then if it has come, what is your answer?
no, but your point is well taken. I would just, because what you are telling is doing the correct profiling and trying to find out what exactly the kind of genetic makeup is there in the population, and then we have to prepare the adaptation plan according to that.
Because we have to give the numbers, sir.
Yeah, numbers as well as we have to give the budgeting also, because it depends on the ultimately it's profiling. Everything is based on the health profiling of this. I take. But if you have got any specific questions which is related to climate change also, we will welcome you.
Climate change, extensive talks, sir. I have not seen such climate change talks in USA also. I am a regular attender of just twice a year in USA and UK.
Now it has started.
Yes,
Now it
climate
has
change,
started.
extensive talk. Thanks for our Professor TSS.
Thank you, sir. So we honestly, any other questions?
Very good afternoon, sir. Sir, I am Dr. Dinesh Vikraman, but I would like to ask this question as a general public, sir. Sir, I think as long as we breathe the same air, our purposes are common. Wherever we are, whatever district we belong to, state or nation, we are breathing the same air, and that fact is not going to change anytime soon. So our purposes is common, and this is a very important discussion. What I wanted to ask is, sir, 100 years before, we had the problem of acid rains, and while we were in our school time, we had the problem of ozone depletion and all that, and now climate change. This is like a wheel, sir. The wheel keeps rolling on, and maybe somehow the science finds some solution. Definitely, the science has come a long way in reducing the air pollution. There's no debating that. And so the acid rains have come down, and the ozone depletion somehow we are better than how we were 20 years back. But what I'm asking, sir, like whenever the wheel rolls, there are people dying every time. Suppose there's a farmer who is living nearby a mining town. He is just doing farming. He is not involved in mining work, but he is getting COPD, and he is dying at 30 years due to respiratory failure. What answer we are going to tell these people? Because I have worked in a PHC setup. I see lot of patients with COPD. I refer to medical college, and after some period of time, they develop respiratory failure. 17 and 19-year-old children with respiratory failure with no promise for life. Their life expectancy is totally reduced. So what are we going to do to that? And two more things I want to ask, sir. Like at international level, I think, sir, maybe, sir, kindly correct me if I'm wrong. I think we need a much more stronger watchdog, because a lot of climate conference is happening, and as you can clearly see, every conference, simultaneously, lot of protests will be going outside the conference, because the people will be demanding, you are not doing enough. Even if we bring down all the world leaders to a table and we discuss, but what is ultimately happening, sir? Because we can't demand the developed nations to bring down their emissions, at least not yet. Like, we need a much more stronger watchdog to enforce things, because Bhutan is there. Bhutan is a carbon negative country, but not all countries are carbon negative. They are enjoying the productivity of Mother Earth, but what are they going to do in return? That is one thing I want to ask, sir. And then, where we have legislative control, under a single nation, we have proper control. But what are we doing with it? Let me say, sir, I live in a tier 2 Indian city, and I can see lot of lorries going with mining sand, but they are not covered. Whenever the lorries are going, they simply throw the sand, it is getting dispersed in the road, and it is a clear cause of air pollution, and which can be very easily addressed if we just bring a single legislation at state level stating that all transport trucks should be properly covered with a sheet. I'm just saying for an example, and we are all breathing air, and maybe we can just put up a legislation that every single human being living under this nation, they should plant and maintain at least 5 trees. So things like that could happen, but why it's not happening? What can we do to address these things, sir? That's my question, sir. To the panel members, thank you.
Yeah, it is working. It's on.
Yeah. So thank you for your question. I'll try to address one or two of the things that you asked. I can see the angst and the you know, from a young person in the audience, and this is what we are seeing when all these conversations are happening at global level, national, international level. There's a whole momentum that the youth voice is bringing to these conversations, and you'll be happy to hear. I've been to about 3 COPs, and there has been no voice before for these young people. But now there is a whole youth, there's something called Youngo, youth NGOs that are coming in big force and asking for a voice at the table. And they are now becoming active parts of these conversations. So it's, yes, the protests happen outside these conferences, but there is a voice now at the table that is representing youth, that's representing vulnerable populations. I'll tell you about a group called Warrior Moms. They are people whose children have been affected by the health impacts of air pollution. So they've become an international force, and they are there at all these conversations. So it's not that it's restricted now. In the last 2 years in the COP conference, for example, there is a health pavilion, which is hosted by the WHO. So there we are having a lot of conversations where the health professionals are bringing these knowledge and conversations around climate change and impacts on health. And what I've been also telling in those conversations is that we should not restrict ourselves to our own health pavilion. We should go and plant ourselves in all the other pavilions, energy pavilion, transport pavilion, food systems pavilion, so that people are starting, whatever they are talking about, they should think about health in all policies and programs. So that answers some of your questions, I hope. There is action that is happening at the global level. It has to filter down. And definitely in terms of conversations that happen there has been now this time that funds that have been allocated, the climate finance, as you might have heard, that developed countries should be giving to developing countries. $100 billion is what it was. There is now going to be a mechanism for that to flow. And it's really heartening to note, Sir said, that Tamil Nadu Green Company, some Green Climate Company. So, Green Climate Company, that's already a start. Again, Tamil Nadu being a pioneer for institutional mechanism to receive those funds. So I think there's a head start in some parts of our country and the world, and I think it's, the momentum is changing. So it's a nice feeling as well. So not all bad.
Thank you, thank you. To compliment, madam, I would like to share you, there are a lot of these international dialogues, no? And this Paris Agreement is there, and recently there's an acceptance from the Western world, or what we call this developed, that has been said, that they have agreed, to provide the funding, to the other countries and all who has not faulted from their side and all. So there are something that the positive things are coming up also, and you are rightly saying that. See, the thing is that climate change, when you say about the climate change and all, not only climate change, it's about the health issues. See, climate change is, there is increasing the frequency and magnitude. The frequency which was happening 1 or 2 before is happening 4 or 5 times. And what is happening is that, the previously it may be, the magnitude may be 4, but this time it is increasing into the 6, 7 level, something higher level. And this is increasing to the more areas. Because of that, we know that there is a competing, this funding requirement for the health issues that is occurring in the society. But this is also one of the things that is also coming up, and this is a very recent phenomenon and impacting and it encompasses the whole, the spectrum of the health issues. That's why these are relatively new. So you are also feeling into that. This concept was also not included in the medical program, so you are also not aware much of that. But right now, in the coming generations, we have also, this has been incorporated by the 6 councils in the country. So they will be more aware. So when, they are passed out or coming out like you, they will be a little aware, and they will not be that much angst like that we show to you. So, I mean, the issues are there, but it has to be solved through dialogues and through the, by giving proper, appropriate funding to each and every locations depending on their issues, right? This is the thing that I've...
So, thank you so much. Now, one last appeal from my side to all the audience, you can disseminate it throughout the Tamil Nadu, that we are implementing Green Tamil Nadu Mission, where we have to bring our total area under forest and tree cover to 33% in 10 years. And now we are only at 23
7%. So we have to plant in 10 years 265 crore of seedlings. And till now, we have done only 2.5 crore, and coming year we are doing 7.5 crore, then we will be increasing day by day. So my appeal is that, see, trees are one resource which takes care of a climate change also, which takes care of health concerns also. So please disseminate to the larger part of the state, remote part of the state, that one household or one person, just 3 to 4 cloth bags, and we are coming out with a YouTube video to how to prepare your own seedlings. So therefore, if each person, suppose today the population of Tamil Nadu is 9 crore, means 7 crore, might be 9 crore now, so only 5 crore I am taking, 5 into 5, 25 crore. 25 crore seedlings we can plant, and we are geotagging it and putting on the web portal to see your seedlings where it is being planted. So for the first time, this mission has uploaded 67 lakh plantation till date on a dedicated web portal. It is www.greentnmission.com. So you can do it and just adopt few trees, plant few trees and adopt, and protect one water body in each block and make that sewerage and household waste free. I think if these two things, small steps we take, it is not only a climate change mitigation, we are adapting to the adverse effects of the climate change, and we will be improving the health of the communities. Thank you so much for your patient listening, and thank you, my panelists, for supporting me in a very grand manner. Thank you so much.
Yes, sir. Thank you, sir. We honestly thank the chair and the panel members for providing us valuable insights on this mysterious area for most of us. And it was an in-depth and complete discussion covering air pollution, pollution due to household energy, and role of health department in climate policies, and sensitizing the major areas where we need to focus to manage the climate change. And finally, definitely we'll take the chair's suggestions on 2 points. One is the state health policy of Tamil Nadu, and also the Green Tamil Nadu mission, sir. Thank you, sir. Thank you all the panel members. Now I request our OSD ma'am to felicitate the chair with a memento. I request our additional director, Dr. Shekhar sir, to felicitate the panel members. Thank you, ma'am. Thank you, sir. Thank you, thank you. Thank you all. Yes. So now we will move on to the next session. Sustainable Development Goals and Tamil Nadu Health Systems 2030, a plenary session by our renowned, very familiar Dr. Darius Ahmed, sir. Welcome you, sir. Sir completed his MBBS in sir. Yes, sir. A simple note, sir. So actually, I wanted to insist on only one point, sir. Like during the tenure of sir as mission director, we could achieve certain things, like we achieved the Sustainable Development Goals for reduction of MMR and IMR well before the target 2030, and we implemented the universal health coverage and initiated new programs based on analysis of Dali's Lost, and of course THAI program, and Sir was the incident commander for and overall coordination of the UCC as single nodal point for COVID-19 control activities and so on. And finally, we all miss you, sir, actually. So please.
Good afternoon. Sorry to stand between you and lunch. I think Director of Public Health is like coming back to home to me. It's like something which is very intuitively normal, and I feel that this 100 years of such a glorious department is really worth celebrating, and we should, as all citizens of India and Tamil Nadu, should celebrate this achievement. And with all pride, we can say that we have one of the best functioning public health departments in the country, and maybe one of the best in the world. And honoring that tradition is what we are here for. And here I would like to just talk about some observations on how sustainable development goals are going to be played out in Tamil Nadu. At least that is what I feel the direction or the route which we are going to take, and what will be the most credible outcome, what are the outcomes which we can have at 2030. So all this I will just skip. Basically, you all know SDG goals ensure healthy lives and promote well-being, equity, inclusiveness. No one should be left behind. So where do we stand? This is actually a snapshot of where do Tamil Nadu stand as a state in sustainable development goals. See, all these MDGs unfinished targets are there: reduce maternal mortality and preventable newborn diseases, reduce mortality from NCDs, strengthens and prevention of treatment of substance abuse, halve global deaths from injuries, reduce death and illness from hazardous chemical, air, water and soil pollution. There was an excellent discussion regarding climate change and how it impacts health outcomes. Here, the most important thing which we have to understand is that all these targets are quantifiable, and where do Tamil Nadu stand and how much improvement has to be done to achieve the goals is what I am trying to just give some data. Already it's too late, I'll just try to rush through. See, when you look at this data, Tamil Nadu, almost 1 in 7 people die of non-communicable disease. When 1 in 7 die of non-communicable disease, do we have an appropriate response system? Out of that, almost 36 out of 100 is cardiovascular, 12 is diabetes, urogenital, blood and endocrine. Neoplasm, cancer is almost 8, and chronic respiratory is 6.5, and neurological disorder 2. So basically, 70% of all deaths are non-communicable disease. And it's Delhi, if you look at Delhi, it is similar. Here, injuries is another 13%. So if you want to achieve sustainable development goals, our most important challenges lie in NCD and injuries. And are we ready for this? We'll just have a look at the numbers. See, I've just extrapolated GBD data of 2016 Healthy Nations, Healthy States ICMR report of GBD. So if you extrapolate the data with CRS, you can say that almost 1,94,000 deaths in Tamil Nadu are due to cardio. I'm just putting numbers. Since public health CRS are very critical, these numbers we have to understand how much effort is needed to achieve the sustainable development goals. See, if you look at cardiovascular disease, we have to reduce 64,700. If you take 2019 CRS as a baseline, and you have to reduce 64,000 deaths due to cardiovascular disease, and you have to reduce 24,000 deaths from 70 out of 70,000. If you want 1/3 reduction in premature mortality. Premature mortality is any death which is before 75 years. That's what the definition is. And most of this, if you look at the CRS data, it is premature mortality. So this is the quantum of deaths which we need to reduce if you have to achieve the sustainable development goals. And if you look at cancer, almost 15,000 deaths, COPD 12,000, kidney 3,000, and self-harm. Suicide we have to reduce by 8,500 deaths. And injuries almost 9,000. So this is the target and achievement goals for Tamil Nadu in SDG. And all as health professionals or health consultants and health system people, you have to think that do we have the strategies? Do we have the resources? Do we have the HR? Do we have the response for achieving these numbers? This is SDG. Or by 2030, will we fall short? So this is something which I thought is worth raising during DPH 100 years. Because public health, most of the achievements of the Tamil Nadu health systems is built on the base of public health. And that base is celebrating 100 years. And this is the biggest challenge Tamil Nadu health system was going to face, which is in 2030. We have different type of response, but the numbers which we have to achieve are huge. And we have to think, because now this is 2022 and SDGs are not, the strategies for SDGs is not the same which we have for MDGs. We need to think differently to achieve these goals. For example, if you take, I will try to go in deep depth for cancer. How do we prevent 15,000 deaths by 2030 in cancer? And this is a very tough question, and this is something which I would like to, and what is the role of public health in it? I will only discuss cancer. Rest of the things which I don't have time, because all of you are already delayed. And that same application you can do for any of the, because what SDG we have to achieve, it is not some philosophical goal. It is a number-based goal. And this number you have to be very clear. If you falter in achieving this number, then we are not really getting there. So, health system challenge. What are the challenges? The biggest challenge is investment. Only 1/3, 30% of state finances goes to SDG, which is almost 65% of the DALI and 70% of the mortality. And almost maternal, neonatal and nutritional based diseases are 40% of the investments. Injuries 15%, communicable 14%. So this is the distribution of funding, and you can very clearly say that NCD funding is not commensurate with the amount of problem which we have. Unless until we correct this discrepancy, it is very difficult for us to really achieve the target. Again, it's very, very strong argument here that when you are facing 100 years of public health, our primary expenditure on primary care is now only 34% of the total health budget. And that is a situation which is not sustainable, in the sense that all over the world, more than 50% of the health expenditure has to be in public health. And that is a standard formulation everywhere, which we are not able to, we are not able to, and which is almost, and it's a standard reference is above 60%. So without investment, adequate investment, it's very difficult for us to achieve the goals which we are stated to achieve. So at the 100 years of public health, I would like to say that our investments has to be commensurate with the challenges facing public health, and at least above 50% of the total health budget. And it is, say we need to redesign. In the first session, Girija Madam would have talked about Public Health Code Act, how do we, and it's time that we need to redesign based on, for example, TN Public Health Act doesn't talk about non-communicable disease, if I'm right. And that has to be corrected to ensure that it is in line with the latest, the current challenges we are facing. And secondary care also. And I think that administratively, colleges and teaching hospitals has to be de-linked in the medical college system, because the problem is that the public health aspects of medical college hospitals are not really stepping up to the challenges which we need to do. So this de-linking, administrative de-linking of college and hospitals is something which is very critical for example, them to serve as centers of public health and medical and health science researchers. This is one of the other thoughts which I am raising here. And devolution of local bodies. Since I am Commissioner of Rural Development and Panchayat Raj, the local bodies' involvement in health system is very, very minimal, in the sense that there are dengue mazdoors. So that is another area which Tamil Nadu can tap and ensure that local bodies are part of this huge enterprise in improving the health of the public. And local bodies have the resources, the manpower and the wherewithal to deliver the services, and we have not really used that part of the system. And this is a critical problem here. And if you look at care, inpatient institutional care, if you look at 1% of people use almost 1/4 of health expenditure. and 5% use almost 50%, and 10% of the people use 65% of the healthcare. So what is it mean? The meaning here is that there is an element of cross subsidy, because the other 35% is used by 90% of the people use only 35% of health expenditure. So what is important is that public health caters to this 90%. Unless that is the bottom of the pyramid. Unless until this aspect is clearly bought out, the funding mechanism is not really attuned to understand that this is where public health, because a strong public health system ensures that only few people needs institutional care. And the achievements of public health are not, you cannot, because it is basically prevention. So that you don't need, if you treat hypertension, diabetes on time, you don't end up in bilateral kidney failure and dialysis. So these are the things which is subsumed, because, and you only talk about institutional care mechanism, and which 10% of the people uses, and this funding itself is a challenge. And public health has this constant issue of making the whole system understand that 90% of the people will not access institutional care, the big institutional care, and these people are kept outside the institutional because a strong public health system prevents them from falling sick. So this is a very critical aspect of the whole issue. And we need to, because I don't want to go into details, payment reform, health technology assessment, what will work and what won't work in public health system. Primary health care reform, universal health coverage, and Makkala Thedi Martha, for example. So, idhila mukkiyamaana vishayam enna, in the 90% healthcare kodukra public health system thoda funding, institutional system thoda funding different ah irukum. Adoda importance rendu we should bring out in our system. So, health system priority, non-COVID essential healthcare, normalcy kondu varanu. Then NCD mortality, the cancer, mental health issue. I'll just go into details of cancer. For example, if Tamil Nadu wants to achieve SDG goal in cancer, which are the areas which we need to improve? And we need to have the Right to Health Act, state health policy, toxic ban, for example, banning toxic chemicals, which is an important, plays an important part in suicides, urban healthcare, emergency medical services, road safety bill, HR policy. So these are the some of the policies which we need to reach towards SDG, which is only 8 years away. 2030 is what our time frame is. Cancer and palliative care service. So I'll take one example and see that how we can further disaggregate an SDG goal achievement. So if you look at incidence of cancer, see Tamil Nadu is very high in the sense that, for example, CIR, cancer incidence rate of Perambalur is 4th highest in the world. And for example, 42.4. And oral cancer also we are high. And if you look at similar comparable countries, Thailand, Bangladesh and Sri Lanka, Tamil Nadu's breast, cervical and oral, which are easily screenable and preventable cancers, are one of the highest. It is from, I have taken the data from IARC. So, high mortality, and we are reporting also almost 8,000 deaths from cancer, which is only 50% of the real reporting, because our MCCD is extending, medical certification of cause of death is extending only to some for 30% of hospital admissions. So from there, at least this much deaths are reported in Tamil Nadu due to cancer, but the actual numbers, if you look at GBD, will be around 3 times the number. And if you look at cancer facts, okay, 80,000 new cancer patients in 2020, there is a 5x in cancer incidence increase in 2025. 20 people die every day of cancer. To put it in perspective, that is very, in the sense that very underreported figures, it will be almost 50 to 60. And if you look at 40% of cancer at tobacco, 1 in 8 men and 1 in 7 women have cumulative risk of developing cancer during their life. If you look at risk again, Chennai has 1 in 7 risk, cumulative risk of developing cancer, and this is again from cancer registry we have got this data. And if you look at the projected cancer cases, so the point here is, which are the different type sites? Site-wise, if you see cervical, breast, lung, mouth, which are preventable easily, like in the sense that preventable, and other screening, we can have a better screening to really have an impact on this cancer incidence. See, here, this is a very important data in the sense that Tamil Nadu, only 10% of women in the age has undergone a screening. And if you look at breast cancer, it is only 5%, 6% total. Okay, and oral cancer, it's still 1.1. So there is a huge gap in screening, which can easily improve the outcomes, because what we find is that only 12% of the people in the state is diagnosed. I'll just run through, and these are the data how to provide. So here, HPV vaccination once again. So what the problem is that our identification of the cancer cases is almost always at, most of the cases are at stage 3 and 4, and only 12 to 15% is in stage 1 and 2. So unless until we have a better diagnostic system, which at least we are able to diagnose stage 1 and 2 cancers, at least 70% of all diagnosis by 2030, we will not be able to reduce the outcomes in cancer, because it's a very critical and tough thing to achieve. Unless until we have a proper plan, we will not be able to really make a dent on cancer care. So screening, we have a lot of work to do. MTM, already PHCs and district hospitals, daycare chemotherapy, morphine, palliative care services, HPV vaccination. One of the easiest way of reducing mortality from cervical cancer is HPV vaccination. I think we are on the right track to do that in Tamil Nadu. Risk factor management, burden of disease study, focus on women-centric cancers, awareness program, opportunity screening. The overall proportion of patients visiting early with disease in localized stage is only 12.5. 88% of the cancer cases are identified once it's already spread. This is an unacceptable high rate of spread, and which will cause the which will reduce the quality of outcomes in cancer care. So this is where public health has to step in and ensure that we are able to identify and diagnose cancer at early ages. Surgical oncology changes, because it's already late, I'll just rush through. Tumor board, cancer detection, and cancer. We don't even have enough beds to take care. Vulnerable, I'll just go start mental health. See, I'll just rush through anyway. See, when suicide is another huge problem which we have. 50 people commit suicide every day. For every successful suicide, there are 20 unsuccessful attempts. So the number of people committing suicide which end up in Thai emergency rooms will be around 400 cases a day. And repeat suicides, almost 50 to 60% of suicide is second attempt and above. So there is a window of opportunity for counseling which we have to use. And this counseling has to happen at the public health community level, not at the institutional level. So this is how suicide rates are going up. It's almost 16,000. And at least banning almost 6,000 deaths are by poison, banning the availability of killer poisons which are highly toxic, which doesn't have an antidote. It's another thing which we need to do. And comprehensive approach on suicide prevention. So public spending has to, I'll just stop here, enhance public spending to achieve SDG, building capability using data, because the data is there. We have a very robust civil registration system. And that data baseline of 2016, reduction of 1/3 premature mortality, is a data which is very clearly defined. We have to ensure that we are following the target, and we have to analyze every year how much reduction is happening. Investment in primary care, UHC, MTM, which 80% of the conditions can be managed at the primary care level. Strengthening of sub-center level care delivery, access to drugs and diagnostics, strengthening district hospitals, integrated district health planning, health facilities. These are all simple health technology assessment. But basically, what I am trying to say is that you please check the data and try to understand that how much reduction in premature mortality we have to achieve, and what are the strategies we have in reducing the premature mortality. So with this, I'll stop here. I think I won't stand between you and lunch. Thank you. Any questions anybody would like to ask, please feel free. Otherwise, I think you can break for lunch. It's not working. Mic is not working. Please. Please.
Sir, under CMCHS scheme itself, we are having a private data of more than 2,50,000 patients, sir. And we are not known about your buccal screening. And that also we will start do it, sir. And how to associate with you to give the data to you, sir, with free of cost. Everything we'll do free of cost, sir.
So I think Tamil Nadu Health System Project is the person who should be doing this data things. So I think that Tamil Nadu Health System Project, Dr. Uma will be the correct person to do this.
Thank you, sir.
Okay. I think that's all. Thank you. Have a nice lunch. Okay.
Thank you, sir. The presentation was an introspection of our current status of cancer screening and also on mental health and suicide, sir. So definitely we'll imbibe all your valuable suggestions, sir. On behalf of the organizing committee, I take the privilege to say we are much delighted and honored to have you here on this prestigious and grand event, sir. And it's really a great chance for us to have you here and hear from you. And we definitely always look for your expert guidance and work in the way to reach or try to reach your vision, sir. Thank you, sir. And I request our additional director, Dr. Cheran, sir, to, Chitra ma'am, to hand over memento as a token of love and gratitude. We all break for lunch, and I request all the delegates to come back to your seats by 2:45. Thank you.
A very good afternoon to you all. This one final call for the poster presentations that are to be started at 3 o'clock. The judges will be there at 2:50, are expected to be there by 2:50 p.m. We have at least another 23 posters yet to be displayed in their respective panels. If the participants or delegates are currently available in the hall, and if they are allotted their posters, I request them to report at the reporting desk at the portico in Port Hall that is available at the right end of the reception. This is the last call for the poster presentations that are pending. I request the delegates to display their posters in the respected allotted places for the judges and be available at their panels by 2:30 p.m. for the judges to evaluate your posters. Thank you.
the UNESCO Bioethics Forum, and regulator of International Confederation of Midwives, the HOG for the Southeast Asia Regional Professional Committee, and brought renewal of license to practice the profession of nursing and midwifery from the year 2013 onwards, and also e-certificate shall be sent to the concerned nurse's email ID. And ma'am has received many awards like Best Teacher Award from Dr. MGR Medical University, Best Nursing Leadership Award from Education Today magazine 2011, and Best Non-Medical Award from Indian Medical Association Tamil Nadu branch, and received Best Nurse Administrator Award from Tamil Nadu Nurses and Midwives Council Chennai, and received Best Women Academician Award from ESN Publications Association Development Tamil Nadu. Over to you, ma'am. Thank you.
Can I have the remote, please?
Good afternoon to everyone. I know it's a sleepy time after your heavy lunch, and I'm not going to grab your time, and it's just going to be a glimpse how, because nurses are the backbone of the health industry. நீங்கள் எல்லாரும் ஒத்துப்பீங்கன்னு நினைக்கிறேன். எனக்கு தெரியும் நிறைய பேர் விஹெச்என்ஸ் வந்திருக்கிறீங்க, பின்னாடி உட்காந்துருக்கிறீங்க. நீங்கள் எல்லாருமே பப்ளிக் ஹெல்த் அப்படின்னா நீங்கள் இல்லாமல் இல்லை, ரைட்? ஸோ வித் தேட் நோட், can I have my presentation please? With that note, I would like to start this because first of all, I congratulate Directorate of Public Health for conducting such a mega event for celebrating this 100 years of establishment of Directorate of Public Health. And it is a great boon that everybody is part of it, not only nurses, doctors, every person who involved in this are part of this program. So I could witness it today. That everybody is participating, there are panel discussions are going and everything. Right, so let me start with my intro. Nurses and midwives constitute the largest component of health workforce, and often they are the first point of contact between the community and health system. I don't think nobody will have a doubt, because that is the true in any part of the world, not only in India, in any part of the world. The need to strengthen the nursing and midwifery has been reiterated in many reports and can be traced historically in recommended by lot of committees, Board Committee, Budaliyar Committee, HLE Committee, and other committees. I will just do it. Yeah? What happened? This is one change, right? I'm doing it. Yeah. What's the problem? So these are all the reports you can see here. So the roles and responsibility of nurses has expanded rapidly in terms of delivery of components. காலையில கிரிஜா மேடம் பேசும்போது சொன்னாங்க, விஹெச்என்ஸ் அன்னைக்கெல்லாம் இருந்தப்போ வெறும் எம்சிஹெச் சர்வீஸ் தான் பார்த்தாங்க, இப்போ நிறைய காம்பனன்ட்ஸ் பார்க்குறீங்கன்னு. That is what the expanded roles you have started doing in your community level. Then however, the involvement of nurses and midwives in the policy making level, like even today, the morning we had the panel discussion headed by Dr. Girija ma'am, and we could see there could have been one representative from your end to tell what is the ground reality which you are facing it. So unless until nurses are involved in decision and policy making, definitely what we are expecting, the SDG goal, which every country look upon, cannot be possible. So it should give an establishment procedure, educational policies, remuneration, benefits, and the nature and quality of training has not progressed the same pace. So though we talk all these things, it is not really taken place or grown in the way what we are expecting comparative to the other profession level. The National Health System Resource Center, I hope you all know, here we have TNHSRC. The same way there is a National System Resource Center has conducted a study on about nursing and midwifery in India, and they did it in some 5 selected states, and they took three points as the broad category. One is leadership and regulation, number 2 education and development, and third is deployment and utilization. If any part of the world now, even today, and I was yesterday attending one of the presentation, the school education also started thinking about training the HMs and HMs on leadership role. So I think in health now we started look upon, we need to develop the leaders in nursing. So how do you develop these leaders in nursing? Based on regulation and your education. Education in the sense now I want to tell you, being the regulator for nursing in Tamil Nadu, I would like to really say we are the one state which very proudly would say we have a live data of nurses where from 2013 onwards we have a renewal of license linked with continuing nursing education of 150 hours. So I can give you the exact data, how many nurses are in Tamil Nadu. So that is what data is the investment today. Without data, you cannot plan for any program. Today morning, we were talking about so much of a HRH policy, human resource health policy. So how could this happen? This HRH policy like councils, like medical council, nursing council, dental council, pharmacy council, allied health council, they should have the data to plan so that the country and the state can plan demand and supply need. So I really enjoyed the time when I visited Thailand with the registrar and the regulators over there in a panel discussion. The registrar said that every year the government used to call them on the board, the nursing registrar, and they asked them whether according to the population, we have this many schools of nursing, these many colleges of nursing, these many public health nurses we need. So based on that, they supply the need. Accordingly, they reduce the number of seats for the college, or they enhance the seats of the college. So that such discussion at policy level, until nurses have been involved, there is no change will happen. Especially in the community sector, public health sector, these things starts to happen, and until the regulator been involved with these all things is not possible. So let me cover up these things in a later part, but I would like to give a small clinical scenario over here. The same thing you will also tell me over there. The clinical scenario, if I say here, like in the primary health center, the staff nurse is there and there is a patient admitted, has not passed urine for 6 hours, and you feel that the bladder is distended, and if you wait for a medical officer order to do that heart application, or you would like to do some other procedure on the patient for everything, then you are not empowered at all. So the empowering is, I'm going to tell you what is it. So the nurse, here you can imagine management, physician, she has been asked by everybody. அவங்க கழுத்தை போட்டு ஒரு சுருக்கு கயிறுல சுருக்கிற மாதிரி management, physician, client, housekeeping, ISO, HR, NABH, supervisor. Though I have given a clinical situation here, you can connect with the public health sector. Whenever there is a target being fixed, I remember I have born and brought up in my primary health center where my mom was a community health nurse, and I could see those days they used to run for cases for vasectomy, number of vasectomy target, number of PS target. Now we all running for COVID vaccine target. So these are all things like everybody were like doctors, the patient who comes there, they approach you, and the higher level officers, and now we are all going for a lot of accreditation, NQAS we are going. So a lot of things, so you are being really being excused by everybody. So what is the problems here? What are the solution here we have to look in? If you could see here, I think lot of non-nursing roles, whether it is a public sector or a private sector, both the areas there is lot of non-nursing work, nurses being involved, and lack of synchronicity is happening. Because of that work mental violence, a lot of work pressure. You saw the previous speaker, Dr. Darius sir presentation, the suicidal one, 52 people out of 1,000 is committing suicide. So there is because of the mental health issues and shortage of staff. Morning also this was the story, and I would like to tell you WHO 2020 nursing report, which clearly indicates throughout the world that is 5.9 million nurses shortage, and especially in Southeast Asia, it's about 4 million nurses shortage. That means you can imagine how much of a shortage, எவ்வளவு nurses வந்து தட்டுப்பாடு அதாவது கிடைக்காம இருக்கிறாங்கன்றதை நீங்க புரிஞ்சுக்கலாம் இதுல. Then workplace health hazard, long working hours, lack of recognition. See, these are all the scenarios or the nursing whatever. One of the nursing report of the WHO 2020 says, I really love the three first things. One is, if you want nursing to be recognized. It need to be visible first. So I appreciate, I really thank DPH department that you brought the nursing representative and making nursing as a visibility to the crowd and to the public, though not much of other cadre, I don't know whether they are there or not, but it is one of the visibility. The second thing they say is leadership. The leadership really we need to inculcate with every nurse. Today morning I was having a dialogue with one of the principal. Somewhere we went lagging. We need to inculcate with our student nurses from first year onwards the leadership. See, a bedside nurse, if she cannot sit in the boardroom and take a decision, your policy is failure, utter failure. If you could say, see, I have visited China as one of the expert member in 2011, and where I could sit with county people and discuss in the southern part, and the nurses were part of it. And they were giving lot of suggestions, what all to be done and how it could be equipped. Such change should happen in every department of our country. Not only in public health, it should happen in medical education, and it should happen in the medical services. Such thing happen unless you cannot solve this problem. So what is the solution we can look for? Positive teamwork. Without teamwork, cannot see COVID time, we all worked as a teamwork. It proved how teamwork gave a fruitful result. So we need to develop, even post-COVID, we need to have that teamwork spirit and workload balance. I know everybody said that you are all overworked and workload is too high. We need to find a solution how to, give a solution to cut off that workload. And then evidence-based practice. Now we are in the era without any scientific evidence, people don't believe your representations. Imagine the lady who found the modern nursing, the Florence Nightingale. She's the first statistician who put up the death rate of the Crimean War with the pie diagram, with the statistics. That is how she could prove herself that the infection control practice is how much important. So we need to encourage evidence-based practice. It could be small. You can think about why in particular area there is a infection is maybe malaria is high. Why dengue? You can take a study. I think now the MLHPs are there. They have been appointed in the sub-centers, and they can collect the data, and you can pool in this data and do a small study and do a great research, and you can supplement with your medical officer with these data, and as a team you can present it and look for a solution. Then recruitment and retention policy. I think morning enough of people spoke about that. I'm not going to talk about much about that, because you have to stop the contractual workers and voluntary basis, all those talks, it's all policy decision. So I don't want to touch that, but these are all the solutions you can think about it. So concept of power and empowerment. So power is different from empowerment. Power is authority over others. That means I say you do this. That's the power. But if you are empowered and the authority is purposefully shared, yeah, come on, I work along with you. This is what is happening. I be with you, and I one along with the team to do the things, so that you give a empowerment to your nurses. So whether it could be a sub-center, whether it could be a PHC, or at your district level, DD level, it should, if it is shared one, then empowerment start happening there. So non-empowerment scenario, I have given clinical here. I don't want to tell anything from public health sector, because it is long time connection for me with the public health sector. So I thought I will safely take out the medication error, whether it is in the public health sector or the clinical scenario, medical services, the medication error, which any nurse who does, immediately the doctor comes and shouts. Or the in-charge nurse comes and shouts in front of a family, in front of other person who are working along with her. That is a very, very bad practice. That is a non-empowered scenario. So non-compliance of the quality indicator by a nurse, what is next step? You need to have a SOP for everything. Your sub-center is being done like this. For this Wednesday, there is something, you are conducting MCS services. What is the SOP? How to be followed? If anything happens, what is to be next to be done? So SOP need to be developed. then adding new form by the quality team which has to be filled by the nurse, but attitude, accountability of the nurse is not motivated. You keep on giving the work, but her attitude and accountability, you don't give her a responsibility, you are accountable for something to give these results to me. So it's like, I would say, like a rubber stamp. You use them, but you say that I'm giving you power, but like a rubber stamp. So nurses function as a housewife, just do what is dictated by doctors. I'm sorry to say that word. It is most of the time, this is the scenario we have been seen. It is not only here, in many part of our country, they think it is because the nursing is like a mother role. That is why the World Nursing Report 2020 says, you need to have a gender equality in nursing. This is happening now, and when we see the gender equality, we are going to see the big change in it. What is the empowered scenario? Taking accountability and responsibility in each aspect of care. Whatever you are doing, whether you are giving a vaccination or you're doing a home visit, be responsible for every action what you do. You record it, document it, and taking ownership of your patient and environment. Taking ownership is what? Your sub-center you are given with 5,000 population, or a primary health center which is 30,000 population your coverage. Whatever responsibility, take a ownership. That is what morning panelists were telling. Community ownership, you need to develop that ownership in your work. Then innovating on new products and ideas. See, a lot of things, innovation happens in the clinical sector, but public health sector, a lot of things need to happen. Yesterday we were talking about disaster and other things. I think nurses are the people who come in the triaging, and the doctors, as a team, as doctors and nurses, could find, we are the always coastal region of the country, in the always flood hit states, we are Tamil Nadu. We need to develop a toolkit and we put it up. If you see in most of the other parts of the country, the nurses have developed kits on this. When the disaster happened, take out that kit. Everything will be there as a Xerox copy, whatever document and everything. So think innovatively and do something in that way. So until you do it, and it will not happen. And developing the trust in working place. So see, the first point of contact in my first slide itself, I said, the nurses are the first point of contact. So you are the ambassador for your own profession. So that means in the public health sector, the village health nurse, you are the first point of contact. So you are the ownership, you have the ownership of that community. That 5,000 population, that households, they trust you whatever you say. So you need to develop the trust with the people wherever you are posted, wherever you are working. So what is the nursing empowerment is instilling about granting decision-making, authority, creating opportunity. So simply giving, you don't say that I have given you a power, I have empowered you. But empowerment is nothing but you need to give her the freedom to make decision, give her the authority, and give her an opportunity. So that will give the nursing empowerment. So what is empowerment is? As I told you earlier itself, it is taking ownership, working independently towards the common goal. See, you all know we need to bring down the MMR rate, IMR rate, and other lot of indicators is given to you. So as I told you, you need to work as a team so that we achieve the common goal. Understanding why, so that guidelines can be applied. Sometimes you need to maintain the at the primary health center level, the vaccines ILR to be maintained at some point of a degree of centigrade, and when it is transporting, how much it need to be maintained. All that you need to understand the guidelines, why I am doing this, why I am applying this, and weighing the impact of the decision affected by the stakeholders. Maybe because of your mistake, something happened, something to a patient or to a public. Why it has happened? You need to give a retrospection. Based on that, you make your decision, then you will really get a commitment towards whatever you are talking about. So what is not empowerment? See, most of the time people say, just throwing the rule book, oh, you don't know that this is the rule, this is the act to be, and bypassing somebody, you don't give an opportunity for them to explain themselves or doing the fun parts, you take up somebody else's job and doing it, or unilaterally, மேலே சொல்கிறது மட்டும் தான் நான் செய்வேன், சைடில் இருக்க டீம் சொல்கிறதெல்லாம் கேட்க மாட்டேன். Unilaterally you take the decision. That is all non-empowerment scenarios. Why is it needed empowerment? World is becoming a global village. You all agree with me. Today we are connected. If you want, I don't know whether it is relayed in the virtual media through online. throughout the world can watch this program. So, and likewise, your Android mobile, the globe is within you. So it has become a global village. Employee motivation and retention is needed. And one more thing, what I find is with the younger generation of nurses who coming in, see, my father's fathers, they just want a job for food alone, to live. My mom and dad, they thought they should work hard, be faithful to the organization so that I get a good life of a better opportunity. Now my generation, I got a better opportunity and I'm having in a good position, and not only me, everybody I'm talking about. What about my next generation? They want quality of life. So that quality, whether we are giving, whether it could be a community or it could be wherever they are coming to a hospital, tertiary care, or a secondary care level, or the primary care level. That is our responsibility. We need to think about it. Employee to employer bonding, that is more important. See, you are working in the government and you need to have that faith, oh, government is paying me for this. The tax money from my public I am getting as a salary. I need to commit myself and do the best work what is given to me. See, the commitment, nobody will come and give you, my dear nurses. The commitment you have to take, the ownership you have to take, it's all has to come within. Then more connected to an organizational goal. So wherever you are working, whether it is a public health side or a primary health center or a sub-center, what is your objective of that particular center? What is the problem around the area? You need to think about it. And you need to definitely look upon personal and professional growth. That is very, very important for a nurse to empower herself, and easy to attain real-time effectiveness. So that today's world, global village, definitely you all can achieve many more, because we could see, I don't know how many of you seen last year Astra Award. I don't know how many of you seen Astra Award given by the Dubai Authority of Health Sciences. African lady who's just a multi-purpose health worker. She has done a tremendous work in her community, educating them on, I don't know whether, here we don't have much of a practice on that. She educates about the female, they mutate the female genitalia because they don't want others, the women should go away. So she has done a special work on that, and she has got $1 million for that prize, but is globally only one award which was awarded to that woman. So it is not, don't think I'm a VHN, I'm just a ANM, or I'm a nurse. Don't think I'm chumma beru, and chumma nurse. No, I say proudly, I am a nurse. Okay, I am a VHN. Be proud of yourself first. That passion will make you to grow. அதுதான் உங்களுக்கு ரொம்ப முக்கியம். உங்க ஜாபை நேசிக்க கத்துக்குங்க. எவ்வளவுதான் ஓவர்லோட் கொடுத்தாலும் ஒரு நாள் உங்க டாக்டரோ உங்களோட டிடியோ திரும்பி பார்ப்பாங்க நீங்க பண்ற வர்க்குக்கு. யாரும் நமக்கு அப்ரிசியேஷன் தேவையில்லை. You need to work on your own. And three factors of empowerment is direction, challenge, and autonomy. So direction is sufficient, instruction is given confidence. So before you employ a MLHP or a VHN in that particular setup, what is our responsibility? Clear-cut job roles to be given, non-nursing role to be taken away. If you give that, then she will do in a very correct way. Then challenge, what is a challenge? An element of a stretch that will bring out creativity and satisfaction on completion. If, for example, you are given such a challenging sub-center to one VHN or a MLHP person, and they have to take it as a challenge, you should not always critically supervise them. Give them the liberty to do the work so that they will come out with a lot of ideas. If you could see, yesterday also I mentioned in northeastern part of area, during COVID time, the community health officer, we call it MLHP here, their community health officer, their designation is, and there those nurses, they have really traveled up hills and they have conducted yoga session after COVID patients, after the COVID infection, they have put up nice screens, how they isolated little far away from them. they beautifully done those things. I could, even is still available in Government of India Health and Family Welfare website. Lot of creativity nurses have done. You know, nursing profession is a women profession. We are always multitasking, multi-talented women, right? Because நமக்கு ஒரே நேரத்துல சாதம் வேகுதான்னு பார்க்க தெரியும், குழந்தை அழுதான்னு பார்க்க தெரியும், வீட்ல கதவு தட்டிட்டானா, கேஸ்காரன் வந்துட்டான்னு பார்க்க தெரியும், அட்மினிஸ்ட்ரேஷன் லேப்டாப்ல என்னன்னு பார்க்க தெரியும், right? Women are multitasker and you can do wonderful things if you could apply this, okay? Then autonomy and support. Confident that there is a further help and direction available if needed. See, sometimes everybody will not have that autonomy. You need a little support, for which you are the higher officials who are sitting on your sector. They need to encourage you. For example, maybe it may be your CHN, or it may be your MCHO, or your principal of a training school can give little support to them so that they will develop much more autonomy. So empowerment, regulations. What is regulation here? Persons, public, integrity, and professional responsibility and accountability. Persons here, it means patients and colleagues. Here I will take into a public health concept. And public and professional means with the employer. And the integrity in consciousness, how you are working, and professional relationship. These four things which gives the empowerment. So what is nursing regulation when it comes to? It's a regulatory body like every state council which is regulated by the independent states of the country. The nursing, you can see 3 regulatory bodies here. One is International Agency, International Council of Nurses. You might have seen while they were reading my CV, they said, I'm the regulator for Southeast Asia International Confederation of a Midwife, right? So what am I doing there? I am representing India there, Southeast Asia. We give inputs, you know, many times they, you know, one of the meeting they were telling from ICM, International Confederation of Midwife, there is no midwives in India, they were telling. How can you say there is no midwife in India? We have a licensed, registered midwife, and my nurses are being appointed as a staff nurse. Unfortunately, they are not appointed as a midwives. That is the problem. They conduct delivery, they do everything at the primary health center level. Even if I go to corporation, the VHN will, the ANMs are doing fantastic deliveries over there, right? So they were talking, so such things, inputs when I gave, they were surprised. And also one thing in the last regulatory meeting, when we had it in the Zoom, and they were telling like there is no independent practice which never prevailed in the southeastern part. I said no, you can see my council act, which is the Premier Nursing Council Act, which was established in 1926. In another 2 years, 3 years, we are going to celebrate 100 years. Is the first piece of legislation which was brought in for nursing. A piece of legislation has been brought in. There, who is a midwife? So beautifully given. Who is a midwife? How she has to set up a clinic, how she has to report to the birth and death register office. Till date, it is alive. I want to tell you everybody that. So that much premier legendary council we have. And the same way, and then state medical health, that is universities. Each state has a universities. So how can you bring it these regulatory bodies? When you talk about practicing Nursing Practice Act, I don't know how many of you seen the scope of practice for midwives. It is published by Government of India in 2018. I don't know how many of you seen. There, every tertiary hospital should have 2 units. One is midwife-led unit, MLCU, then obstetrician-led unit. Now they knew the importance of midwife. The Government of India is bouncing back with the course with the nurse midwifery practitioner, and our government has sent 6 nurses from public health side to undergo nurse midwifery practitioner in midwifery educator. We are going to roll out soon with the other 30 people training, where she can have an independent liberty to conduct all normal. That means you will ask me, so even now, but this will give a visibility to the society. This delivery is conducted by a normal delivery by a midwife, right? A midwifery practitioner. And she is the one first point of contact if any complicated high-risk labor which will be conducted by the physicians. This will give really a workload balance, because doctors are really overloaded and we have a shortage of doctors. Morning, he was telling 757 doctors over 1,000 population, international figure and all that. But this will definitely, if we delegate, decentralize your work, then there will be a great change will happen in the quality of care. I'll finish it off. Okay, ways for nurses empowerment, that is, you have to encourage, identify and involve and enable. And these are all the characteristics. I'm not going to much. Nursing excellence implement, which could be done only by these sort of things. Nursing leadership, work environment by the nurses, what you are providing, a quality environment, and a professional development you should give her, and the nursing practice rules, and a patient care. Here I can convert it to the public care, which involves the patient care. So how do you do this? A great leaders, a great structure, a great nurses, so that you could get a great knowledge, so that you will get a great outcome. So pricing for nursing service. நீங்க பண்ற வேலைக்கு pricing இருக்கா? இல்ல. No yardstick, because no practice act. So நம்ம பண்ற வேலைக்கு எவ்வளோன்னு சொல்ல முடியாது. But we are following in India repair maintenance model. Repair வந்தா மட்டும் அட்டெண்ட் பண்ணுவோம். மெயின்டெனன்ஸ்க்கு நமக்கு பட்ஜெட் இல்ல. Right? So that is why no money for maintenance. So that is why staffing shortage எல்லாமே நம்ம பேசுறோம். So what are all the barriers to accept the nurse in a leadership role? கேட்டிங்கன்னா, nurses are not empowered. As I told you, many points I said already. We lack in voicing out in a single voice, lack of understanding about the health policy. இன்னைக்கு சொன்னாங்க, காலையில எல்லாரும் பேசினாங்க, நமக்கு public health act பத்தி தெரியணும்னு. Not only for doctors, every nurse should know. You are the one going to accompany. MO will come and go. We know how many hours he will set, but you are the person, you should know what to guide him. And lack of term vision, no vision. Nursing focus on acute care partner is lacking. Lack of opportunities, varying educational levels are there, and lack of accessible leadership courses. Right? So I will come to the study. I told you initially, the National Health Resource Center, which TNHSRP, like the same way they did the study, and they came out with these, again, 3 major items. One is, nurses need to give education and development and leadership role, and regulation to be strengthened, and deployment and utilization should be done in a proper way. So with these few questions for thought, unga ellarkum indha kelvi kettu na mudikiren. Do we have a nursing shortage really in the country? Are we making the best use of nursing workforce? Why do those scope of practice of law stand, and how do you use nurse practitioner role is evolving? What competencies are most important for nursing going forward? What are the biggest challenges affecting the nursing profession today? What must hospital and health system leaders to do address these changes? இதெல்லாம் உங்க கேள்வி, உங்களோட கேட்டுட்டு போறேன் நானே. நீங்க யோசிக்கணும். நீங்க எல்லாம் உங்களுக்கு போகும்போது evidence based practice you need to put it into action. Then these few questions will come. So the future, my dear nurses, here I am addressing my own fraternity. My dear nurses, the prediction of the future is easy, or inventing the future is easy. உங்க சாய்ஸ் நீங்க தான். Whether you want to predict the future, இல்ல நீங்களே உங்களுக்கு ஒரு opportunity உருவாக்கி போறீங்களா? So inventing is easy, so you decide which one is good for you. As the great person, our Gandhiji said, we must become the change what we want to see. With that note, I will conclude, because I look for my profession, what the change I wanted, and I think with this given time, I could, at least a little bit of mustard level, I could have instilled in your mind. So any question and comments and thoughts, you are welcome. If not, thank you for stopping by. Thank you.
Any questions? Any questions from the audience? From the back benches? Okay. Okay, ma'am. Thank you, ma'am, for a motivating speech. Actually, ma'am, I've clearly explained what empowerment actually is, and what are the responsibilities, and how nurses should take the ownership to be an achiever and to reach the leadership role. And definitely, nurses are the inevitable part of our public health system. Thank you, ma'am. And I request our organizing secretary and our additional director, Dr. Somasundaram sir, to hand over the memento as a token of gratitude. Thank you, ma'am. So the next session is a panel discussion on COVID-19 spectrum and continuing challenges in achieving sustainable development goals. And I request all the delegates to join me in welcoming Dr. Harivansh Chopra, who is the chair cum moderator for this panel discussion. So please. And sir is the president of IAPSM India chapter, and before that he was the IAPSM president UP UK for the year 21-22, and he had been the scientific secretary of IAPSM UP UK conference 2008, and sir has organized many workshops, CME on malnutrition, tuberculosis, HIV AIDS, BFHI, and organized socio-cultural festivals for more than 2 decades, and awards like he had received Lifetime Achievement Award for exemplary work in community medicine, UP UK Con 2022, and Visionary Leadership Award in Southeast Asia M Health Summit, and Best Paper by a Teacher in UP UK State IAPSM Conference. And with regard to the publications, he has published more than 100 publications in international and national journals with research gate score of 23, HI with more than 500 citations, and he has wrote a book titled Dosage of Common Drugs in Pediatrics. So we welcome you, sir. And now I welcome our panel members. Dr. Sitanshu Shekarkar, Professor and Head Preventive and Social Medicine, JIPMER. So about sir before joining JIPMER in February 2010, he had served in the WHO Country Office for India as National Consultant in NCD and Mental Health Cluster and Population Council, New Delhi as Program Officer. He is also a Nehru Fulbright Advanced Professional Excellence Fellow for 2016-17 at the Institute of Global Health, University of Southern California, Los Angeles. And he has 16 years of teaching and research experience. He played a significant role in starting an MPH course in JIPMER, and he was instrumental in the establishment of JIPMER International School of Public Health. He has conducted many workshops on research methodology, epidemiology and biostatistics, and scientific writing throughout India. And he leads the Health Technology Assessment Resource Center at JIPMER since 2019. And he has 160 research publications. And his areas of interest include health technology assessment, medical education, tobacco control, and chronic respiratory disease, chronic diseases prevention. Welcome you, sir. And next, our panel member is Dr. K. Surendran, sir, very familiar person for all. He is a survival medical officer, WHO. And sir has worked as assistant professor in Sri Ramachandra Medical College, Chennai, 1995 to 98. And he is now the surveillance medical officer at WHO and since 1999. And sir was awarded with Tamil Nadu Government Best Doctors Award for the year 2014. And sir has published books like in the textbook of Pediatric Infectious Diseases, Vaccine Preventable Diseases in India. And he wrote the chapter Polio Endgame Global and National Perspectives in the IAP textbook of Pediatrics. And he has wrote chapters on adverse events following immunization and disease surveillance in the Handbook of Adolescent and Adult Immunization 2013, and a chapter on polio endgame global and national perspective in the IAP textbook of Pediatrics 2016. And next, I take the privilege to invite our another panel member, the organizing secretary, Dr. Somasundaram sir. And sir joined service as Assistant Professor of Community Medicine in Chengalpet Medical College in 1995. He worked in various cadres as Assistant Professor, Health Officer, Deputy Director, and Joint Director. Currently, he is serving as the Director, Head Institute of Community Medicine, Madras Medical College. And he is the editor of the Tamil Nadu Journal on Public Health and Medical Research from the Office of Directorate of Public Health and Preventive Medicine. And he is the Member Secretary of Institutional Ethics Committee of our Directorate. And he is the Chief Editor of our DPH newsletter. And sir has numerous publications. It will take time to read all the publications. Welcome you, sir. Yes, sir. Over to the chair, sir.
Hello. Well, good afternoon, everyone. Vanakkam. Well, this is an afternoon session, and I have been given the task to chair this important panel discussion on COVID-19 and COVID-19 spectrum and continuing challenges in achieving SDGs. For last 2 years or so, COVID has played havoc in the world. And COVID not only played havoc, it disrupted everything related to human life. And not only disrupted, it destroyed many families, including the family of healthcare providers. A lot of healthcare providers, they lost their lives. And I think it is important when we are having this session to have a recap of what is COVID, what are the epidemiological facts of COVID, and was it managed, handled in a scientific, evidence-based manner, or something more to it, or what was the role, or still the role of media in COVID. And as far as the health is concerned, because every country is committed to achieve SDG by 2030, so what challenges it has posed and what are the further challenges which we will be facing in achieving the goals which are there to be achieved by 2030. I will not go much into the detail, but there are few basic epidemiological facts which should be clear when we talk of spectrum of COVID. As all of us know that approximately 40% cases of COVID are asymptomatic, 40% are mild, and only 20% cases, they go into the category of moderate to severe. And why I said media? Because media created a hype in the mind of the people that if you suffer from COVID, you are going to die. And that instilled a fear in the mind of not only healthcare providers, but also the politicians. But media was asking questions every day. What are you doing for COVID? What are you doing for COVID? And what is your response? And the response then, the politicians, public health is nothing but politics at large scale, because ultimately, whatsoever you want to achieve and do in public health has to come from the politics, because the money is there with the politicians. And if they are sensitized, they will take actions to mitigate the suffering of the people. So going forward, we saw lockdowns, and still we are seeing lockdown. COVID started from China, and still it is creating havoc in China. COVID is still creating problem in US. Of course, in India, the story is different, and there are so many mysteries regarding COVID, why it has happened. People thought that, yes, we are taking precautions, we are using vaccines, and then probably the COVID is being under control. But there were few epidemiological facts. My dear ladies and gentlemen, I want to remind you that Lancet said in March 2021 that COVID is airborne. And those of you who are following my YouTube channel, when I got repeated requests, I took 4 lectures on YouTube on COVID, and probably in September 2020, based on the epidemiological fact, we said it is an airborne infection because the size of the virus is less than 5 micron. So these are the basic epidemiological facts on which the scientific actions are to be taken. And similar stories with the mask, with the lockdown. When there is a new infection in the community and there is no immunity, then sooner or later, if you don't have a vaccine which can prevent infection, mind it, that is a very important point. The vaccine we have till date today, they do decrease the severity, but it does not prevent the occurrence of infection. That is another scientific point which has to be kept in mind when we are trying to manage COVID. So going forward, we saw lockdowns, we saw so many interventions, so many drugs, hydroxychloroquine, ivermectin, and so on and so forth. And so many guidelines were made, change, Disaster Act was imposed, and you know the story. And there are proponents and opponents of every action which government take in this kind of a situation. And yes, hindsight is the best side, we can say yes. But then there was a lot of collateral damage. Because what happened? Only few hospitals were designated as COVID hospital, and you never knew which patient who is suffering from a cardiovascular morbidity is COVID positive or not. So there was a lot of collateral damage, and it disrupted the healthcare delivery system throughout the country. Tamil Nadu is an excellent state, and I would like to congratulate the organizer for organizing a wonderful centenary conference here, a public health conference, and giving us opportunity to share our views on this point. Yes, and when I was going through the SDG index, now let us come down to the Sustainable Development Goals, and the SDG index, which is prepared by the Government of India, having all the 17 goals into it. I'm proud to say Tamil Nadu is having a score of 74 along with Himachal Pradesh, and only Kerala is having 75 with 1 point ahead. So big round of applause to the people of Tamil Nadu for taking it forward, but still the challenges are there, and those challenges, how we are going to face those challenges, how we are going to overcome those challenges. So that is all in this panel we are going to talk about. Of course, we have seen a lot of panel discussions since morning, and we have seen a lot of discussions on various topics that we will try to reflect when we try to conclude the session. But this will be a panel discussion, not a symposium. But I can say it will be a panel come symposium, because we are going to start our panel discussion with a presentation. With a presentation which will be done by Professor Shekhar, and he will be presenting to you the hurdles which are there due to COVID in achieving the SDG. So kindly, Dr. Shekhar, your time starts, and I hope you will be able to finish in 5 minutes, and then we'll be moving to our panel discussion. A big round of applause to Professor Shekhar.
Thank you. Can I have the slides, please? Thank you. Yes. So today morning, 9 o'clock, when we reached in this hall was overflowing, right? There are no seats available. So till the time we reached 3 o'clock, there is attrition. So as an epidemiologist, we call it as dropouts in cohort studies. So this is what is going to happen next. At 5 o'clock, we'll see less number of people, but that's okay. We have to live with that. So with that, let me start. The respected chair and my co-panelists and dignitaries of the dais, thank you so much for being here, and thank you so much for your interest to listen to SDG and COVID-19, what is happening. So my job is to talk about how the SDGs or the COVID-19 has impacted SDG. So I'll be talking about 4 main points. So simple points, common sense, but as you know, common sense is very uncommon. The first one is, when you look at what are SDGs, people of public health, the students of public health must know about SDG because it is the successor of MDG, the Millennium Development Goals. It started in September 2015, and it was to be achieved by 2030, where 17 goals and 169 SDG targets were formulated. All the 192 countries under the UN body, they came together and told that we have to do this. So you can see the goals there, very colorful, very bright pictures there. But when you go to the analysis of SDG goals, we cannot separate the goals from one another. So the pillars of analysis or the presentation that UNDP and other agencies have come up are 5 Ps. It starts with people, prosperity, planet, peace, and partnership. But today, because we cannot cover everything, we are going to talk about the first pillar, that is the people's pillar, which includes the goal from 1 to 6. specifically on goal number 3, which deals with well-being and health. So, sir has already done my task very easy about talking about COVID-19. It started in the late part of 2019 in India. We saw it in the early part of 2020. 645 million cases, 44 million cases in India, and 645 million cases globally. The deaths are already there. So it created a lot of changes in the health system, the way we live our life, as rightly put by Professor Chopra, saying that it created havoc in the lives of people. So now let's come back to SDG and COVID-19. So there is a report from UNDP published in 2021. It said, if you look at 3 scenarios, the scenario 1, where there is no COVID, just imagine there is no COVID. Then second scenario, where there is COVID, which contributed to the loss of lives, the damage, the economic loss, and everything as per the normal route. And the third one is high damage probability. So many countries did not report it properly. So there is another assumption that was taken. Suppose let's imagine that around 8% of the GDP was lost. Another 20% of lives were lost because of COVID. That's the third scenario of high damage. So when we look at these indicators and we try to look at those SDG goals based on the 3 scenarios, what do we find? So do you think that if COVID was not there, had we been reaching the SDG goals by 2030? I'm afraid it is not the truth. The problem was, even if in the absence of COVID also, you can see around 60 to 70% of the countries would have reached the SDG goals of the people's point that I told you from SDG 1 to 6 in that particular thing. Maximum going by the maternal mortality, under 5 mortality, neonatal mortality, and primary education completion. So that's the situation. In the COVID, which is represented in the green bar, has pulled down these targets little or goals little below, but it has not contributed a lot. So we have not reached there earlier. The third phase is high damage. When you consider that there is a lot of damage, 6 to 8% of economy GDP was lost, then there is or 10% fall from the particular thing. So this is a very interesting report for people who are interested to read about this particular SDG and impact of COVID. So coming to the fourth point, so how did COVID affect us? So there are 2 pathways that was discussed. The first one being were limited. The second part came to the school closure. Because of the COVID, school closure happened, dropouts, the education status was affected. The third one is regarding the food chain disruption because of the lockdown and other non-pharmacological measures that was taken. Then next you come to the economic activities, the tourism industry, so many other things happened. Unemployment raised, the rates went up. Then the last one is about the planet, the sky blue color there. When so the air quality improved, that's a positive thing because people did not come out. But the other thing what happened is the single-use plastic, the biomedical waste that was generated because of plastic was very high because everybody started wearing the PPE. So that was the problem. So these are the 5 pathways that was discussed in this report beautifully, talking about how do you analyze the fact that COVID has impacted the SDG goals. And coming to the last slide, there is another situation where people talk that if SDG push is given, that means what? All the collaboratives, the international agencies and the partnership developed, and they started focusing on SDG. If you can look at the Astor graph, you will see still in 2030, we will not be able to reach even if with the SDG push. We will be reaching around 60 to 70%, and that is what we are going to achieve. So now people are talking about that let's revisit our deadline or timeline, whether the 2030 is an optimistic timeline of achieving SDG goals, or we should try to move it a little further, and what are the other indicators that we should look upon. So this is in nutshell about the SDG, the presentation, because we cannot cover everything in 5 to 6 minutes. I thought I'll try to limit my presentation by giving the highlighted points here, and any other questions that we will be able to take at the end. Thank you so much for your patient listening. Thank you so much.
Thank you, Dr. Shekhar, and telling us the various combinations and permutations. If the COVID would have happened, then what would have been the scenario? If the COVID would not be there, then what would have been the scenario? So that highlights another important aspect which everybody is talking about, but then action is not there. So my next question is to my co-panelist and the organizing secretary, who has vast experience of working in Tamil Nadu, and we say Tamil Nadu is having for last 100 years the public health cadre. Sir, what is your take then? What was the effect of COVID as far as the provision of essential healthcare services were concerned in Tamil Nadu?
So, good afternoon, Chairperson and my co-panelists. This is a good opportunity apart from organizing this conference. Having learned from my experience of many crises, disasters, and small epidemics during my tenure in public health for the past, say, 27 years. COVID was one of the worst disasters, as everybody would recognize, and we have not seen earlier Spanish flu or something. We have learnt lessons. But at the same time, we have also learned to rebuild our capacity. And we have also thought about new avenues to negotiate such pandemics. However, when the disaster struck in 2020, we thought it will not affect India. Then we thought it will not affect Tamil Nadu. Then we thought it will not affect Chennai, or every district thought that districts will not affect it. Sometimes we even received from our district collectors or deputy directors of health service that this is not our case, this belongs to the neighboring district. So everybody was not prepared to accept. And despite repeated cautions, in fact, as usual, we were little complacent because we thought the system will automatically take over, but it was not the case. Only after the disaster struck their respective districts or places, then we learnt. So it was an worst case scenario. The day one, we realized and we announced that it is a disaster. Then the routine services were diverted. All the services were stopped. We stopped conducting surgeries. We stopped even conducting emergency surgeries at one point of time. In the history of Tamil Nadu, I think we have now 38, 36 medical colleges. Earlier it was 25 medical colleges. One of the biggest medical colleges, Madras Medical College, Madurai, etc. Even in those medical colleges, we could not conduct surgeries, important surgeries, cardiac surgeries, neurosurgeries, orthopedic surgeries, plastic. For that matter, we cannot list out. Then subsequently, in government hospitals also, we started diverting resources, diverting manpower, diverting infrastructure. We have to count the ventilators. We have to count the volume of oxygen available. And the next phase, as you all know, Delta phase was even worst. So we only concentrated on oxygen, we only concentrated on ventilators, only concentrated on a number of ambulances, number of people, and we started counting the wait list of patients without oxygen outside every hospital. So everybody was thinking about COVID only, and the routine services were, for example, antenatal cases. Mothers were suffering. Somehow we managed. We alternated strategies. That is a separate, parallel, debatable how we came out of that. But initially all the services were disrupted. Everybody, in fact, the reportings, the data, nothing was for routine services was sent wired. So it's very clear that the not only the essential, not only the routine service, but also the essential services. In fact, now we are in the process of, in the era of climate change, zoonotic diseases, we are planning to handle antimicrobial resistance. SDGs try to reform the health system, but COVID tried to deform the system. That is what I will try to say. Now we have to rebuild infrastructure, manpower, equipments, and for known reasons, we cannot learn further lessons. Now we have in the stage of preparation for further such pandemics. This is my stake, sir. Thank you.
Thank you, Dr. Somu. Dr. Surendran, will you like to add something as far as your experiences are concerned?
Good afternoon, sir, and good afternoon, panelists, and all the delegates and people from other international agencies and all the participants. And I think we had been talking at every topic we had been touching on COVID from the morning. I think, no speaker had not talked about COVID in some form or the other. I think it is all known, and one of the services where I'm working with is on vaccine preventable disease surveillance and immunization. That is a mandate for us from the WHO country office. Probably I think it is more appropriate to speak on how it had affected very significantly. Because the first wave, I think it started peaking from June onwards, and then it went up to October. I think that was a period where, in fact, many of the lockdowns, there were people who had a fear of coming to hospitals, people had a fear of taking children to the immunization sessions. So most of the immunizations were delayed. Not that they didn't want to get vaccinated, they feared more of the disease. So there was a delay in vaccinations, and particularly we also saw, I think the first wave put a lot of this, now migrant worker is a big issue globally and nationally. I think it is that crisis we saw people sometimes, I think this is a media coverage, people walking all the way from, say, one state to down to, crossing many states, and the hardship they have to face. The Government of India gave a direction to all the states to ensure their safety, their welfare, their food, shelter, and their transport. I think many of these train services were initiated to carry them, and we saw how it was all overcrowded, both the road transport and as well as rail transport. Now all this had brought the MCH services had a tremendous impact. I think that is a very, very vulnerable, both the maternal and child care. I think the immunization, is one of the critical services got affected. And in fact, in 2000, we had an estimate following this COVID, approximately 30 lakh children went either partially vaccinated or unvaccinated. That was the estimate for the country. In fact, we made, the Government of India with the partners, they made an assessment about state-wise, the data, based on the HMIS data and based on the sessions conducted, immunization outreach sessions. At a normal time, we conduct 1.2 crore outreach sessions per annum in India. And all these sessions, there was a decline. So these were all based on these two parameters, plus immunization coverage of pentavalent 3 coverage was considered. These are the two parameters. And we categorized, and we found there were 7 states had missed a significant number of children. The 7 states included UP, Jharkhand, Maharashtra, Rajasthan, and Assam, and Tamil Nadu also was identified as one. So we had altogether 7 states in this. Then the government gave a direction to all the partner agencies to undertake so that the data becomes unbiased. And we selected 2 districts based on, again, the parameters, based on this immunization coverage, based on this, the sessions conducted, we categorized, and we found 2 districts stood out in Tamil Nadu. That was, one was Viluppuram and another was Tiruvallur. And similarly, the other other 6 states, they had collected 2 more. So altogether, this exercise was done based on certain parameters and norms. And what we found in that whole exercise was, we found in Tamil Nadu there was predominantly a data issue. People were doing vaccination, but entry was missing. Though we found some of the children, we kept a definition of delayed vaccination. Any vaccination that is delayed beyond 4 weeks, 1 month delay, then we call it as a delayed vaccination. So they were all become eligible in our target. And we took up a district, then we took up 2 blocks. From the 2 blocks, we took up 2 PHCs based on these. We had a standard format, and in that exercise, in fact, Tamil Nadu, I was part of the team, and the WHO India and UNICEF, I think Dr. Pooja is around, and she was, then Dr. Orlanand was there, and from UNDP and JSI, all the agencies, including government officials, we all undertook this exercise. Then we selected from the PHC, then we selected a sub-center, then we selected 5 villages randomly based on criteria. And when we made a cluster sampling technique method was adopted, and we found most of them, there was a very, very insignificant data was there. I think when compared to the other states, now you must have heard about this Maharashtra measles outbreak, what you are seeing now. All this is happening because of this left out children, because of this COVID. See, one is, as such, all these high risk areas are not, that is one focus is required, and consistent focus is required. So probably this is where that we need to work on this. I think we should give I think the number of people, here in the hall, number seems to be where, when we started this, the number was a little more, and now it is coming down, and this one. I think I request all participants, the whole exercise is for all participants to benefit. And so please inform your friends to be participative and attend for the next 2 days, so that it becomes useful, something they learn after coming over here. And so now coming to this exercise, I think this was an eye-opener. In Tamil Nadu, we did not find this. That because Tamil Nadu had a good resilience, and we were able to build a system. Soon after this COVID that peak period was over. In fact, the additional sessions, Dr. Shekhar sir, additional director, will recall, we had sent communications to them to conduct additional sessions. In fact, the immunization Wednesdays we had 1 more day on a Friday, and wherever the vacant ANMs or VHN was present, in fact, we had put the additional manpower. So a lot of this exercise was done to ensure that children are being vaccinated. In fact, the NFHS 5 survey, which was conducted in 2000, the reference period was 2020 and 21. In fact, Tamil Nadu was the first largest state in immunization coverage, of fully immunized coverage, with 90%. Can we have a big applause, please? I think that speaks about the resilience of the public health system in Tamil Nadu. And in terms of immunization, in spite of all these hardships, I think the continued focus will be all the urban areas. Now, the Government of India is initiating, with the partner support, urban immunization strengthening. 75 cities have been identified. We have 3 cities, Chennai, Madurai, and Coimbatore has been taken up. And all the partners like JSA has been assigned Chennai, and WHO has been assigned Coimbatore and Madurai as a lead partner to coordinate and bring about this. In addition to this, the traditional high-risk areas, inaccessible areas, hilly areas, border areas, and the migrant sites where children are residing, because they periodically move. So those areas, the continued focus should be there. And what is in Tamil Nadu, I think people who have come from outside, who are outside the system, I think in Tamil Nadu we have a financial benefit scheme that is linked with the immunization. So once they complete 1 year of immunization, and there is some financial incentive that is given. It's called Dr. Muthulakshmi Maternal Benefit Scheme, under which immunization is linked. So we have what is known as a pregnancy infant cohort monitoring system. The moment a child is born, the child is being tracked. So we know whether the child is getting vaccinated. So these are all some mechanisms which as the system has evolved over a period of time. I think when our former Chief Secretary, Ms. Girija Madam, was there, I think it was the PIGMI was initiated during that time long years ago. And so these are all some of the system where we are able to ensure immunization. Though there was some shortcomings in that peak period, there was some disruption, all our energy got diverted in COVID management. still we were able to bounce back and we are very comfortable with immunization. Then one of the other important things the Government of India does is this Mission Indradhanush, intensified Mission Indradhanush. I think that is a periodic exercise we undertake, and even during this COVID, I think the COVID peak was over in 2021, and then we conducted in 2021 2 rounds, that is in February and March. We conducted 2 rounds. We identified all those children who were unvaccinated and who were partially vaccinated, and the target age group for that survey, head count survey, was up to 5 years. And we also had pregnant mothers included in the survey. I think that is the routine practice the Government of India does. And Mission Indradhanush is a flagship program of Government of India. And in fact, we found very few children were very few found in few districts, and we targeted those districts, and then we were able to successfully complete. And again in 2022, we had conducted 4 rounds as per the Government of India directions. And in fact, this one more disease which we have talked about, where I had also been working with long, is the polio program. And polio program, the mass campaign, now earlier we used to conduct before 2019 2 rounds of pulse polio campaign, the intensified pulse polio or NIDs, National Immunization Days. This is again was not interrupted. Even during this COVID, when it was at a low level, we conducted a mass campaign. We issued COVID protocols so that the number of children...
kindly conclude in 1 minute. Kindly conclude in 1 minute.
1 minute, okay. So I think this COVID protocols were issued, and we conducted the mass campaign successfully. So I think these were in generic about these immunizations, these exercise of conducting mass campaigns, Mission Indradhanush, all this we implemented. We ensured in Tamil Nadu no children were going unvaccinated or partially vaccinated. So the full immunization, I think in fact the target should be near about 100% is what we aim. And measles rubella elimination is in the cards. I think yesterday they had released the book Roadmap to Measles and Rubella Elimination. By December 2023 is a national target. I think the DPH last night was telling in Tamil Nadu, I think we should make it by March 2023. So we will all work towards that. I think I'll join for further discussion. Thank you.
Thank you. Thank you, sir, for your experiences as far as the routine immunization and the pulse polio immunization is concerned. And as we all know, public health experts, no pandemic can be managed in the hospital. Because if you try to manage pandemic in hospitals, you will have the situation, there will be a lot of collateral damages. And as predicted, and since morning we have been listening to, because of the various disruptions, climate change, and all other things, and zoonotic diseases are making a comeback. And it is expected that it is not the only pandemic which will happen. The pandemic is going to happen again. So what are the systematic changes which are required to tackle future pandemics as far as resilience of the health system is concerned? Dr. Shekhar, what is your thoughts? And I'll give you 2 minutes on it, 2 minutes to each panelist, so that we can finish it in time.
Thank you so much for your question, sir. This is the question that we are all debating and trying to think. This is not going to be our last pandemic. Certainly not. And we have to live with these pandemics in future. So what should we do? The first thing is, probably we should try to build capacity in our health system so that we identify this pandemic before it becomes a pandemic. So everything starts with small. Because we tend to ignore this, slowly the small becomes big. And then the big becomes large, and large becomes largest. So this is how it moves. So if our health system is in a position to identify and take the requisite action at that point of time, I think we can curtail the pandemic. So first point is, we should build capacity in our health system to identify this. Now, capacity building is a very broad term, very vague term. People don't understand it properly. So we need to debate a little more into that. What is the capacity building in that? So one is, I say that people should be trained or should be made aware about the warning sign. The more number of cases reported, what should we do? What should be the action point taken? So once they have started suspecting those cases, there should be another layer where people should be able to identify those. That means the lab support should also be there. So all these things are a part of our surveillance system. So in nutshell, if you ask me a single point, I'll say that we should try to strengthen our surveillance system, which will try to help us in identifying and taking actions against the future pandemics. I'll stop here. Let's hear from others because in the interest of time, I'll stop here. Thank you so much.
Dr. Somu, your thoughts.
First of all, I agree with the disease surveillance. As he rightly pointed out, that before it comes, and the known proverb, prevention is better than cure. And we cannot afford to experience one more pandemic. So surveillance in all respects, in hospitals, in community-based surveillance, the lab-based surveillance, strengthening our IHIP. So now IDSP is IHIP now, and we have to, now people are planning to revisit IHIP, and slowly it's building up, and having all the facilities, particularly in states like Tamil Nadu, Maharashtra, Karnataka, Kerala. The system is strong relatively, but we are not put them fully into use. So people are still not have completeness, timeliness, everything. So IHIP should be a platform to strengthen the surveillance. The second one is mitigation. Mitigation is one, the preparedness, the earlier preparedness with which we mitigate. The other one is after the crisis. So we should be prepared for the mitigation. We should be prepared for apportioning budget earlier. So every year we should try to apportion some budget for anticipated pandemic. So now H1N1 is below the first layer. It's not, but we are planning to expand, or we should plan for expansion of what shall I say, the services without losing focus. The strategies are there. We have to expand the strategies, but we should not lose focus. The third one is whatever is available. This is state specific. We cannot say with Tamil Nadu, I cannot say with Tamil Nadu experience, I cannot say for the whole country. So we have northeastern states, low performing states. So different states have to formulate certain areas, and the central government has to support us. We have a NHM platform, everything. The third one is very carefully, even during those disasters, pandemics, we see to that the out-of-pocket expenditure for the public should not be become high. The insurance, everything should take care of that. So this is my idea, sir.
Thank you, and very well said. And since morning we are listening, health being a state subject, so there cannot be a uniform policy for all the states. The states have to take their own action plan, and Dr. Shekhar has again highlighted the importance of the good surveillance system. And of course, when we are talking of surveillance system, it is again important to understand that we have to strengthen the primary healthcare system. And more important than that is the data which we are collecting. What kind of data is being collected? No collection of data is something which I will welcome in place of data collection which is not correct, which is not of high quality. Why I'm saying so? I was attending another conference where I'm talking about NHFS 5. And what is the status of NFHS 5? Where they said that the low birth weight is 18% in India as per NFHS 5, but this low birth weight estimation is based on mother's perception, not on the birth weight. So if NFHS can do this, so you can imagine, that is why I say, if there is no data, it is good. But if the data is faulty and it is of not of quality, because then it will create more problems than it will solve the problems. Because on one hand, you are saying we are not taking the birth weight of the child, and we are estimating that low birth weight is as per the perception of the mother. So this kind of thing, again, should not be there. That is again important. So what are your 2 points, sir, for the future preparedness? 2 points.
One is involvement of private sector. Now, private sector in healthcare is becoming very, very important, more so in urban areas. COVID management, the state government, in fact, they took over all the beds in private hospital, and it was the allocation was coming from the government for COVID, particularly in the second wave. In fact, we were taken up by surprise with the number of patients and the ventilator bed requirements, and with the panic reaction, whoever could afford, they were all getting admitted in tertiary care institutions. But then they did not truly require. So this was observed, then the state made a policy and networked with them. They brought them all under one umbrella, and then so probably involving this private sector will be one key thing. And second, again, this COVID I think is still not over. COVID is still lying low. So I think as a research, the state has initiated genomic sequencing of COVID virus is happening now. Because anytime the virus has got a propensity to undergo mutation, which is all of us are aware. So this is one research component should also be integral part of this. I think you asked me only 2 points. I think I'll stop here.
Yeah. Thank you. Thank you. Thank you. A round of applause for our panelist. So we have to understand the health system which works in India. It is not only the government health system which works. The majority of the people, as far as the secondary and the tertiary care, they are taken care by the private sector. And the private sector involvement in health cannot be denied. Neither it can be denied. Rather, now time has come that in spite of working in silos, we all have to work together, whether we are in the government, whether we are in the development sector, whether we are in the professional association, whether we are in the medical colleges, whether we are in the health system. Because unless we come together, we will not be able to make a dent as far as attainment of goals are concerned. And I agree with Dr. Shekhar what he said. We started with health for all, could not achieve, went to Millennium Development Goals. And of course, yes, but then if we don't fix some targets and goals, then we don't accelerate the process of achieving them. So that is again important. So with this, we will be finishing with our panelists, and I'll be now opening the session for the audience. If you have any questions, kindly ask, because it's a panel discussion. Your queries are welcome.
The whole audience, I am the Governor of Chess Council, South, sir. And we are 5 members who are involving almost all over India. And we only designed for in the tertiary care services, mild, moderate, severe, critical, how to do it, that can be done even by the VHM. It has been given not for the government, but for the only one man, Dr. Radhakrishnan, who is the first man who has come for us out of the AC room to the streets, and he is the first man with the family has been acquired the corona, but he has not come to any corporates, but he come to the King Institute. Please applaud that. In whole India, our person has been, believe our government hospital, and he has been in the King Institute. At that time, night, we have been designed the mild, moderate, critical, mild, moderate, severe, and critical. I request the government, kindly don't open this notes. That is very simple. It has got only 15 points. Very easy, just like what you do the protocol for ordinary diarrhea. So if it has been gone out, there will be a challenge for oxygen. And there will be a challenge for immunomodulators, because we don't have any good antivirals. Because the second time the Delta, we have got from the infection to the dead end of ARDS is only 72 hours. I think sir has been known. It is because the genome, we don't have the time, sir. So at that time, we have done the Sepsivac IV. Sepsivac is Mycobacterium W, sir. It has been designed by our government. It has been identified in 1959 by the Tamil Nadu for the coronavirus for the dogs. And it has been given by the Cadila, and it has been supported by our Prime Minister and President. And it has not been it has been taken as the last protocol for these severe and critical case only. But at that time, we have identified, we put 0.1 ml on the right arm and 0.1 ml of the left arm for 15 days. After 21 days, we ourselves, there are almost 3,000 doctor family have put that, and we have been identified, there is no ARDS, sir. There is no ARDS, sir. I have been requested the government, as sir has been intensively doing the, what he has said is very correct, sir. We are the persons, all the 3,000 doctors, we have not closed from day one until it has been in August 15th. We have been almost closed, and CM has been decided 2.3 lakhs only, we have to get the thing.
Thank you, sir.
Sir,
Kindly be short.
That's why, sir.
Yeah.
Next COVID is going to come, sir. Nobody can stop it. But if it is there, if the ARDS has come, we don't have, yes, sir, yeah, it will be, sir. We must wait, because Wuhan has been already stopped on 40,000.
Sir, please
Sir,
ask your
that's
question.
why my question is, how many G5 ventilators? Because IntelliVent and IntelliSync only can only stop that ARDS, sir, in our research. We can't do with the ordinary ventilators, sir. We don't have any G5 ventilators adequate in Tamil Nadu, not only in Tamil Nadu, in the whole India, sir. And another thing, we have to include Sepsivac as an immunomodulator preventive, sir. That's my request.
Thank you. Thank you. Any other questions?
Sir, it's not a question, it's just a comment to the discussion what is going on. One of the important thing is a behavioral change that is expected from the community, because whenever these infectious or outbreaks are there, they think everything government or the health system will provide. I think it's high time that we give the correct message to the community. So we have to involve the community in all this business. Otherwise, in the long term, unless there's a strong behavioral change from the community, especially airborne diseases like that, I can control my water, what I drink, the food, what I eat, but I can't control the air which we breathe. So we are talking about climate change, everything. So the airborne infection is going to be the future in this millennium. So I think we have to involve the press and media and social media in this process. That's my small suggestion.
Thank you. Thank you very much. I said that, again, the pandemics cannot be managed in the hospital. They have to be managed in the communities, and community empowerment and awareness and education is, again, very, very important. And we have to, when I said we have to join hand, it means not only the health professionals, but all the people in other sector as well as the population. Because until and unless we all come together, we will not be able to manage any of the pandemic. This is for sure. This is for granted. So if there are no more questions, I'll thank my panelists who are giving us so good insight. Dr. Shekhar telling us what would have been the impact on SDG if COVID would not have been there, or if COVID would have been there. And Dr. Somu accepting that, yes, COVID created a havoc and even the routine surgeries were cancelled. So one can imagine that if we are going to concentrate only on one particular problem, and I said in the beginning, that is the media, which created this particular havoc in the mind of the politicians, and everything then was coming from the top, and was coming from the top, and then it created much more problems than to solve the problem. This is my personal opinion. Of course, there will be people who will be having the different opinion, and then Dr. Sunindran telling us about the routine immunization services and other things. So thank you very much for a patient hearing, and I think the panel deserve a big round of applause. Thank you. Thank you.
Thank you, sir. The discussion touched upon the impact of the pandemic and how we managed and managing to be resilient. Definitely, we should accept that we should be prepared for facing similar challenges in future also. So now I request our Additional Director, Dr. Shekhar sir, to hand over a memento to the chair as a token of gratitude. I request our Joint Director, Dr. Vinay sir, to hand over the memento to the panel members. Thank you, sis. Thank you. Thank you. Okay. So, our next session is a panel discussion on financing primary health care, global lessons to identify opportunities for Tamil Nadu. And I request all to join me in welcoming Ms. Dr. Trina Haq from World Bank. She is a practice manager in South Asia region and leads our HNP program in Afghanistan, India, Maldives, and Sri Lanka. And please. An economist by training, she holds an MPhil in economics from the University of Cambridge and a BA from Wellesley College. And she joined the World Bank as a young professional and since then has held various positions including lead economist in human development in Africa and Middle East and North Africa regions, country operations advisor in Latin America and the Caribbean region, sector manager, practice manager in West and Central Africa before joining South Asia HD in July 2019. And ma'am has led several analytical products including poverty assessments as well as published on the topic of covariate shocks drawing from her background in social protection. She thrives in emergency context as well as in promoting innovative multi-sectoral approaches to address complex development issues such as adolescent girls and women's empowerment, productive safety nets, regional disease surveillance and preparedness, and achieving development impact on scale. We welcome you, ma'am. And I request the chair to introduce the panel members. Please, over to you.
Good afternoon, everyone. We're approaching the latter part of a very long day, a very rich set of discussions all day. I hope you're still with us and looking forward to this panel discussion, which is going to be very interesting, I can tell. The topic for today is financing primary health care. Global lessons to identify opportunities for Tamil Nadu. So I have to start by just saying I'm really excited to be here. This is the 100th anniversary of the Directorate of Public Health in Tamil Nadu that we've heard all day, and I'm really, really proud and happy to be able to join. And we have a large World Bank team here because we have a long-standing partnership with the state of Tamil Nadu and the health authorities here. So thank you very much for inviting us, and we are delighted to be part of this. I have a personal reason for being very happy to be here, because this is the first time that I've been to southern India. While I've been to other parts of India, this is my first time here. So everything is new and exciting for me, and I just wanted to mention that to you. But of course, we know that Tamil Nadu has a lot to offer in terms of sharing knowledge, experience, and lessons for the rest of India and indeed for the global community. Let me just introduce our very illustrious panel today, inviting to the podium Dr. Valeria de Oliveira Cruz. She is Regional Advisor for Health Financing and Governance in the World Health Organization CRO office. Dr. Cruz is based in India, and she supports countries in the region to strengthen their health financing and governance systems. Prior to this assignment, she has been team leader for Bangladesh. She joined WHO actually in 2010, working on Lao PDR, and she has done a lot of different things in her career throughout the world. Second, let me also invite our panel member, Professor Sunman Kwon, Professor, School of Public Health, Seoul National University, Korea. And Professor Kwon just arrived this morning, so we're really happy that he is with us. He was president of the Korea Health Industry Development Institute in 2021-2022. He received Excellence in Education Award of the Seoul National University in 2020, and he has held a multitude of visiting positions at the Harvard School of Public Health, the London School of Economics, University of Toronto, University of Tokyo, Peking University, University of Bremen, and I could probably go on for several more minutes. He is the president of the Korean Society of Health Policy and Management and has served as the president of the Korean Health Economic Association. He holds a PhD from the Wharton School, University of Pennsylvania, and taught at the University of Southern California School of Public Policy until 1996. Our third panel member is Dr. Edson Correa Araujo, senior economist from the World Bank. Edson is a senior economist with our global practice in the World Bank in health, nutrition, and population. And over the last 10 years, he has been leading different analytical pieces as well as projects in countries as diverse as Mexico, China, Brazil, Costa Rica, Latvia, and I believe Capo Verde, and so on. He also provides technical assistance through cross-support to East Africa and East Asia and Pacific regions. And Edson has led the preparation and implementation of COVID-19 response operations in West Africa and the Latin America regions, including the first vaccines project in the African continent for Cape Verde. And prior to joining the World Bank, Edson worked as a health economist in the University College London. He was also with PAHO and the Brazilian Ministry of Health. Our third panel member is Professor V.R. Muralidharan, faculty member, Department of Humanities and Social Sciences, IIT Madras. Inviting Professor Muralidharan to join us. Professor Muralidharan has been a faculty member of the Department of Humanities and Social Sciences at IIT Madras since 1988. He obtained his master's degree in economics and the doctoral degree also from IIT Madras. His primary research areas include health policy and planning, environmental health, history of healthcare in South India. He was a Takemi Fellow in International Health at the Harvard School of Public Health during 95-96, a visiting scholar at Queen Elizabeth College, Oxford University during the summer of 2000, and a Rockefeller Foundation Research Fellow in History of Medicine at Rockefeller Archives, New York. He has worked closely with the government of Tamil Nadu and the government of India, and he has served as a member of the Mission Steering Committee of the National Rural Health Mission and is currently engaged on the Tamil Nadu Health Systems Reforms Program with the World Bank. And he has served as the head of the Department of Humanities and Social Sciences, IIT Madras, and is currently the head of the Center for Technology and Policy there. Very illustrious. Last but not least is our panel member, Additional Director of the Directorate of Public Health and Preventive Medicine, Dr. C. Shekhar. He started his career as health officer in 1993 and worked in various municipalities. He also worked as assistant professor for community medicine in Stanley Medical College, Chennai. He served as deputy director of health services for various health unit districts, the principal in the cadre of DDHS at Salem, and joint director of public health and preventive medicine. He has also obtained awards at the national level, placing first in non-communicable diseases screening through health and wellness centers, and third in conduction of wellness sessions in health and wellness centers. So we have so many, well, 5 to be exact, extremely illustrious speakers in our panel. So I'm going to keep my comments to an absolute minimum. We're going to be talking about financing for primary health care. And I think it goes without saying that even though for the last 50 years we've been talking about primary health care, knowing its importance, and focusing on the importance of universal health coverage over the last 2 decades, still, without question, primary health care services in almost every country, it is underfinanced. Throughout the South Asia region, we see that there is, in general, a very low level of public financing for health. In fact, it averages in South Asia around 1 to 2% of GDP, and in India, it is about 1% of GDP, which is extremely low. And even within that low level of public expenditure, the bulk of spending is not on primary health care, but much more oriented towards secondary and tertiary health care. What is the result? The result almost invariably is that service quality and coverage at primary healthcare levels are very low, and people still have to purchase medicines, out-of-pocket expenditures are high. So often people bypass this primary healthcare level because of these challenges and go directly to hospital services, which creates an enormous pressure in terms of services and expenditures and budget needs on the healthcare system as a whole. Yet, we know that a strong primary healthcare system is absolutely essential if we want a strong public health response to the next crisis and ongoing strong quality healthcare for the people. So how do we finance a people-centric, high-quality, comprehensive primary healthcare program? What are the lessons from the global context? How can we parse that to identify opportunities for Tamil Nadu? That is the purpose of this panel. My 5 panelists, I'm going to be really generous but also strict, which means that they will have less than 10 minutes to make their interventions and presentations, so that we can then hopefully have a little bit of time for any questions and comments from the audience. But if I find that they're going over 10 minutes, I'm going to be very rude. So pardon me in advance. So let me first go to Dr. Valeria de Oliveira Cruz, who's going to give an overview of primary healthcare financing, drawing from a recent analysis that the WHO has conducted. Over to you.
Good afternoon, everyone. Can you hear me well? I hope so. All right. So, okay, great. It's a pleasure to be here today to talk about primary healthcare financing in the region, which for WHO is slightly different than the way the region is organized for the World Bank. So we have, of course, India, we have Bangladesh, Bhutan, Nepal, Indonesia, so in total 11 countries. Globally, as we know, there has been strong recognition of the importance of primary health care, how it is important that we prioritize primary health care through different PHC-focused strategies and interventions, dating back to 78, the Alma-Ata Declaration, to more recent, for example, the 2018 Astana Declaration. And of course, COVID has made us, as partners, further renew our commitment to UHC. Almost every country in the world has been severely affected by the COVID pandemic. In this year, in April, we had the launch of the Lancet Global Commission on Primary Health Care, which is a very important document that I believe, if you haven't seen, I really hope you will be able to access, because it really gives us a very important overview of the evidence. And I'm sorry, I can't read with these glasses, so I have to open my computer. So if you bear with me for a minute, I'll be able to get the slides. Yeah, so the report combines a shared vision with practical guidance on how to align health financing with overall reform strategies that place primary health care at the core. Oh, great, thanks. But it's okay, I can do that, it's okay, thanks. Yes. So why primary health care matters? As Trina rightly recognized in her opening remarks, at present, in most countries, spending is oriented towards secondary and tertiary care, unfortunately, and not towards primary health care. And we know that increased and better spending on PHC is the most cost-effective way to make progress towards UHC. We also know that 90% of essential services can be delivered through primary health care. Yet, we are not prioritizing primary health care as we should. So what is the context for primary healthcare financing in the region? Well, we have a very long history of success in the state, in Tamil Nadu, but also in neighboring countries like Sri Lanka or Thailand, where we have achieved a lot of good health outcomes and at a low cost. Recently, WHO agreed with its member states a regional strategy on primary healthcare that spans from 22 to 30, and the strategy has a number of strategic actions, including on increasing and improving financing for primary health care. Unfortunately, we are very constrained in terms of resources. As Trina mentioned as well, we have very high levels of out-of-pocket spending and very low levels of government spending. And we also face a number of challenges when it comes to poverty and inequity in this region. Then with COVID, the macro-fiscal impact on the economies of the region has been very severe. Between 2009 and 2019, this was the fastest growing region in the world, growing on an average of 5.4%. In 2020, the region experienced a severe contraction, on average of 5.5. Now, moving forward, looking after 2019 up to 2026, according to a World Bank analysis from double shocks to double recovery, different pathways are emerging. Forecasts have been made for countries at the global level, looking at different scenarios where you have a set of countries which might be expanding, some countries which are likely to be stagnating, and others which are going to be contracting. If you look at our region, the prospects are that India, Indonesia, Bangladesh are likely to be expanding. Maldives, on the other hand, is likely to be stagnating, and Sri Lanka, as we know, is facing a severe political but also economic crisis and is likely to be contracting. So these are important challenges that contextualize primary healthcare financing in our region. So you might be asking, how much are countries spending on PHC and from which sources? Well, we don't have data for all countries in the region. For the countries we have data, which are 7 countries, Thailand is the highest spender at around $150 per capita, while India, unfortunately, is the lowest spender at less than $40 per capita. And the PHC as a share of GDP in India is very low, it's 1.36%, while the global average is 3.1. What WHO recommends is that countries spend at least an additional 1% of GDP on primary health care from government sources, from public sources. Of course, more is better, but that's the minimum that is recommended, an additional 1% from public sources. Now, when it comes to the sources, and that's the graph with the blue, red, and green bars, private financing accounts for more than half of primary healthcare spending in Myanmar, Sri Lanka, Nepal, and India. For Thailand and Bhutan, government financing is the main source for PHC spending. External financing is not very significant in the region anymore, except for Timor-Leste and to some extent in Nepal. In terms of the components of primary healthcare spending in the region, it's mainly for outpatient curative care and medical products, medical goods, followed by prevention. Medical goods are mainly funded from private sources, and prevention is dominated by government and external sources. Now, it's all good to spend more, but we can also spend better the resources we have and the ones that we hopefully get in addition to existing resources. So we need to look at more value for money. And there we need to focus on strong public financial management systems. We need to ensure that we have strong policies to enable better access to medicines and improve strategic purchasing. When it comes to improving public financial management systems, we need to look at the full cycle, from budget planning, formulation, to budget execution, spending, and expenditure reporting and accountability. As mentioned before, public financing in this region for health is still very low, less than 50% of current health spending for most countries in the region. Unfortunately, budget execution is also very low. While PFM systems in the region are in transition as part of public sector reforms, we still have a predominance of input-oriented budgeting approaches, of rigid spending rules and procedures, and poor monitoring accountability mechanisms. We have a recent documentation of PFM experiences in the health sector from a systems perspective that will be coming out later in the first half of 2023, and we hope that will be a helpful tool for countries to identify some of the bottlenecks and some of the possible pathways that they can look at for improving PFM in the region. We also importantly need to look at improving access to medicines. As Trina mentioned at the beginning, out-of-pocket spending is high in the region. It's among all WHO regions, the one with the highest share. It's on average 40% out of current health spending. And as we know, out-of-pocket spending is both inefficient and inequitable and results in severe financial hardship. We produced a chapter looking at financial protection in the region this year under our UNHC monitoring efforts, and we identified that 299 million people, so almost 300 million people, are suffering financial hardship, and 24 million people are being pushed into poverty, extreme poverty. And the main driver for out-of-pocket spending in this region is spending on medicines, except in the case of Sri Lanka. And that's an area that we really can do better. I don't have data for Tamil Nadu. I'm sure you're doing better than the average for the region and the average for India, but it is overall a very important area where we need to do better. And as you can see in the graph, looking at out-of-pocket for the poorest quintile as a share of total out-of-pocket, the share of out-of-pocket on medicines is higher than 80% for a number of countries, Bangladesh, India, Nepal, and even Thailand. So that's a very important area that we need to address. 1 minute, okay, so I will be very brief. So these are recommendations from the Lancet Commission on how to improve financing for medicines, looking at the need to include essential medicines in the PHC package, and also encouraging efficient use of medicines through incentives to providers, dispensers, and patients. And I'm sure you have access to the report, so you can look at the details there. Just very quickly on improving strategic purchasing, it's very important. We face a number of challenges in this region with multiple payment streams, with inefficiencies and poor quality. But we also have emerging new challenges, the growing burden of NCDs, the growth of the private sector, which will further compound the problems we have, for example, unlimited flexibility to use funds to respond to population needs, where providers also tend to be more accountable for money than for outcomes. And here, we need to really move away from single payment mechanisms, say, for example, rigid line item budgets, fee-for-service, and opt for blended payment methods with capitation at the core, supplemented, for instance, with fee-for-services for the promotion of priority services. We need to ensure that we use provider performance information, for instance, to monitor quality. We also need to ensure that we have adequate funding level and we coordinate funding flows. Very important, it's all very good to have a very well-designed reform from a technical perspective, but we also need to look at the political economy of PHC financing reforms. And there we need to look at the political environment, we need to look at the social conditions and the economic conditions. We know that the current economic crisis is affecting health budgets with government spending reduced. Government is spending increased, but government revenues reduced. So we face a number of challenges, and here are some key messages that I'll let you read because my time is up, and thank you very much. Leave it this, I don't know if the next.
Thank you, Valeria, for almost staying on time, but and leaving some key messages for us. She referred to the Lancet Commission's, the Lancet Global Commission on Financing for Primary Health Care. Our next speaker, Professor Muralidharan, is going to continue to paint the big picture, drawing further on the Lancet Commission's report. Over to you.
Good evening. I would like to first thank the Government of Tamil Nadu, Department of Health and Family Welfare, and those engaged in organizing this workshop for having invited me to this conference. So, I originally thought I would present something which happened to be very much in the line of what Dr. Valeria presented. And I also happen to be one of the authors contributing to the Indian case studies to this Lancet paper. I have passed on the report to Anushree and I request her to circulate. What I thought I would do today is to look at what Tamil Nadu did as part of UHC with regard to primary health care. Just give some illustrations of the impact of the manner in which money was spent, particularly during the piloting of UHC 3 years ago, much before even UHC was declared in 2018. So the question is how much more to spend and how well to spend. Can I move the slides? Oh, here it is. So I refer to the same commission report, which argues that we need to spend more as well as spend better. The first question about how much more to spend, I think there is a lot of discussion on this. The magic figure that we have is that 2.5% of GDP. So I have tried to argue in many places and also placed before you for your consideration that this 2.5% of GDP is perhaps not the appropriate way to phrase, to get this point. What we need to do is, of course, there are many ways of estimating how much should be spent, and that could become either 2% or 3% or could be even 1% of GDP, because 80% of the GDP is not in the hands of the government. But what we should do, while we should be arguing for more money to spend, is to think more about how well it could be spent. So which is, in a sense, easier to answer, but difficult to also demonstrate that we are spending better, is that from an equity perspective as well as from the economic efficiency perspective, spend more on, of course, primary health care. Within primary health care, spend more on sub-centers, the centers which are closest to the community and which forms the basis of the entire edifice of primary health care system. So, if anything, we draw from the global experience that spending more on delivery points that are closest to the community is the right starting point. I mean, while you may spend more on higher levels, but definitely a step that you would not consider as wasted money. So, we have done in the last 4 years 2 studies. The one on the left-hand side shows the evaluation of the pilot, 3 pilots, 3 blocks carried out in Tamil Nadu, spending money on sub-centers, and more recently in Virudhunagar district, what has been the impact. I won't say impact, but at least the processual factors of spending on health and wellness centers. So I'll give very key points from the first report and then move on to revisit the same question. What you see here is the first 10 months of the sprucing up, investing money on sub-centers, the 3 blocks that you see. These are the footprints of the outpatients in those 3 blocks over the 10 months that you see in those 3 blocks. Progressively, the footfalls of the patients in those blocks over the month, progressively increasing for a variety of reasons. What you also see in this table, we'll spend a minute on this so that we can skip the next 3 tables. You will see a baseline carried out, baseline survey of health-seeking behavior. And one of those 3 blocks called, I think the Shulagiri block in Krishnagiri, the baseline before the piloting was started. Health-seeking behavior, you will see less than 1%, that is 0.3%, of 100% seeking care from health sub-centers. Then we did a post-UHC intervention, nearly after 10 months, with a very large survey of samples, which has increased to 17%. The 17% of those who sought care, outpatient care in that block, which used to be less than 1%, this is pre and post comparison of the same centers. It's a very easy way to illustrate, but it requires time, careful, patient, laborious surveys. And the implications are very obvious. So you will see, I'll skip the next 3 slides. The implications are very simple. Out-of-pocket expenditure among those who sought care from sub-centers were less than 3 rupees in the same block. These people would have gone to either primary health care centers or district headquarters or private health sector, would have naturally spent a lot more, or at least in terms of travel, half a day of wages lost, and spending by the caretaker, and so on. And likewise, we have figures for other 2 centers as well, which I will skip. And then we did a back of the envelope calculation to show how much it costs per patient, per visit for OP care in those centers. So we find it is less than 100 rupees. It's far less than what people, government would have spent had they been treated in primary health centers at the higher level or in district level for the same patient. So there's a lot of money saved by treating the same patient at lower levels of service delivery, which is at the sub-center, than at higher level. So this is a hypothetical cover. If you can somehow capture the overall efficiency of the primary healthcare system in terms of footfall, outreach, and other factors, and if the share of public system goes up, efficiency goes up. Of course, the red line that you see is the supply side factors. It has to be enhanced, improved over a period of time in terms of manpower, etc. So the impact of this, how well it is spent, whether it is being spent better, is seen in terms of these features. Dependence on private providers falls, and because proximity matters, which means that the service provision is there where closer to the people, closer to the place where people live, therefore financial burden falls down. Government spends per patient less than it would have otherwise spent. From an equity point of view, access is improved. These are the impact. Just I'll show you illustrative 1 or 2 figures how the physical infrastructure was improved. Same thing in different places. And the impact, as you see, in terms of attendance, footfalls of the patients. What you see here is straight from the budget, how much is spent on different directorates. But if you see in terms of the allocation of money vis-a-vis the DALI by NCD is 65%, but the proportion of budget that goes towards NCD is about 30%. Whereas you will see the distribution of budget according to vis-a-vis DALI for communicable injuries more equitable than NCDs. So one of the arguments, I would say, instead of speaking in terms of 2.5% of GDP, I would go in terms of how much of the total budget is being spent on health. Right now in Tamil Nadu it's 6.7, but if you go by the National Health Policy, which says or NHM guidelines, 8%. My argument is that extra 1% of the budget that we are arguing could be spent on primary care, and within that primary care, spend a lot of it on sub-centers. That's my. So with this argument or point for your consideration, I will close. Thank you.
Thank you very much, Professor Muralidharan. He has really highlighted what could happen if we invest at the primary healthcare level, what happens to the utilization patterns and health-seeking behavior of people. Instead of going directly to hospitals, people will come to primary healthcare units, sub-centers and other, if the quality of services is there. We'll come back to this theme because it has a lot of implications in terms of savings for the health system that could be then plowed back into strengthening primary healthcare. We'll come back to that during Dr. Edson Correa's presentation. But now let's go to Dr. Kwon's presentation. He is going to be walking us through an important source of financing, health taxes, particularly tobacco, for primary health care. Over to you.
Thank you, Chair. Well, it's my great honor to join this very important and prestigious meeting. It's my first visit to Chennai, although I've been to New Delhi a few times, and actually it's quite important. I feel special to be here because I have an eldest brother who used to live in Chennai, at that time Madras, for about 3 or 4 years, about 25 years ago. So he was the first man, one of the member of the groups who came here and built the manufacturing plant for Hyundai Automobile. So, you know, he talked a lot about this area. So thanks a lot. So the topic of my presentation is health taxes, but mainly I talk about the tobacco taxes. I try to be as short as possible. WHO recommends that the tax rate should be about 75% or more of the price of the cigar packs. But in reality, only about 13% of the world population living in 40 countries are protected by those, subject to that tax rate. That means that still many countries do not follow this kind of suggestions or recommendations. And some research shows that if we increase the price of tobacco, say by 10%, then the consumption will be reduced by 5% in low and middle income countries, or slightly lower, about 4% in high income countries. So the gains of tobacco tax will be higher in low and middle income countries. And about half of this reduction comes from those who quit smoking, and another half coming from those who reduce the smoking. So this is the WHO report according high income, middle income, and low income countries. So still those 75% tax rate, more countries in the high income category comply with that kind of rule or suggestions, whereas in the low income countries, still only, out of this sample, only a minority of low income countries, they use those suggested tax rate of 75%. And this is a so-called affordability of cigarette. Affordability means that if people become affordable, that means it's not good. but affordability changes. This is comparison between 2010 and 2020, and affordability globally, affordability becomes similar. But usually, if you think seriously about this affordability, government should keep increasing taxations because there's overall inflation rate. So that's the affordability issue. And this is the weighted average price and taxation of the so-called most sold brand. And in high income, middle income, low income, and global average still. In terms of the total taxes, in terms of the global average, still total taxes is about less than $4 per PPP adjusted. So there's still potential to further increase these tobacco taxes. Sorry, this is in Korean words, but does show that among those OECD countries, probably Australia and New Zealand, they have a highest tobacco price per pack. Unfortunately, I feel ashamed that the price per pack is the lowest among this sample in the case of Korea, that the rightmost red line is representing the Korea. And in the most recent report from this task force on fiscal policy for health, they estimate that if you increase the tobacco price increase worldwide, then say 50% tobacco price increase will lead to a more than 27 million. We can avoid this more than 27 million premature deaths over the next 50 years. And also, about 50% tobacco price increase will give us more revenue worldwide, say US dollars, $3 trillion, so which can be used for public health purposes, for example. So we recommend that we need a very high tax rate, and also we need to increase the tax rate significantly and periodically. Otherwise, if we keep the tax rate constant, then affordability may increase over the years. And warnings, these days warnings seems quite effective, and government support, public health support for the smoking cessation programs, and there should be various type of bans on the advertisement for tobaccos. And there's a new, as you know, kind of a new type of cigarette. There are increasing concerns on this type of new and emerging products, so-called electronic nicotine delivery system, or e-cigarette. And still, so far, we don't have a very conclusive, certain evidence on the harms or effects of this e-cigar, but still there's an uncertainty there. But as you know, there's a very strong tobacco industry influence and lobby on the tax policy, such that they argue that this new type of cigarette is less harmful for the health of the population. But there is another emerging evidence showing that still this type of cigarette has a very high level of addictivity, and if it is combined with some flavors, it might be even harmful impacts, especially on the behavior of teenagers, and also the so-called risk of renormalization of smoking behavior, because we kind of had a public campaign that this smoking behavior is not good, but this type of new flavored cigarette gives the wrong impression, especially for teenagers, that this behavior is a bit normal. So this is a lot of kind of increased concern and controversies about this, because tobacco industry heavily argued that there should be a no tax or even much lower tax on this new type of cigarette. And some countries, depending on the physician's prescriptions, if it can be used as a program for reducing smoking rate. Okay, some controversies in terms of equity, earmarking, price elasticity. In terms of equity, the issue is that the low-income people are more addictive to the tobacco, so tobacco taxation may have a more harsh impact on the people with lower socioeconomic status. But there's some, conflicting evidence, but recently there are more and more evidence that the tax burdens and health benefits are higher for low-income groups. So the equity issues might not be that serious. And also, the equity issue can be relying on how we use this additional revenue from the taxation. Another kind of controversy is the earmark. Many people, I think most of you in the public health programs strongly support the earmarking of tobacco tax for public health purposes. And also this type of earmarking can increase the public support. But it's a controversial kind of a conflicting empirical evidence about especially the long-term impact of this earmarking, because Ministry of Finance is very smart. So when there is increased funding to the public health programs through this earmarking of tobacco tax, then Ministry of Health is trying to reduce the existing funding to the health sector or public health programs. So some countries, after a few years, this earmarking really did not have a very significant impact on the overall funding to the health sector. So in that sense, I think we still need a political prioritization, because without a political prioritization on health, earmarking might only have a short-term impact. Well, recently, the Philippines, they have a very high, rapid increase in the tax rate for tobacco, and they successfully use them to the public health programs in there, and they usually quote as a good example for those earmarking. Thank you.
Thank you very much, Professor Kwon. And I think that he has reminded us that whatever mechanism we use to generate financing for primary health care, and indeed reforms for improving the effectiveness of primary health care, political commitment to these instruments and policies is absolutely critical. Otherwise, we will improve and then get stuck, improve and plateau. So I think that that is something really that we have to keep in mind as we think about what Tamil Nadu can do more to help increase and spend better financing for primary health care. Now I invite Dr. Edson Correa. He is going to help us understand the nitty-gritty of how to improve the effectiveness of primary healthcare systems in a very interesting way. Over to you, Edson.
Thanks, Trina. First, good afternoon, everybody, and I would like to say thanks to the organizer for the invitation. It's a real pleasure to be here during this celebration of 100 years of the Directorate. And also, it's my first time in South India. And also interested, what's the order of having two Brazilians in a public health session in Southern India? But anyway, so I'm actually making this presentation on behalf of my colleague, Jay Tandon, because he unfortunately couldn't be here for us today. But I think Trina gave a good introduction of the presentation, which comes back to the issue that's being discussed by my colleagues here about first financing primary health care, but also spending better. Valeria mentioned about the commission report, the Lancet Commission report. I think one of the recommendations also is not about the more results, but how to use the results in a better way to improve health outcomes. And also it has been mentioned here about the fiscal constraints and the need to improve health systems efficiency. So I think this presentation brings this metric of how to do that, how to look at how the results at primary health care are being used, and also how this use impacts the rest of the health systems. And it has a lot to do with the way we finance healthcare. It's not about the amount, but the incentives, the underlying incentives in the way we finance, but also how primary healthcare are organized, in terms of are we providing the service in a way that's continuing and they provide follow-up to patients. But anyway, I'm anticipating too many issues. Let's go to the presentation. So the first thing is, what are the ACSC, ambulatory care sensitive conditions? You can go to this definition, but basically we're saying that there's some hospitalization that could be avoided due to if primary health care, if ambulatory care is provided in an efficient, timely way. You know? So those are the definitions different NHS, OECD, WHO. But as I said, the common aspect of them is how primary health care can avoid the hospitalization related to those. And this is important. We have some data here for India, but I think you observe this trend most of the countries around the world is the rising of the chronic disease, right? You know, this more and more chronic disease represents a higher burden of the disease in countries, and that conditions require a certain way of organizing health service, and specifically organizing primary health care services. Oh, sorry, I'm passing by myself. Oh, sorry, there was a mistake. Thanks, Trina. Sorry, I'm reading by myself here. So first thing, the definitions. As I said, the common aspect is timely and efficient primary health care. The second that I was just mentioned now is the raising a burden of chronic disease. Of course, this data is for India, but it observes this trend everywhere in the world. And one key aspect of that is this epidemiological transition requires that the health system, and specifically primary health care, is being organized in a different way, right? And of course, I hope we can make the link. It's not only about the organization, but how the way we finance primary health care and the underlying incentives that in the way that we finance. I think Valeria mentioned a lot about capitation, about pay for performance, and I hope we can bring the discussion when we look at this data. So one thing that's important also is to differentiate the different types of ACSC. Some of them are fully preventable, like the one that can be prevented through vaccines. Some of the others we can use to reduce morbidity. And others is used for chronic conditions that we can use extend life, and of course, extend quality of life. But those are the more definition aspects. Here we have a few conditions, it's just for illustration, but I think the main point and the main part of the presentation is this one, no? Which is the point I had made, is with the increasing burden of chronic disease, we need to prepare health systems to have this continuum of care, from prevention to screening, treatment and management. You know? And what we often see is the health system not able to do that in a coordinated way. We see fragmentation across providers, you see fragmentation across levels of care. No? This issue of integration between primary health care and hospital care is essential to guarantee to achieve that objective. No? Which means if primary health care service is able to do this continuum of care from prevention to management of conditions, we can avoid the hospitalization of ambulatory sensitive care conditions. And one data about this is, I'm going to come a bit later, but around 15 to 20% of all hospitalizations are due to sensitive conditions. In other words, conditions that could be avoided. Which brings the point about efficiency, right? If primary health care is able to do all this, we may be able to save healthcare costs significantly. Here there's an example of diabetes. No? You see, from the same thing from prevention, screening, treatment, management. No? If healthcare and primary healthcare fails to do one of those, we can identify the gaps. No? We can identify also what the incentives to follow up or implement each of those aspects. So it's very important, these two, not only for understand the service delivery in terms of clinical aspects, but in terms of efficiency. No? I would say those two slides are the key ones, right? To show how you structure primary health care, both in terms of service organization and of course the finance, and what the outcomes you get out of it. So here's a bit about how to define this. It goes from the global standards, and WHO has a list of conditions that are defined in this list. And of course, one key aspect of it is how we adapt it to the country context. And here we have the UK NHS list of ambulatory care sensitive conditions. Here I bring the Brazilian list. There are 19 conditions that are considered avoidable. One critical aspect of this, both in the UK, but in Brazil, and I believe in all the countries, is to adapt this list to the context specific. We're going to see later that not all of these conditions are avoidable. Not all of these conditions, in terms of avoidable hospitalization, are due to the primary health care service, which means we need to understand the context that we're analyzing this metric. So, a bit of summary here. First, ambulatory care sensitive conditions is an important tool to measure primary health care effectiveness, to measure access and quality of primary health care. I just showed in this graphic of continuum of care, if you look at different aspects of the service delivery, we can identify where the gaps are, and how they influence the outcome. And of course, the outcome here is hospitalization, or avoidable hospitalization. Can reduce mortality, morbidity. As I said, 15 to 20% of all hospitalizations could be avoided, but also can improve health outcomes. And of course, as I said before, cost savings in the healthcare system. One important aspect is data. We have data available. I think the point my colleague was making here is in the Indian PMJ, it's a large scale of data that we can analyze these admissions, and then, as I said again, identify what the gaps are in terms of service delivery and continuum of care. Here are a few examples of cost savings. This one from the UK, and then one of China in China, but I think the common aspect here is how to look at this and see where the possible cost savings. In my own country in Brazil, we have done some efficiency analysis, and about $500 million a year is spent on this hospitalization, which means significant part of it could be saved if primary health care, ambulatory care were more efficient in terms of service delivery. Here's a few examples of analysis. Again, this has been used extensively as a metric to understand primary health care effectiveness, and you have large evidence around the world on using that. Two important aspects of it, as I said before, not all the conditions from that list from the NHS, from 19 conditions from Brazil I showed, not all the conditions are avoidable. Some of them happen not because of healthcare didn't deliver the service as desirable, but for other reasons, including socioeconomic reasons, including conditions in the past, etc., etc. So again, in terms of analyzing this data for assess primary healthcare effectiveness, it's important to open the black box. And I think that the graphic of show the continuum of care gives us a good pathway to do that. From what Professor just mentioned about health tax, the prevention side, but from that to screening, treatment, and management. Yes, I think that's the last one. As I said before, this is important. It's an important metric to look at the primary healthcare efficiency and overall health system efficiency, because 15 to 20% of all hospitalization are due to these conditions. So a lot of potential cost savings looking at this. This ACSC is a powerful tool to assess health system performance, the weakness in the health system. And I think the way I mentioned, to look at different steps, different pathways within the service delivery system, from screening to management, gives a good opportunity to look where the gaps, but also what the barriers to access. Sometimes a patient can go for screening, but cannot follow up in the treatment, or sometimes the treatment is done by a different provider. So it's important to look at these different, let's say, blocks, and then assess the effectiveness of service. However, one important aspect here, and I need to emphasize that, is this is context specific, right? Of course, you go to conditions that are defined by WHO, and then you do the assessment to adapt by specialists to adapt to the context. But one important aspect on the look at this data is to really understand which part of the total admissions are avoidable and which parts are avoidable due to the gaps within the primary healthcare service delivery system. So these are some reference, and I think the one point to make in my last 30 seconds is I hope we can make the link, as Traina mentioned, between the way the amount we finance, but it's important to look. It's not about more finance, but better finance, better design of incentives that allows us to follow different service delivery aspects, as I showed. And of course, complement what my colleague also mentioned about efficiency. No? I mean, this metric is an important tool to look at health systems efficiency and the potential cost savings within this. Okay, thank you.
Thank you, Edson. So the way I look at it is, I think in Tamil Nadu in particular, there are dialysis centers in many blocks, but how can we detect diabetes, or hypertension, etc., early enough so that people can be screened at a population level early, and then medication or whatever is necessary to lifestyle changes to manage conditions so they don't end up requiring dialysis and further hospitalizations, which are very expensive, and that would save funding that could then be reinvested into primary healthcare service systems. That is the question, and I would really like to hear back from this audience as to the opportunities for doing that, because this type of analysis that was just described can be done using readily available data from hospitalizations. Our last but not least presentation is Dr. Shekhar, and he is going to be talking about achieving UHC in Tamil Nadu.
Madam Chair cum Moderator, dear panelists, then our DDs and our friends, officials from our public health department. Today the topic which we are going to discuss is financing primary health care and global lessons learned from them, which I am going to discuss. So during the discussion, both of them spoke about what is the result if you invest the money in PHC. Dr. Muralidharan told a lot of things. He showed the evidence. If you invest in the PHC, what will happen? And also, on our official from World Bank, I think Dr. Edson, he also spoke about if the NCD patients are treated well in the PHC level, that burden in the tertiary will be reduced. So, as I have said, we need the topic shows financing primary health care or primary health care funding or expenditure. So I won't say the expenditure in primary health care, rather I will tell this is a capital on the health of the people. If you make expenditure in the PHC, this will be a capital on the public, not on this, for the health of the all the people present today, the health of your children and health of your grandchildren, for the health of your grandchildren. For example, we need funds for the expenditures in the primary health centers. Justification for that. See, in the PHCs, we are doing immunization, particularly in Tamil Nadu speaking. Tamil Nadu, our 100th year we are running. And this entire 95% of immunizations done in our state by our PHC only, not even in the private hospitals. Then, during the COVID period also, I want to tell again, the PHC only done all the tests, not the private hospitals. And then, for the PHC, all the people from our Tamil Nadu, they are coming for taking treatment, as rightly pointed out by our Dr. Muralidharan sir. Not only that, not to speak about the COVID-19 also, in future also we are expecting more outbreaks. So just 1 week back, a virus was sleeping for about 50,000 a year. He was sleeping just like that virus. They brought out. What is that? Mozambique virus. Who knows? It may be next epidemic. Who knows? So these are the things, the burden of the PHC care will be added some more. And also they told about the GDP of our world and nation and Tamil Nadu. The GDP, the expenditure on health out of GDP is very minimal in our country also. So the world, even the United States increased the GDP from 16 to 90% after affected by the COVID. Even they increased there. After infection, after the getting a lesson from the COVID infection only, they increased it. UK is with a 9%, and France is 11%, Sri Lanka is 3%. What's ours? It's only 0.8%. So this GDP also, the expenditure on health also should be increased. We were expecting our officials from our finance department also for this panel. So if it is there, it will be also very good for us to place some important request on them. And then here, speakers from regional advisor from CRO, WHO, and madam, from World Bank also. So you can also give us your lessons as a recommendation for our Tamil Nadu. So these are the way how can we get funds for our PHCs. Because in 2005, yes, we want to recall this, the same meeting we had it, then World Bank on Dr. Gamma Rogo. He was a person came from our World Bank. Then we had a discussion with them. I'm telling the history of the National Health Mission, how it came. We had a discussion with them. He sanctioned 500 crores, the 2005, the same World Bank personnel. So you can also, your friends are here, you can recommend us how to go for the Tamil Nadus to getting, this is a lesson, these are the lessons, how we are going to get the funds from some of the things. So these are the things I want to put up on the, this we need all the lessons derived from your presentation for getting more funds for our Tamil Nadu. So thanks for your time allotted for me. Thanks. I think I've finished within 10 minutes.
Thank you, Dr. Shekhar. I didn't even have to remind him about the 1 minute. But this means that we have a few minutes, not too many, but if there are some questions or comments from the audience, please speak out. I don't know who has the microphone.
Just a question to you, sir. We were talking about tobacco. Can you share the experience of what the world is doing on taxation of alcohol?
Maybe if I can suggest, if we can take 2 or 3 questions and then we'll come to the panel, just in the interest of time.
Good evening. So I would like to know about the conditional cash transfers, which is an important tool in seeking behavior or change in the public to achieve the desired goal. Since 1/5 of our Tamil Nadu public health budget is given or offered to one such program, how far this program or this sort of tools will be effective in getting the desired goals in future to some next extent, say for example, next challenge would be our non-communicable disease. Could you throw some light on utility of this tool in other countries, especially in the context of low and middle income countries?
Very interesting. Thank you.
Sir, just for our director, it is only 0.8% is very less, sir. But even to chest, I think in USA, that is the most costliest affair in chest. Chest is having only 2% of GDP from USA. What is your expectation from Tamil Nadu government or central government as a GDP, sir? What is the best we can preventive, not only communicable disease and also especially diabetic hypertension, IHD, hyperlipidemia? Because I have got 2.5 lakhs patients, which has been done in CM scheme with your minimal ailment, which has given only 55,000 for 7 days of ICU. Nowadays they are reducing to only 32,000 of rupees for 7 days of ICU, but still we are doing at least minimum 220 cases from 2,000 villages, sir. What is your best GDP you expect, so that we can all throw the picture to our Prime Minister, who is the number one in
Yes,
the
sir,
Prime
yes,
Ministry of the whole world?
Yeah, your question is, I will be telling for that. Your question is well taken. This 0.8% of expenditure of health, with our entire force of VHNs, doctors, medical officers and health inspectors all, we achieved such things. He is presenting such a very good presentation that we achieved a lot. And there is also presenting next. So, that Tamil Nadu is, we are conducting 100th year. We are top in the entire nation. If they give, as you told, more GDP, we'll do more activities. It's a policy decision. We will request our government, will be done. Yes. Thank you. Thank you. Yes, definitely. Thank you, sir.
Okay, 4th and last question, and then we'll come back.
I want to address the panelists. This fallacy of pegging your health expenditure on GDP, it's a big untruth. It's a big fallacy because the GDP as a denominator keeps moving. And I think we have been fooling the people with this kind of analysis. Especially I call myself in India 1% to 1.3% to 2.5%. And our GDP is going, and actually we wrote a paper about it in EPW. I would like to look at international, Suman and others to respond to that. And second, Murli, one of the things, I think this financing of primary health care, somehow it hides a very major issue of financing of public health care system is how much do we spend of public health care on salaries and how much do we spend on medicines and diagnostics? Because some of the analysis I did, 80% of your expenditure of public health expenditure goes into salaries and administration. Correct me about Tamil Nadu. And the Zero lady brought out about expenditure on medicine, that's also applicable to India. Why do our people spend on medicines? Because they are not available in our public facilities. So how much, Murli, do we spend on salaries and how much on medicines, and if it is being done? Thank you.
Okay, thank you very much. So let me start with Professor Kwon on alcohol taxation, and then we'll go to any of the panelists who want to take on the other questions. The microphone.
I haven't done research on alcohol tax, so I asked whether they are familiar with alcohol tax, but neither of them are familiar with alcohol tax. But so do you have?
Yeah, if I can comment on that, it's like two things. One is I haven't also done extensive work on alcohol taxation, but what we when you look at this country's experience around the world, what I can say is a combination of tax, but also other types of measures. For instance, limiting age to consumption of alcohol, limiting time to purchase alcohol, etc. But more generally, I think we are moving to a more comprehensive approach where we look at health taxes, which includes not only alcohol but tobacco, which the tradition, Professor understands very well about that, but also unhealthy diets, the excessive use of sugar and processed food, salt, sugar, sweetened beverages. So we're moving towards a more comprehensive approach to these taxes. As I said, we call health taxes.
But in terms of the impact of these health taxes, I think we should monitor its long-term impact, because in terms of, in my research on the impact of tobacco tax, especially for the teenagers, after half year or 1 year, that is bounced back. So we should really take into account those long-term impacts, monitoring the long-term impact of this taxation on the behavior. Another controversy recently is that many people in the public health community say that the revenue from this kind of a health tax, it should be used only for or targeted for the public health programs related with this alcohol, tobacco consumption. But it is controversial in some countries. If we have a, for example, extended UHC program benefiting the majority of the population, I think it should be okay to use some of those revenue from these health taxes for the benefit of the majority of the population. There is a case in the Philippines, and there is a case in Korea and some other countries. So I think we can a bit broaden our perspective on which is the best way to use those revenue from those health taxes in the health program.
Thank you.
I just wanted to add, thank you. I think what was said before was very important. We need to look at the whole range of taxation, tobacco, alcohol, sweetened sugared beverages, and junk food, if you like. I think there are a number of opportunities, and as we know, countries are facing several challenges when it comes to their macro-fiscal environment. It might be a source to increase revenues. But just as Professor Suman Kwon was saying, we need to monitor the impact. We really need to see the more effective these taxation programs are, the less revenues we're going to get over time. But they may not be immediate, so it could be a short-term option for increasing revenues. But again, we need to keep monitoring and adjusting as we go along the process. Thank you.
Thank you very much. Who would like to take on the question on conditional cash transfers?
I think he was asking other lessons from other countries for Tamil Nadu on conditional transfer.
Go ahead.
I think one example that's very famous around the world is, again, not because I'm Brazilian, Valeria is Brazilian as well, but as you know, Brazil has one of the largest conditional cash transfer in the world, and some of the conditionalities are related to health, vaccinations, and other follow-up for kids. And what we've seen the evidence is considerably increase the uptake of immunizations, and also some other basic care. So the evidence, there are actually some papers published on that showing the positive impact of the Bolsa Família, which is the conditional cash transfer, on first access to services, like people are going, the mothers and fathers are bringing the kids to health facilities to take vaccines and other services. But secondly, to health outcomes.
I think he wants to supplement the answer.
He asked about that one-third funds go to some important schemes of Tamil Nadu. The schemes are there only in Tamil Nadu. Even no other countries are having, in our states are having. So it's unique. Tamil Nadu is unique in that. So அது அவங்களுக்கு தெரியாது, விட்டுருங்க.
I just forgot to mention one thing about the conditional cash transfer. As we usually call, it's like a demand-side intervention, you know? And when you see also the successful examples of conditional cash transfer are the ones who are matched by good supply-side conditions. In other words, it doesn't matter if you incentivize families to bring the kids for healthcare facilities if the healthcare facilities are not able to deliver the service with appropriate quality. So my comment is just there is a match between the demand side, which is the conditional cash transfer, and the supply side. Thank you.
Very good point. Thank you.
Just one remark in response to Sunil's comment about human resources accounting for a large proportion of the budget. In fact, unlike agriculture or industry, where machine can replace manpower to a significant extent, in healthcare, human resource in the form of physicians and auxiliaries are not that easy to be replaced. They will grow, and we should not be surprised to see that they account for 60 or 70, 80, I'm not sure which state is referring to. Our estimates of the state health accounts figures are already 5 years old. We would like to revise that, and 5 years ago it was about 60% plus. And DPH alone, as he has remarked many times in the last 2 days, 75,000 people in one department, and it is going to expand, and it ought to expand, and there's a clear need for expanding the human resources. So I think the overall budget also has increased more than 10 times in the last 10 years in health department. So the base is increasing, proportion of each one. What we should perhaps be concerned is if the proportion, the medicine goes up, and particularly the antibiotics and so on, given the current concerns about AMR and others, we should try to look at that part of it and see how we can change consumption of drugs in a particular manner. So with that remark, I would give this.
Okay, one last response from Dr.
Just
Valeria.
quickly to complement on the issue of medicines, I think we really need to unpack that there is a lot of irrational drug use, which is raking up spending on medicines for through out-of-pocket. And I think we really need to understand how much is it overprescription from clinicians, how much is people purchasing over-the-counter drugs, and how much of these drugs are out of essential medicine lists. And I think we can do a lot more. At the same time, we know that in many cases, people are not getting the drugs they need from public facilities, and they are going to the private sector, to pharmacies, and buying their drugs as a replacement for access to services. So for instance, having facilities, public facilities open in the evenings can make a big difference. And that is a set of issues that we need to think of. Thanks.
Okay, thank you very much. So one last comment from my side, which is to say that yes, it's true that we shouldn't be looking at just what percentage of the GDP, because especially in the case of India, India has had a very high GDP growth rate over the years prior to COVID. And that means that even though the percentage has remained the same, the absolute level of funding going into healthcare in general and primary healthcare have both been increasing in absolute terms. Even then, however, financing levels are low, given what is required in order to produce sufficient coverage and sufficient quality of services. And how do we, so one question is what to do to increase further the levels of financing going into primary health care, and we have some ideas. But the other is also, which we've discussed today, how can we improve the efficiency of spending and effectiveness of spending in the healthcare system, so that primary healthcare can be that people-centric, comprehensive primary healthcare that we're looking for. So thank you, everyone. Thank you to the brilliant panel that we have had, and to the brilliant audience who have stuck through. Thank you.
Thank you, ma'am. Though we doctors are considered to be poor in maths and economics, as public health managers, we should have insights of financing public health care and health taxing. And I'm sure the discussion had helped us know better than before. So I thank the chair and panel member. Now I request our additional director, Chairan sir, to hand over memento to the chair. Now I request our Joint Director Shanmuga Sundaram sir to hand over the memento to our panel members. Thank you, ma'am, sirs. And now, we'll move on to another plenary session on universal health coverage, seamless integration of primary, secondary, and tertiary care services by our former Additional Chief Secretary and MD NHM Government of India, and currently serving as Director, Department of Health System Development, CRO, WHO. So actually, sir tried his best to do an in-person speech, but because of his commitments, he could not join us. And so I request all the delegates to listen to the video recording by Dr. Manoj Chalani sir on this topic.
Dr. Girija Vaidyanathan, Madam, officials of Government of Tamil Nadu and other dignitaries. Anai Varukam, Kalai Vanakkam. Good morning, everyone. It's my great honor to address this August gathering at the International Public Health Conference, DPHI-Con 2022, the first of its kind organized by the Directorate of Public Health and Preventive Medicine, Health and Family Welfare Department, Government of Tamil Nadu, to celebrate its century or 100 years of successful existence. Although I would have liked to be there in person in this ancient and lovely city of Mahabalipuram, but due to other obligations, I am unable to join. First of all, my thanks to Government of Tamil Nadu and the Directorate of Public Health and Preventive Medicine, Health and Family Welfare Department for inviting me to this event, and I wholeheartedly wish the Directorate of Public Health all success in its journey to effectively address the current and future health challenges. Tamil Nadu state has emerged as a model state in the country with regards to providing quality health care to its entire population. The policy interventions, introduction of several novel schemes, and state-specific innovations have played an important role in states' better health outcomes. Few notable state innovations like Muthulakshmi Reddy Maternity Benefit Scheme, Pregnancy Infant Cohort Monitoring and Evaluation and its integration with the civil registration system, Makalai Thedi Maruthvam, Tamil Nadu Accident and Emergency Care Initiative, Namai Kakom 48, NK48, Emergency Care and Recovery Centers, Tamil Nadu Medical Supplies, Medical Services Corporation, etc. are worth mentioning. These all have helped the state to become a frontrunner on several health indicators in the country. Tamil Nadu achieved the MDG targets and it is also poised to achieve several of the global SDG targets ahead of 2030. Tamil Nadu is a rare example of a state which chose not to amalgamate its medical and public health services. The state has a separate Directorate of Public Health and Preventive Medicine functioning since 1923 with its own budget and a legislative underpinning for its work, the Tamil Nadu Public Health Code and the Tamil Nadu Public Health Act 1939. With this dedicated Directorate of Public Health in place, Tamil Nadu has managed to maintain focus on public health programs and improve population level health outcomes and maintain a balance on essential health services and essential public health functions. The topic given to me for this plenary session is UHC, Seamless Integration of Primary, Secondary and Tertiary Care Services. The topic is very timely when the world is seeking to build back better and resilient health systems post-COVID-19 pandemic. Universal health coverage or UHC means that all people have access to the health services they need when and where they need them without financial hardship. It includes the full range of essential health services from health promotion to prevention, treatment, rehabilitation and palliative care. WHO perceives and recognizes UHC as fundamental for achieving the SDGs related not only to the health and well-being goal but also to other socio-economic development which is critical for the attainment of healthy lives and well-being for all with a focus on health outcomes throughout the life course. The WHO has identified 5 strategic priorities that includes support a radical reorientation of health systems towards primary health care as the foundation of universal health coverage. Investments in quality PHC-oriented health systems where essential health services and delivery of essential public health functions are integrated, communities are empowered, and multi-sectoral action is enabled can deliver significant returns on investment and achieve maximum efficiency. The learning, including during the COVID, is that features of high-performing primary health care are the same as those required to address the growing challenges facing us, emerging and re-emerging infectious disease threats, escalating climate events, and the growing burden of non-communicable diseases. Reorientation of health systems towards primary health care will thus not only advance universal health coverage but also advance health security and promote health and well-being, thus advancing all the 3 strategic goals of the WHO in a very cost-effective manner. One of the major challenges being faced, particularly by the low-middle income countries, is about how to seamlessly integrate primary, secondary and tertiary care services through a PHC approach for achieving UHC, which is the focus of my talk today. First of all, I wish to clarify that seamless integration is needed not only across levels of care, but also from womb to tomb, that is across the life course, also laterally across different specialties and programs for people with multiple morbidities. Also, it should cover full range of health services from health promotion to prevention, treatment, rehabilitation, and palliative care delivered in homes, community, and in healthcare facilities and hospitals. Now let's discuss what is needed to seamlessly integrate primary, secondary, and tertiary care services and how this can be achieved. First, it's important to establish patient-centric convergence of all health and related activities by establishing a harmonious program network to ensure effective forward, backward, and lateral linkages. 2. Clear understanding of the services that are to be delivered at different level of facilities. There should be adequate and competent multidisciplinary health workforce, availability of free or affordable quality health products, and service delivery mechanism to deliver those services. Indian public health standards that were released recently provide a good starting point. Clear bidirectional care pathways, when to refer a patient to which level of facility, and what follow-up is to be managed by which level of facility after treatment at higher level facility. This should be known and well understood by providers at all levels of health systems. Standard referral pathways have been designed for several of the common disease conditions. These need to be developed for many more of the NCDs, and these need to be adapted to the state's context. Enablement through digital health. Facilitate care continuum and capture longitudinal history in the personal electronic health records through ABHA. Use of clinical decision support systems to assist the providers, and use of telemedicine for a range of conditions including primary care, teleradiology, and telehealth, particularly for supportive supervision and capacity building. AI could also enhance efficiency and quality of decision support systems. Mobile technologies should be used to communicate with the patients and families as also with the providers. We need to identify gaps in the existing health and care systems to provide care continuum and address gaps in governance, sustainable financing, information and monitoring systems, service provision, quality standards, health workforce, etc., and take measures to address these gaps through appropriate action plans and implementation. Sixth, it will be important to have program management and monitoring capacities to track adherence to care continuum across stages and individual follow-up. We notice that for care of hypertension, there are significant misses. We fail in early diagnosis of hypertension. We fail in initiation of treatment for those diagnosed with hypertension. We fail in adherence to the treatment. And then even those under treatment, it's not necessary that the BP is controlled. It's also important to have robust grievance redressal mechanism to ensure that the patient receives high quality, respectful care at all levels. To avoid financial hardship and improve facilities utilization, it is important to ensure uninterrupted availability of free drugs and diagnostics at all levels of care, so that the medication and diagnostics prescribed even at higher level facilities can be available at lower level facilities. The access to quality diagnostics can be ensured through the hub and spoke model for in vitro diagnostics. Create a learning health system so that we keep monitoring and evaluating the performance of health systems or the PHC systems and make course corrections and scale up what works. Let me try to explain the scenario with an example. Muthu Lakshmi, a 50-year-old lady, had severe headache and palpitations for last 3 days. The women health volunteer or ASHA visits her and suspects through the BP examination that she may have high blood pressure. The ASHA or the volunteer guides her to the adjacent health and wellness center, and the MLHP too finds that she has high BP based on the protocols. The MLHP then enters this information in the IT portal with the inbuilt clinical decision support system that will assist the MLHP in analyzing the patient's records and making well-informed decisions. The MLHP then fixes a time with the staff nurse at the higher level facility as per the standard care pathway as to when Muthu Lakshmi can visit the referral facility, and then gives her a referral slip. This is further entered into the IT system that informs the patient and the referral facility about the patient's scheduled visit over a mobile phone. At the referral facility, the physician or doctor does the evaluation as per the standard treatment guidelines, and finally, the physician confirms hypertension. The physician gives her a note that she has to show up at the health and wellness center, as also provides a prescription for which she collects medicines from the treating referral facility for the first 2 months. The doctor's prescription is not only for prescribing medicines but also to indicate the treatment plan. By treatment plan, we mean the counseling required, including changes in lifestyle, the medicines to be taken, the follow-up visits needed, and what should happen on those visits, the early detection of complications for which caregivers should be alert, and the indications for referral and for the next specialist consultation. This should be part of the personal electronic health record. Subsequently, after she achieves an adequate control rate, she goes to the health and wellness center every month where she gets her BP checked and collects that month's medicines if the medicines are able to control her blood pressure. She need not travel anymore to the referral facility for this. When Muthu Lakshmi fails to come to collect her medicines, the ASHA or the health volunteer or the MLHP contact her to find out why and remind her. They also spend time counseling the family on changes in diet, exercise, and to stop using tobacco, and connect them to the patient group. Once in 3 months, the patient is seen on telemedicine with the specialist, facilitated by MLHP. This whole cycle of event is captured by an IT portal wherein all the longitudinal data of the patient is being captured at every point of contact with the healthcare system. This is a small example of how within the primary care setup, a continuum of care is established between the household, community, health and wellness center, and a higher level facility. Taking this scenario further, now Muthu Lakshmi has developed high-grade fever with SpO2 dropping below 80 while checked by the MLHP. The MLHP and the team, after consulting the PHC medical officer, called for an ambulance and referred her to a district headquarters or a medical college hospital. She was tested there for COVID and was found to be positive and admitted in the COVID ICU while she is having a drop in SpO2 and is having a high BP, elevated maybe due to COVID. The treating physician was able to check her longitudinal health records or personal electronic health records with consent of Muthu Lakshmi and changed her drug regime for blood pressure in addition to the treatment modalities for COVID-19. This was also entered in the IT portal. Once she got all right, she was referred to home with a change in prescription for hypertension with an addition of second line of drug. The MLHP, the PHC medical officer, and ASHA got informed about this during the back referral, and they later continued to follow up with Muthu Lakshmi at the primary care level. After 3 months, the PHCMO again confirms that Muthu Lakshmi's blood pressure is in the normal range and called the physician via telemedicine platform to confirm the step down in her treatment to the normal regime. The service delivery has to be conceptualized in such a way that the primary care team with the MLHP, supported by the supporting staff, does the preliminary screening and early detection. The medical team establishes diagnosis and treatment plan, and the primary care team, supported by community volunteers, ensures follow-up and medication compliance. In case of complication management or comorbidity management, there needs to be seamless patient and information flow with secondary and tertiary care service levels. I'm sure that Tamil Nadu, through the state's experiential learning of implementing USC, starting from its pilot initiatives way back from 2016, is also aware about the need for a robust ICT platform with population denominator to establish a continuum of care. In the Indian context, the recently launched Ayushman Bharat Digital Health Mission, the ABDM, and the Abha ID is trying to integrate all applications at multiple levels and avoiding duplication. Abha number is a randomly generated 14-digit number used for the purpose of uniquely identifying persons, authenticating them, and threading their health records only with their informed consent across multiple systems and stakeholders. What we need to do is to identify gaps in the existing and health and care systems to provide care continuum and address gaps in governance, sustainable financing, information and monitoring systems, service provision, quality standards, health workforce, etc., and take measures to address these gaps through appropriate action plans and implementation. Achieving the UHC is obviously ambitious, but we can accelerate our progress towards it by bringing in synergies in action of all relevant stakeholders and partners. I hope Tamil Nadu shows the way to the country by providing for UHC through a robust PHC-oriented health systems. I wish you all success in this endeavor. I thank you all very much for your patience. Nandri, Vanakkam.
care and also continuum of care with the secondary and tertiary care services. And now we have started, though we have tried different information system in the last decade, now we are moving towards the ABA ID also. So we have started doing piloting in some of the districts for NCD. So hope and assure that in this 100th year we'll be getting a good information system, which is very vital to have a seamless integration of across the levels of care. We have 2 more sessions for the day, and now we'll move on to the plenary session. Emerging NCDs including non-alcoholic fatty liver disease, colon cancer and CRDs, etc. by Dr. Grieve Hilde Rene Susan, who is a team leader, Health Systems, WHO Country Office, India. And please join me in welcoming Dr. Susan, Hilde Susan. Welcome you, ma'am. So Dr. Hilde is the team leader for Health Systems at the Country Office of the WHO in India, where she is leading the agenda for universal health coverage and health system strengthening. She has extensive experience in public health and health policy development and has worked for many years for the Ministries of Health in Zimbabwe and Mozambique on improving access to primary health care. She has special interest in governance, human resources for health and integration of healthcare services. And she is a medical doctor from Belgium and an alumna of the London School of Hygiene and Public Tropical Medicine. Over to you, ma'am.
A very good evening, and thank you for joining the last 2 sessions of what has been a very busy day. Thank you for the introduction, ma'am. Let me just simplify the pronunciation of my name. My name is Hilde, and I'm indeed the team leader at the country office of WHO in Delhi. The topic that I was asked to cover is emerging NCDs. And emerging is a word that we usually associate with communicable diseases. It seems to imply that there is a certain urgency, that there is a new development, that there is a new cause that can lead to a pandemic or an outbreak. What I'm going to do now throughout my presentation is addressing elements of evidence, causes and risk factors and responses, and see if there is indeed emerging elements. Are new elements become more apparent when we talk about non-communicable diseases? And I will start with the evidence that we have. And the first slide, some of you will be familiar with this. This is from the Disease Burden Initiative that was published in 2017, the disease burden that was looked at the different states in India. And there it shows very clearly that there is a clear epidemiological transition happening. Looking at the DALYs, the disability adjusted life years, over the 26 years, we see that where in 1990, diarrheal diseases, lower respiratory tract infections, TB, measles, that was the top 5 causes of death at that time. This has moved completely, and you can see these linear lines. Now what is is considered to be leading causes for India, it is ischemic heart disease, chronic obstructive pulmonary disease, and stroke. Looking at premature mortality, and that is when we look at mortality amongst adults between the age of 30 to 69 years, again in India, looking at the mortality for that age group, you can see that there is an overwhelming contribution to these premature deaths due to NCDs. What was traditionally known to be a major public health problem when it comes to communicable diseases, maternal and nutritional conditions, and injuries, that is now only representing 1/3 as a cause of premature death amongst adults in India. When you look at the right side of that slide, well, absolute numbers in India are always impressive. They're very large. Nevertheless, when you have 77 million people with diabetes, we know that it is still 10 million more people than the entire population of the United Kingdom. So in terms of magnitude, that can count. Looking at the increase of utilization of hospital services and OPD services, over a time span of 10 years, an entire decade, there's been an increase of nearly 120% of outpatient services, but also hospital stays have increased by 55%. So that is linked to an increase of NCDs and chronic diseases. This has financial implications. The cost or the share of out-of-pocket, what people pay towards their care, is in India more than 47%, and it is higher in, there's differences amongst the states. It can even go up to 70% plus. And I'm sure the issue of out-of-pocket expenditure was probably addressed extensively in the previous discussion, panel discussion that we had. So, when I said emerging evidence from those 2 slides, there is sufficient evidence that there is indeed an epidemiological transition going on. We also know that there are demographic changes, but where we can still, or where we need more evidence, is not only on the causes of death and mortality statistics, but morbidity. When we talk about non-communicable diseases, morbidity has a high impact on people's lives and puts a burden on the health system, but also on the social sector to provide for people who are living with these chronic conditions. So when we now look at causes and risk factors, what I'm showing you here is the 5x5. Some of you may be familiar with it. It is a way of summarizing in an easy to understand and in a logical way of when we talk about communicable diseases. We have categorized them in 5 diseases, as you see them listed there. But when we talk about non-communicable diseases, we also talk about risk factors. So they are there. Nothing new there, nothing emerging, but we know that for each of these disease conditions, like when we look at mental health, there is still a lot that we don't know. There are new elements coming in. COVID-19 has shown us that mental health and the burden of mental health, but the new developments in our societies, children getting addicted to games, requiring psychiatric support now for game addiction, that are new elements. Again, under the mental and neurological conditions, what is emerging as a real challenge for every society is the growing number of people with dementia and how families and the health sector can provide and care for these people. So within that 5x5 matrix, there are changes happening, and we will have to follow and monitor that closely to see which direction this is going. Now, when the topic was assigned to us, it clearly it specifically mentioned emerging NCDs, and was mentioned chronic kidney disease, non-alcoholic fatty liver disease, colon cancer. These diseases have always been there. What is new or emerging is that the incidence of these diseases are rapidly increasing, but there is also a very clear link between existing risk factors that are also contributing to the diseases that we have listed in the 5x5 matrix that I have joined you just now. One newer disease or emerging NCD that is beginning to get more attention and which seems to be very relevant for the Asian Pacific region is conditions or diseases of the liver. That is not appearing in the 5x5 matrix that I've just shown you. But we know that within this region, although it is home to more than half of the global population, its contribution to the global deaths due to liver disease is actually 63%, which is actually fairly high. And how these emerging non-communicable diseases need to be factored into our public health responses needs to be further examined and explored. Now, non-communicable diseases are known to be multifactorial. There is not a single cause that contribute to NCDs, and that is where it differs from infectious diseases. The risk factors that have been identified, we can easily classify them in the non-modifiable and the modifiable risk factors. But there are new risk factors emerging, and I'm moving here to this, where the focus is very often on modifying lifestyle of people, where individuals are advised to move to more healthy lifestyles and moving away from sedentary life to a more active way of living, doing more sport and all that. But there are other developments going on that need to be factored in these lifestyle changes. But when it comes to the individual and making these changes in leading a more healthier life, I think it also merits attention that one of the emerging determinants, or maybe should we say the ignored determinants, which are not really addressed in the policy discussions that are happening, that are exactly the commercial determinants. We know that the private sector, influenced by the businesses that they run and the profit-making focus that they have. Now, the private sector does influence health outcomes. It does that in a positive way, but we know very well that some of the lifestyle changes that we have seen in the past decades, right, is a direct result of the private sector. Negative influence on people's habits, shopping behavior, diet. And we also know that the private sector is targeting young people that turn out to be more vulnerable to these influences, but also they are the generation that is going to make use of these new products that are being developed. And we also know that the private sector is much more active and putting more pressure in countries, low and middle income countries, where regulatory authorities may be less strong than what you see in other countries. So commercial determinants, is it emerging? No, private sector has always been there, but this is definitely something that would require a lot more attention from the policymakers, how you interact with the private sector and how you find ways to turn their business focus into a positive contribution towards health. Just to mention that when we are talking about risk factors and diseases, poverty, and there is often a misunderstanding, so this is not a new given, poverty contributes to NCDs. And it can be summarized, there are three main reasons. It is increased exposure to risk factors like poor diet, tobacco use, and harmful use of alcohol. But people who are poor, they also suffer from cancer, diabetes, and that is often not linked with, or that is often linked with new lifestyle diseases, but it is something that should also apply to people who have lesser means of income. And then what comes and defines their major contributing factor for them is limited access to services. So with the focus on equity and trying to bridge that gap, it will, improving access to services will also contribute to reducing mortality and morbidity of NCDs. Now, I've put it amongst the risk factors because we have seen during COVID-19 that many health systems are not really ready to deal with emergencies. And many health systems are actually not ready for the challenges, not only the challenges, but the demands and the new developments and evolution that we're going to see in this century. Now, when it comes now to our responses, is there anything emerging there that could either bring more solutions? Is it building on what we have done before and doing it better? And I think this graphic illustration summarizes it quite nicely when it comes to NCDs. First of all, it shows you that when we talk about NCDs, it covers an entire lifespan. People start off healthy, they increasingly exposed to risk factors, they may develop non-communicable diseases, they may develop complications, and when they grow older, we see then also that the population that is affected by NCDs, it reduces, but the health and economic burden does increase. Now, the responses that have been designed to prevent and control NCDs, it is, for anyone in public health, very recognizable. That hasn't changed. It is about health promotion, it's about risk reduction through screening, it is about managing people who are sick or treatment, it's rehabilitation for those who require it, and it is palliative care for those who come at that end stage of life or suffer from cancer and other related conditions. Now, again, for those in public health, prevention is the core of what we are focusing on. And you can see very clearly in orange for the four main NCDs, the diseases there, heart disease, stroke, type 2 diabetes, and cancer. If we bring down or we eliminate risk factors that are modifiable, it will have an enormous impact on the development of these diseases. I'm moving forward with responses and that have been taken so far. Sometimes we hear that the world is not acting upon NCDs. We are too late. But if you just look at the timeline of this slide, and this is a summary, or it gives you a timeline of global commitments, global decisions, policies, international guidelines. That starts back from 2000. That is where this timeline starts. But there are enough examples that this global commitment to address non-communicable diseases is something that has been going on for a good number of decades. So NCDs, in terms of responses, policy decisions, reorganizing our services, is not something of today. This is something that has started, but what is needed is an accelerated effort. So from the commitments, global commitments and policies, right, then come the suggestions, or not the suggestions, but the frameworks that and set out strategies to tackle NCDs. And I will not unpack this strategy, but you will agree with me, this is what is really challenging about NCDs, the complexity, the multifactoriality of how you look at NCDs and the individual in the middle. And it can be quite overwhelming for decision makers. Where do you focus? Where should the priority be? When it comes to concrete actions and activities and tools that you can use to reduce risk factor and diseases, here this slide shows you a number of packages. Many of them have been developed by WHO, but also with other partners. And some of the packages that are listed there, they have clearly demonstrated that when you apply them or introduce them, you can reduce premature deaths from NCDs. Now, another approach to NCDs, and this is now coming from the more economical side of it, and that financial rationale apply to NCDs and how to focus and where to focus on, is the best buy interventions. So WHO released a document tackling NCDs, WHO best buys, and it's for 5 common risk factors and diseases. They have identified 21 interventions that will give you the highest return on your investment. So this is the document that is available online. So what does that mean now? We looked at the best buy options and what that could mean for India. And you have listed here for India, according to that framework of best buys, for every return, no, for every $1 investment that is being made, right? On average, the return of that investment by the end of the SDG area, that is 2013, you can get a return of $8.7 US. And the highest return on your investment, oh, no, okay, let me go back, is reduction of smoking and intervene at that level. On that one, for India, you get a return of every dollar that you invest of a factor 9. So that is an approach that is being offered to make policy choices and how you prioritize your focus, but also how you prioritize the use of the resources that are always in limited supply. Now, the government of India has developed its national monitoring framework on NCDs, and it has set out 10 targets that should be attained by 2025. And they are nicely listed there, and it is quite impressive that with another 3 years to go, you will see that the targets range from 10 to 50%, up to 80% of what should be achieved within the next 3 years. Action that has been taken, and that is in line with what the previous speaker emphasized on. When we talk about NCDs and taking care of people with chronic diseases, comprehensive primary health care is really the core and the best approach when, for delivering health services. Surely if we do want to move towards more universal health coverage, and the government of India with Ayushman Bharat is going that direction. A lot of progress has been made by bringing health services closer to people through health and wellness centers, but also, and that is a very important development, expanding the range of services that you get at that level. Okay. Now, I want to just summarize a few key points from the slides that I have been taking you through. And with the last slide, when I said comprehensive primary health care, comprehensiveness and integration is what we promote, but it is not easy to do. The temptation of applying a singular focus, the temptation to use a more vertical approach, especially when it comes for some of our partners who have short timelines to achieve or move forward, it is challenging to be comprehensive and still show results. What I have tried to show you that public health principles still stand as they are, the whole range from prevention to palliation. Implementation is, excuse me, implementation is happening. Policies are there, commitments are there, implementation is happening. That takes time and that is usually very challenging. But whilst good policy, strategies and action is being implemented, governments and decision makers also need to anticipate the changes that are going to come and that may dominate the profile of diseases that you will see in your primary healthcare setting. Dementia is one of them. Then the need for more data, more evidence. That's where I started. There is an untapped source of information that India should focus on, and that is through the CRVS system. Causes of that. Only 22% of all death certificates have a medical cause of that. So for 80%, almost 80% of the people who die and who are registered and have a death certificate, India does not know what people died of. And if we would have that information, it would bring so much more depth into our understanding of diseases and especially non-communicable diseases. Increasing our investment, I don't think this is something that should be disputed, but also more efficient use of resources. And then finally, a call for more research, operational research. It continues to evolve in the health sector, so we need to be on track of what is happening, and especially when we look at service delivery models, what works, what doesn't work. And then I would like to end my last slide to remind all of us, 2030 is coming close. We're almost halfway. 7 more years to go. And non-communicable diseases, our target 3.4 is lagging behind. So for the next 7 years, if we do want to make progress on our health SDGs, more efforts need to be made. And I'd like to thank you for your attention.
Any questions from the audience? Okay. Thank you, ma'am. Thank you for the enlightening presentation. Ma'am, please. Ma'am, please. Please, ma'am. I request our additional director, Dr. Bhavani ma'am, to hand a memento to the speaker. Ma'am. Thank you. Now we are into the final session of the day. Now we have a panel discussion on combating challenges due to lifestyle changes, substance abuse and cross-cutting risk factors, chaired by Dr. Poona Chandrika ma'am. Welcome you ma'am. Ma'am completed her MBBS in Madras Medical College and completed her MD Psychiatry in Stanley Medical College and joined service in 1996. And she is a speaker at Bar Council of Tamil Nadu and Puducherry and speaker at Chettinad Hospital Research, speaker at Sri Balaji Medical Hospital, and now currently serving as Director, Institute of Mental Health. And before going into the next part, on behalf of the committee, organizing committee, I apologize for the delay, the panel members in the chair. Welcome you, ma'am. I request you to please introduce and invite the speakers, panel members. Over to you. Who will be showing them later? Maybe speakers. They'll show you. You have the copy? No. I haven't the copies.
Good evening, one and all. It's a very difficult time for us, both being the last session and also a most important topic of the day. So almost continuing from the previous speaker. And also being a moderator, I'm honored and pleasure to invite teachers, students and all of the panel members here. So first, it's Dr. M. Suresh Kumar sir, Research and Development Director. It's a pleasure to introduce sir. He's a clinical researcher, psychiatrist and Research and Development Director for Cities Rise in India and globally. And at Cities Rise, Suresh sir leads collaborative efforts to develop innovations to bring the best of evidence and community's own experience for young people's mental health and well-being. He worked with UNODC, WHO and UNAIDS, World Bank and international donor agencies in the field of substance use and HIV. A former Hubert H. Humphrey Fellow in Substance Abuse, a former member of the Strategic and Technical Advisory Committee to WHO, HIV, AIDS Department, Geneva, and Executive Committee member of UN Regional Task Force on Injecting Drug Use and HIV for Asia and the Pacific, a former director of the International Harm Reduction Association, a former member, Scientific Advisory Board, National NIE India, and also Ethics Review Board at Schizophrenia Research Foundation, India. And he has undertaken a range of consultancies in substance dependence treatment and design development, evaluation of HIV presentation, care programs in several countries such as Afghanistan, Bangladesh, Bhutan, China, Indonesia, Iran, Kazakhstan, Laos, Malaysia, Maldives, Mauritius, Myanmar, Nepal, Sri Lanka, Thailand, Vietnam. I think it should be mentioned the whole world, sir. It is not just a few countries. And he also holds medical degree, PG, DPM and MD Psychiatry from Madras University and a Master in Public Health from Johns Hopkins University, USA. Sir, please welcome you on stage, sir. And also, we celebrate Suresh Kumar sir as one of our own from IMH. It's a pleasure and delight to have you, sir. And he never says no for any lecture we call from IMH. Thanks again, sir, on this day. Next on our panel is Dr. Rana Jay Singh, Deputy Regional Director, the Union Southeast Asia. It's a pleasure. He has 30 years of experience in public health at subnational, national, and international level. As a medical doctor, he has specialized training in managing chest diseases and promoting lung health. And sir has focused on control of tuberculosis, lung diseases, HIV, AIDS, and tobacco control since 1992. He has been involved in the implementation of India's revised national TB control and the national AIDS control programs. And as a WHO consultant, he worked in TB control and advanced HIV-TB collaborations to control both major communicable diseases. He is supporting policy development and implementation enforcement of legislations, capacity building of stakeholders, establishing networks and partnerships, and policy-focused research. Currently working as Deputy Regional Director at the Union Southeast Asia, where he leads tobacco and NCD control programs of the Union. We welcome you, sir. Welcome, sir. And our next panelist, Professor Dr. P.P. Kannan, is a professor of psychiatry, RGGH. And he's completed MBBS in 1997 and MMC, completed MD Psychiatry in 2006 at Madras Medical College. Another one of IMH students, worked as assistant professor in Department of Child and Adolescent Psychiatry of ICH for 6 years, and had worked as associate professor for more than 6 years, first in our IMH, and for 3 years, and later worked in KMC as associate professor for 3 years, had written a book on child mental health for teachers and parents, had worked as professor and HOD for 2 years at Chengalpet Medical College, Chengalpet, and currently has been working as professor of psychiatry in MMC RGGH since February 2021. Welcome you, sir. Our next panelist is Dr. V. Satish Raghavan, Joint Director, Tamil Nadu State AIDS Control and Directorate of Public Health and Preventive Medicine. And more on him, he did his MBS from 1991 to 1997, and NSA Pediatrics in Railway Hospital, Perambur, till 2001, and Health Officer at Thiruvattur, Tamil Nadu Public Health Services, 2001 to 2002. And again, PG DPH in MMC 2002 to 2004, and Health Officer MMC in 2004 to 2008, and MD Psychiatry MMC in 2008 and 2012. This panel has quite a lot of common grounds in it. And DDCMCHS in 2012 to 2016, and CHO Madurai in 2017 to 2019, and DDICTC TANSACS in 2019 to 2021, and Principal Health and Family Welfare Training College 2021 to August 2022. And right now he's a JD TANSAC 16th August 2022 to till date. One of our students here as panelist. Welcome you, sir. One of our panelists is missing due to the Kartikai Deepam, the religious thing of the day. So, of course, a very difficult topic in hand, but combating challenges due to lifestyle changes, and as I said, continuing from the previous speaker, and also the challenges of being the last session, but also the most interesting session, because we have hope with this panel. We will definitely bring about some framework, or at least address challenges which we are facing. And the developing countries like India, right now we have a triple burden of diseases, like unfinished agenda of the communicable diseases, the emerging non-communicable diseases, disorders related to lifestyles, and an emerging infectious diseases. And this huge burden of diseases, disability, and death can only be addressed through an effective public health system. So all said and done, it seems, according to WHO, there are 4 major risk factors for NCDs: alcohol, tobacco, poor diet intake, and lack of physical activity. So eat healthy, walk healthy, and a stress-free lifestyle is so easily said rather than in practice. And let us first call upon Dr. Suresh Kumar sir to talk on the challenges related to substance use and its impact on the public health. So, thank you, sir.
Many thanks to the moderator, Dr. Purnachandrika. It's a privilege to be here in the DPH icon. What I'll be doing for the next 10 minutes is to talk about combating challenges related to substance use. First, the most important public health message I want to carry to this audience is that any substance use that begins early on is a very good predictor that somebody would use it further and even become dependent on it. So the great public health message we need to take to younger people is delay the onset of substance use, be it tobacco alcohol, any other substance, if somebody is exposed before the age of 18 or even 22 now, and I think that's when the brain is maturing and myelinating, exposure to illicit drugs and illicit drugs can actually be paving way for dependence. The second important thing, I think in a country like India, we should be focusing in alcohol use. I'm very thankful to the previous speaker highlighting the importance as a risk factor. But I think if you look at the prevalence of alcohol use, you look at men and women, there is a disproportionate difference. Whereas Indian women are very nice and the prevalence of alcohol use is much less among them. Men, I believe, like 18.8% of the men in India drink. But in Tamil Nadu, it is little more, bothering because 25.4% of the men use alcohol. In Puducherry, our neighboring, union and territory, for obvious reasons, it's about 27.7%. So we have a huge burden in alcohol use in this country. And it is a killing disease because in the younger people between the age of 20 and 39, about 13.5% of the deaths are related only to alcohol. And alcohol kills about 2.8 lakh people annually in India, of which people are dying of alcohol liver disease is about 1.4 lakhs, people dying of road traffic accidents about 1 lakh, and about 30,000 people are suffering from cancer and dying. So it's a killing disease we should take into account. And I think when you talk about alcohol, always we talk about harms to the people who use alcohol. Please remember, there are equal number of people who are harmed by people who drink alcohol. So the harm to others is also a very important public health priority. For example, if you look at the social and economic losses to individuals and others for alcohol use is great. About 5% of the global burden of disease is only attributable to alcohol. But if you look at the harms to others, that is a very important public health message because number of people are involved in accidents, injuries that actually involves other people, not just themselves who are drinking and driving. And intimate partner violence in a country like India is extremely important. Domestic violence, if you look at the police records of domestic violence in the women police stations, alcohol use is the predominant factor. And Tamil Nadu, some work has been done in which you look at the analysis of suicide committed by women. One of the most important reasons why women commit suicide is the domestic violence. The perpetuator is an alcohol user, or the intimate partner violence is leading to suicide among women. So it's a very, very harmful substance, not only to the individual, but also to others. Alcohol use also has a very significant relationship with other NCDs. I think the previous speaker illustrated about that. Alcohol use has also enhances the sexual risk and also predisposes one for HIV risk. So it's a very complicating problem that we have. So in terms of public health approaches, I've taken off the slide that she was talking about, which is like increasing taxes and then banning alcohol advertising and then restricting the access to retail selling. If these are public health approaches which are proved to be very beneficial. But this apart, I want to tell you this. Recently, in IMANS, people have studied about alcohol policy in various states. They figured out states which have a very liberal policy but have a stricter enforcement are better off than states which have a very strict law and a policy but a very inconsistent enforcement. Unfortunately, if you look at Kerala, for example, where there is a very liberal policy but the enforcement is very strict, there I think the morbidity relating to alcohol is far less. So far, a few years back, the Tamil Nadu data tells that's a very strict policy but very inconsistent in enforcement. That actually is really not leading to good results, something that we need to look at. And I think harm reduction is something we need to focus on in alcohol usage because I think the drunken driving, which has become a very focus in Tamil Nadu, it's a good thing because it can reduce number of mortality and morbidity associated with alcohol. And I think as clinicians, we should really understand there is a very much a power associated with brief interventions. If you're a general medical doctor, even if you spend few minutes with your client talking about alcohol use and the harms, this could itself have a very positive and a beneficial effect to the individual. So brief interventions should be carried out at the primary care level. We really require the capacity building for all the medical officers and paramedical staffs, nurses and other people in effective treatment of alcohol, which is very much possible. And alcohol use should be seen as a brain disorder because only by seeing alcohol use disorder as a brain disorder, we can actually remove the stigma surrounding it, help people with effective methods. And I think the other important substance, which is important, is cannabis. I think if you look at the way the norms have changed around cannabis in the recent years, younger people are coming and saying, cannabis is not a drug. It is a herb. It can be used by anybody. It does not lead to any harm. This is a very dangerous statement, dangerous norm that is prevailing in the minds of younger people. With that, there is an escalation in cannabis use. And I think there are cannabis products available legally in this country through Ayurvedic products. That's also a very dangerous move. And what is the impact it has on the college-going and younger students and school students? Certainly, it interferes with the academic performance and the learning of younger individuals because they are spending most of their time in fantasy. And I think cannabis use in India is estimated recently, a few years ago, as 2.8% of the population aged between 10 and 75. But cannabis use alone, if you cut off, you can reduce psychosis by 8%. Even though the contribution may be very smaller in proportion, but I think for those people who suffer from cannabis-induced psychosis, it's a huge problem. Another escalating problem in many, many states of the country is methamphetamine, popularly known as crystal. And this methamphetamine use is having a serious problem among younger people because it produces psychotoxicity like no other substance is ever produced. It's actually a brain-damaging substance. Unfortunately, a lot of young people are exposed to methamphetamine. It's cheaper, easy to make from pseudoephedrine. So obviously, this is something that we should be worried about. And I think cocaine use is also increasing. You know, a few days ago, I think the Revenue Minister was talking about, Nirmala Sitharaman was talking about how cocaine is entering into the country, how DRD should be interested in this. But I think as physicians, we should be interested in the risk it has on the cardiovascular problems, hypertension, anxiety, and psychosis. These are problems we should be looking at and preventing. I'm just going to be spending the last 3 minutes on another important topic which I worked for about nearly 4 decades. I think I worked in substance use for 4 decades with opioid usage. In the last 25 years, I've been focused on HIV-related among injecting opioid users around the many, many parts of the country. This is the recent work we have done in the country. We looked at about 15 sites in the country. We looked at how hepatitis C is an alarming problem among people who use injecting drugs. See, we all know that the HIV is a big problem among people who inject drugs, but one thing which has been forgotten, which is much more a problem than HIV itself, is HCV, because almost saturated levels of HCV infection among people who inject drugs. The co-infection of HIV with HCV is also a very big problem with people who inject drugs. And I think the mortality rates among injection drug users is another problem. The overdose-related deaths is what we know. But we did a work early on in Chennai. We realized that AIDS was the most important factor why people are dying of injection drug use. Over a period of time, it is a co-infection which is responsible. Hepatitis C as well as C and HIV. But we realized to really address the problem of people who inject drugs, what we need is not abstinence. Abstinence-oriented approaches are the best approaches. If somebody is using drugs, he should stop drugs. That's the best. But that best can be done only for few people. Only 5% of the people will be responding to an abstinence-oriented therapy. Whereas we have to look at in public health, what is good for many. What is good for many is a strategy that actually targets risks and harms. So I really propose we must be actually working with, harm reduction interventions, because harm reduction interventions can actually reduce injection rates of the people, shift them to non-injecting forms, which means you can actually not have HCV at all. People start to develop HCV within 6 to 12 months of injecting. And I think today, the mortality in Chennai is mainly related to liver disease among people who inject drugs, not due to HIV, because HIV treatment is available very freely in this state of Tamil Nadu. So many people are dying of hepatitis C. So there are many other communicable and non-communicable diseases these people who inject drugs have. We recently found that diabetes prevalence is also importantly very high among people who inject drugs, and people have concurrent alcohol dependence disorder, and I think they have concurrent depressive disorder. So they come with many, many morbidities. So we really think injection drug users must be provided integrated care centers and services in the integrated care centers where everything that is available for them is included in a comprehensive package. So I'm just going to say, as a final thought, SDG 3 is what we really have to focus on. SDG 3 is what we need really to focus on, and which the previous speaker focused on 3.4, and I want to focus on 3.5, which is on substance use, which is strengthening the prevention and treatment of substance use, including narcotic drugs that I talked about and the harmful use of alcohol. I think prevention strategies for substance use should focus on inner development, social connectedness, as well as environmental factors and system factors. Only that kind of approach, a lifespan approach, will be very helpful for them. And I think we should be actually promoting evidence-based interventions for substance dependence in this country, not to forget about harm reduction strategies. Thank you so much.
Thanks a lot, sir, for the vast amount of work you did. You gave it in a nutshell of 10 minutes and kept to the time also. And as sir was telling, he did an extensive work in the injectable substance users. And right now in Tamil Nadu, sir know that Hopper's Foundation has given it to Institute of Mental Health, and we are the only one running an opioid substitution therapy center in IMH, which should be there in all the district. It should be reachable to everyone. And nowadays the youngsters are saying that they are talking of a conspiracy theory, that the tobacco people are the conspirators. They are preventing the cannabis from becoming legal. That is one thing someone from the college came and said, the people are preventing this cannabis to be made legal is the conspiracy theories among youngsters. And sir, from sir, we'll take it as a brain disorder. Most of the time, I'm so it's time to move on to the model of biological model and focus on SDG 3.5. And also the most important thing of this is capacity training for the medical officers and all the personnel involved, right from SHN, VHN, the ASHA workers, the HI, so that we identify and treat early. And thanks a lot, sir. And going to the next speaker. Sir, we will now invite you to give your thoughts on the tobacco burden, the tobacco control policies, and the current status in India. Thank you, sir.
Good evening, all of you. First of all, congratulations to public health professionals, especially from state of Tamil Nadu, and definitely I know across the globe on celebration of 100 years of Directorate of Public Health. So big congratulations. Thanks also for inviting me for this session. You see, I'm going to speak on a subject which still has not got your attention. When I am saying your means you public health professionals. The way it should have been. And why I am saying that, this is the culprit plant, tobacco. Tobacco use. And what is the magnitude of really the problem as on today? If you ask me, which is the biggest public health challenge right now, it is tobacco use. After independence, communicable diseases was, at the time of independence, communicable diseases was our major challenge. And now, because of non-communicable diseases, it is complete reversal. And tobacco use is one most important factor. So this is a culprit plant. And many of you, especially from South India, you might have seen that. Normally from North India, when I often ask, have you seen this tobacco plant, which you are using every day? But people have not seen that plant, which is causing so much death and disease. So this is how it looks. Large leaves, almost 2 to 3 feet height. And these are the true pictures from state of Andhra Pradesh, Gujarat. So there are many varieties of tobacco which is grown in our country. High quality tobacco, which is called flue-cured Virginia tobacco, is normally grown in state of Karnataka and some part of Telangana. There is a BD tobacco, smokeless tobacco in state of Gujarat, Uttar Pradesh. So almost 10 states grow 85% of total tobacco production in our country. Please see, this is very important public health statement. Tobacco is leading cause of preventable deaths. And you very well understand preventable, that how we can really prevent them, all those diseases. 6.4 million people, we just saw the burden earlier. 6.4 million people are killed by tobacco every year. And 1 billion people will die. 1 billion means 100 crore people will die because of tobacco if we do not do anything. Poor and developing country, there is again, the epidemic has completely changed from developed country to developing country. Till few years back, we used to say, no, it is not our burden. It is perhaps there, but it is completely, now it is our burden. When I say our, it means low and middle income countries. Please see this blue line. Leading preventable cause of death, kills up to half of the people who use it. Tobacco is such a product in our society which kills half of the people who are using it. And please apply this to your state or to our country. What is the burden? How many people are using tobacco currently? And what will happen? Is there any other product in our society which kills 50% of your own user? Drinkable or eatable or something to wear? There is no other product which kills 50% of its own users. It is only tobacco. So until unless we really do something, it is really going to be a big challenge. Many of you who are there, who have seen when HIV/AIDS epidemic came globally, the economy of many countries was destroyed. Same is situation here for tobacco control, tobacco use. Please see. Normally it is not good to compare the burden, but it is also important. Please see the burden. Tobacco causes more deaths and disease than HIV, AIDS, malaria, and now road accident deaths combined, all four. It causes more deaths, but still it is not the priority of the country globally that I will share with you and within our own at state level. It is leading cause of risk factor for 6 out of 8 leading causes of deaths. Please see, this is very important. If it is causing so much death and disease, what is the funding available? Please see the first bar diagram. AIDS causes about 2 million deaths. And what is the funding available? $20 billion are available. Please see TB. It causes about 1.5 million deaths. And what is the funding available? Please see malaria. And then finally see tobacco. Last slide, last bar diagram. Please see that spot. Tobacco causes 5.6 million deaths. And what is the funding? Your bar is not coming out. Hardly any funds are available for tobacco control. This is our situation. So much death and disease, no funding. It is only very few countries globally. India is perhaps one. We have a national tobacco control program, very much in early stage. When we compare our programs like TB control, malaria control, and all other programs, tobacco control is very relatively a new program. So I won't go into detail in the interest of time. Second-hand smoke is also harmful. It also causes death and disease. There is no second thought. You see, this is a burden. Please see, in year 2000, there were 2 million deaths in developed countries and roughly same in developing countries. Total 4 million deaths. Now what will happen in 2030? What will happen in 2030? The burden is shifting. In developed country, it will be only 3 million deaths, but in developing country, it will be 7 million deaths. So burden is already shifting from developed countries to developing countries. So this is again very important for us to understand. Youth, every day, 100,000, 1 lakh youth become regular tobacco users. Now what is situation in our country? How many tobacco users we have?
So whatever information we have, normally it comes from GATS. So I would request all public health professionals, so this is a very detailed study, Global Adult Tobacco Survey. 2 rounds have already happened. So this gives us exact estimates of every state. For example, for state of Tamil Nadu, we have 120 tables in this study. You can look at every indicator, and every indicator is very important if we want to do tobacco control. It is not like routine diseases. This is a product which is legal, it is available, and we are unable to do anything. Now see, what is the situation? In India, 29% Indians above 15 years of age, they use any kind of tobacco. Any kind means either they are smoking or they are using smokeless tobacco, chewable tobacco, or sometimes they use both kinds of tobacco. So in that way, we have 267 million tobacco users, 27 crore tobacco users in our country. It is such a huge burden. And as per WHO definition, tobacco addiction is a disease. So do we have such a number of deceased patients in any other disease? 27 crore tobacco users. I am also a TB physician. I can cure more than 90% TB cases with this confidence, but I cannot help more than 5% people to quit tobacco. I go around the state, I go around the other countries, quitting. Hardly there is any quitting. No one quits tobacco. In every meeting I often ask, have you met anyone recently who has quit tobacco? No. Very rarely. Then what will happen? These are the people, 50% will die because of tobacco-related diseases, and when they will die? When they have already COPD, emphysema, cardiovascular diseases, some kind of cancer. So what will be the outcome? So this is the major burden. Then I won't go into detail. Youth use. Already Dr. Suresh has very rightly mentioned the age, importance of age. Delayed age, younger the age of initiation, more difficult it is to quit tobacco. So roughly in our country, 1.3 million, 13 lakh people die because of tobacco. And TB, you must be aware, 4.5. Other diseases, HIV, AIDS, malaria, road accidents. So tobacco causes, even in our own country, it causes much more deaths. 3,500 deaths daily. 40% deaths in TB patients. Still, we don't find any kind of collaboration. 40% new cases, and then death among a male patient in TB. They are because of smoking, but still, there is no collaboration between two programs. This is a challenge which we are going to have. So very quickly, if you ask me, is there any improvement for the last 10, 15 years? Yes. In our country, we have been able to reduce tobacco use prevalence to some from 35% to 29% overall tobacco use. Similarly for smoking as well as for smokeless tobacco. You please see, what is the situation in Tamil Nadu? 20% Tamil Nadu people, they use any kind of tobacco above 15 years of age. And you know what is the number? Tamil Nadu has a population of, for example, 7.8 crore or 8 crore. 70% are adult, above 15 years of age, so 5.6. And with the 20% prevalence, our state of Tamil Nadu has 1.10 crore tobacco users. 1.10 crore. And for all public health professionals, it is a major challenge. And now I am going to share with you that thing which we have not been able to do. And what is that? We started tobacco control in India, including state of Tamil Nadu, in 2008-9. So between GATS-1, study GATS-1, which was done in 2009 and 2010, tobacco use prevalence in state of Tamil Nadu has increased from 16. So many of you who are already working in tobacco control, tobacco use prevalence in Tamil Nadu has increased from 16.4% to 20%. A major challenge Why that has happened? Already we are doing something in tobacco control. We are making our cities smoke-free. We are implementing the legislation. We are trying to establish tobacco cessation services. So this is something which is a really worrying thing, and you as a public health professional need to think, work closely with the government, how academicians, people among you who are working in various state in public health institutions, how we can just work closely with the Department of Public Health and see, analyze each and every indicator why tobacco use prevalence in Tamil Nadu has increased. And secondly, last one, tobacco control does not happen with the IC alone. Simple. Let's make people aware of harmful effects. Just to update you, as per GATS study, 90% people are already aware that yes, tobacco is harmful. So, that's Dr. K. Suresh, he mentioned enforcement. We have laws. Until unless enforcement of legislation, smoke-free, we need to stop people from smoking at public places. We need to stop any kind of advertisement. You see how much advertisement our film industry, they are smoking scenes. We worked with the Department of Public Health to see that those advertisements do not happen. But still, no one can do anything. Graphical health warning, tobacco taxes. In earlier session, it was discussed. So until unless tobacco control acts and policies are implemented, tobacco control will not happen with the IC awareness generation alone. Laws are there, law has to be implemented. Why India has already become a world capital of road accident deaths? Because we had law. Motor Vehicle Act was there since 1934, but we did not implement. We do not wear helmet. We do not wear seat belt. So that is why India is now having highest number of road accident deaths. So very quickly, let me see anything. Yes, so tobacco, in addition to that, it also causes a lot of economic burden. Tobacco taxes, every 100 rupee government gets as a taxes, government spends as a health cost 836 rupees. Every 100 rupee which government is getting tobacco taxes. So this is the problem right now. Which is more harmful? People often say, BD, no, BD is herbal. BD is not harmful. BD is more harmful. Already Mumbai cohort study has proved that BD is also harmful. For each 139 deaths because of cigarette, there are 178 male BD smokers who die because of BD smoking. So yes, every tobacco use in any kind is harmful. So that is a very clear message. So already, yes, environmental burden. So we spend 7 to 8 kilogram of wood to produce 1 kilogram of tobacco.
Yes, sir.
Yes,
Can
please.
we-
Anyhow, thank you very much. In the interest of time, although I wanted to discuss with you a lot, but only finally, this is a message that this is something we will have to do as a public health professional. I got a chance, being a clinician, I got a chance to work in India's 3 programs from the very beginning. TB control, HIV/AIDS control, and now tobacco control. Really, public health approaches is the only way to have all those diseases, this tobacco use under control. And I think collaboration, multi-stakeholder engagement is very crucial. So thank you and apologies for taking more time, madam.
Quite a gloomy picture indeed, that the funding for tobacco control is low and it kills up to half of people. And of course, the observation that media has put a ban on smoking, and we were a generation, we grew up with Rajini smoking and Shivaji smoking, and that was one of the scenes of remained favorite earlier. Of course, not anymore. Rajini has also stopped acting. So with this gloomy picture, we also call upon the next speaker, Professor Dr. P.P. Kannan sir, on the substance use, lifestyle issues in childhood, adolescence, and parenting, and a close watch on time.
Yes. Good evening, everybody. At the outset, I thank the organizers and academic committee for having given space for discussion on behavioral addiction. That is, the addiction, which we all very familiar with the alcohol dependence. The concept had evolved to consider certain behaviors which the individual himself is not able to control, the family is finding it very difficult to control. So, the scientists who are working with improving behavior, reducing the distress and impairment of individual in various domains, that is family functioning, social functioning, and his health. They try to include few behaviors and try to identify some attributes, factors involved with it, and subsequently try to identify a syndrome with it. In that effort, they had come to understand that the behavioral addiction is an entity which has biological underpinnings similar to alcohol use and cocaine, the opioid, similar to that. So, the behavioral addiction, which appeared in the latest classification of the latest classifications in psychiatry, they started including behavioral addictions, internet addictions, and online gambling, video gaming, and other addictions. We have data only for few diseases like internet addiction and online gambling. But for other addictions, the data is emerging. In behavioral medicine, which has significant overlap with the community medicine, there are a lot of factors which are in society, that is social determinants, which play a significant role in modifying the disease course. And even though we have identified so many biological underpinnings, we are not able to control the course with a biological treatment alone. The larger role of the social determinants helping us to address this issue. So we need to adopt public health perspectives. So coming to this addiction, the definitions are evolving. Behavior is a continuum. There is a difficulty in setting a cutoff point between the normal behavior and abnormal behavior. Even for the established illnesses like schizophrenia, bipolar disorder, many of us not readily agree when the psychiatrist, clinician make a diagnosis at the beginning, in which the possibility for recovery is very high. Think about newer addiction categories. Definitely there will be some reluctance. So my presentation would be to give you some idea about these behavioral addictions. We do not have data except few studies coming up from our Indian setting. So what exactly, how exactly it is defined? We are all familiar that alcohol dependence, the individual standing in front of Tasmak shop with a tremor in his hands, and he is with so much craving, and he is demanding for more and more alcohol as he start using it. The tolerance and withdrawal were considered as primary symptoms of dependence initially. Even now, many physicians, they consider withdrawal symptoms and tolerance. In fact, the current science had moved away from this criteria, and they focus on individuals' diminished ability to control his behavior. It can be alcohol use behavior, it can be internet use behavior, or it can be sexual behavior, or it can be food taking behavior. So, addiction is all about diminished control over a particular behavior and the priority given to that behavior, and he continued to indulge in that behavior in spite of having experienced negative health events. and his persistent desire to continue that behavior, even though many people advise him not to go for it. These 4 points define the addiction. And still, withdrawal and tolerance are considered, but it is not considered in priority. So, I want all the people, public health people, need to be aware that someone is repeatedly going for a particular behavior. Be aware, it can be a part of addiction. It may be one symptom of addiction. So, this social media use, the internet addiction we are going to discuss. I am going to just give some idea on that. This internet addiction, even though it is vaguely used, yes, it is an established diagnosis, and we all know that it takes away all our time. Children and adolescents are spoiling their time. We frequently talk about only children and adolescents, not about adults. We ourselves are just clinging to our mobile phone till late night, including me. Everybody is aware of that, but we have control. When there is an issue, we are able to throw away our mobile phone and get into our work. That ability to adapt and quickly modify our plans, actions, that is not allowing us to get into the idea of addiction definition. This addiction, internet addiction, can worsen depression. There are few scientists who suggest that people in depression resort to internet use to maintain their well-being. So the research is supporting both principles, that is both points, that is internet use leading to worsening of depression. Depression leads to excessive internet use. And the symptoms associated with internet use would get worsened. The comorbidities like ADHD, oppositional deviant disorder, depressive symptoms, anxiety symptoms would go for exacerbation. And what are the direct effects of the internet addiction? It leads to inadequate sleep, lack of physical activity, and cyberbullying. You are all would have come across. Few people might have left the group, and subsequently they would have been brought into the group by our friends. What is that? There may be a problem with the individual himself, but most of the time when many people start discussing one particular point raised by the individual and subsequently making comments and belittling him, that is bullying. This is very common among adolescents, and yes, the internet addiction would lead to that. How it affects our mental health? The people who are watching internet, television, they frequently look at the images, body images, and their lifestyle. So they frequently compare themselves. This is natural to compare one with other, but this comparison frequently goes to a greater level that leads to body image distortions and reduced self-esteem. So individual naturally, when they go for reduced self-esteem, they become vulnerable to developing depression. So the children and adolescents, as they move from the age of 10 years to 19, 20 years, the natural process is they go for looking for more autonomy and identity. This makes them to get used to internet. That is, they are able to freely connect with anybody with whom they want to relate with. So the autonomy seeking and identity seeking of adolescents propels them toward internet use, but when that leads to the points I just mentioned in the first slide, diminished control over the behavior, priority given to that behavior over other activities, lead to internet addiction. So there are positive effects too. We should not forget. We cannot talk about removing internet or stopping internet like we come back to malaria control program, no? After starting with the malaria eradication program. Similarly, not similarly, we cannot even think about eradicating this particular use of internet or mobile in children. Of course, they need to be regulated. People feel connected, it fosters empathy, internet use helps to spread businesses, and it helps to gain support from peer group. So the symptoms, the diseases that are worsened by internet addiction are the depression and anxiety, and self-esteem of the individual get reduced, and there is a false sense of connection in major portion of people who are using internet, and cyberbullying we had discussed, irregular sleep pattern leading to daytime somnolence and other diseases. Many children and adolescents develop unrealistic views about their future, and fear of missing out. That is, whenever they are not in a group, when they are not given the likes, they become disappointed immediately. The toxic comparison, that is, they compare themselves with the images they see in the screen. That leads to many negative mental health sequelae. And social media narcissism, of course, you would all be knowing when you are in a group. So what are the red flag signs when you need to refer an individual to a clinician, or you should consider treatment for the individual? Aggression, academic failure, and school dropouts. Of course, every mother would be telling us that this child is always addicted to gadgets. And the mother, you know, when she wants to feed the child, she herself promotes YouTube watching. So there is a conflict, and we are not consistent in enforcing certain rules we follow in family. And we need, most of the problem can be addressed when we adapt to this public health approach. See, we all know there is a village in Maharashtra recently, it was popular WhatsApp message also. That is, one particular village had banned mobile use for children. So when we adopt that kind of approach, when all family plan to switch off mobiles by 9 o'clock, probably the family well-being may be greatly increased. But how to build the cat? So the leaders has to repeatedly talk about this particular issue, and this behavior is considered by scientists as amounting to be called as a disease. That need to be instilled in everybody's mind. And of course, we need some professional associations like Alcoholics Anonymous and Opioid Anonymous. We also need to have parents' body or professional bodies from community. The people who had recovered from this particular addicting behavior, they need to form and they need to educate the people. We need to train the professionals too at all levels. What are the public health perspectives we can have? The approach to this problem is more like how we handle chronic disease like tuberculosis or cancer or diabetes or hypertension. It's basically a medical problem, relapsing and remitting illness, and it cannot be solved with medicine. Medicine-assisted treatment is existing, but addressing the psychological factors and social factors are very important. That is why we need to have some policy, public health policy, to address all these issues. Integrating services and availability of accessibility of services are very important, and we have to reach out to the community leaders to educate the public about the harms of the excessive use of internet. We need to educate them about red flag signs involved with internet addiction, and we have to advocate continuously about these newer addictions. And most importantly, when we say don't use internet to our children, do we have any other alternate? Rather than parents advising, teachers advising the children, they should spare time, they should talk to the children, they should take the child or adolescent for a nearby restaurant or to a park, spend time, engage them. That is the best way of handling this issue, rather than advising and preaching about internet addiction. But we accept or not, the disease called addiction, behavioral addiction is emerging. It is included in newer classificatory systems. The statistics as a science fastly evolved in 60s and 70s. The imaging technologies fastly evolved during the last 2 decades. And we started getting more insights about these addiction, behavioral addictions only recently. So this may appear new to a few people. People may reject it as a diagnosis, but it is going to be there for another few centuries if we fail to adopt a public health approach. Thank you, one and all.
It was not bullying you, sir. The time limit was gone, so that I had to set a timer again and again. So most of our children actually guide us how to post pictures on net or Instagram, and the most panic sets in when our battery charges run low also in our mobile. And at the same time, the online gambling leading to more suicides is a matter of concern. And at the same time, positive or negative or a lifestyle challenge is a Swiggy available at 1 a.m. in Tamil Nadu, providing us hot biryani, which will be another lifestyle challenges also. So with all this in mind, we'll go on to the next speaker, one of our very own. Come, please invite Professor Dr. Satish Raghavan, sir, to include SDG and challenges due to substance use in HIV, opioid dependence in HIV, sir.
Good evening to all. The most challenging is being the last speaker of the day at the end of the day. Problems have to be solved. We are discussing problems, otherwise they remain. Let us talk about the solutions from the public health perspective. First, we have to learn from history. History is a data which we are going to just see. If history is not learned, it repeats. What is a repetition? We'll just see. So, to realize something, we need to set a goal. SDG, Sustainable Development Goals. So goals are reached only if they are visualized. Otherwise, they will not be reached. So in substance use, we come into interface with not only communicable disease like HIV, non-communicable disease. So it is going to be a game changer, or rather a game spoiler if we want to reach SDG. So let us go into that. If you take HIV, it is going to, there are 2 SDG goals. One is you have to reduce the HIV deaths. Second is no new HIV infections by 2030. PrEP. PrEP is pre-exposure prophylaxis. So what is the challenges in substance use is, it takes away consent. Even if condoms are provided or intravenous drug, it is going to increase the infections. We are just going to see data. What happens when substance use increases? Say for 20 years data. Second is injectables. Injectables are going to increase HIV transmission. Third is opioid crisis. During COVID, we saw how the opioid crisis happened in US as well as in Canada. And important thing is, any substance use, it produces depression. So NCD management gets worsened. So this is a data showing our targets, 90, 90, 90 in 2018. Tamil Nadu has achieved that 95. Now the target is 95, 95, 95. 95 is how much you screen. Among those screen, those who are positive, how much get ART. Among those who are getting ART, how much is actually virally suppressed. So if you take the entire comparison, if you take new HIV infections, majority have fallen. But if you take Latin America, there is an increase of 3.1. Another Eastern Europe and Central Asia, 25% increase, whereas other countries are falling. Likewise, in AIDS-related death, if you see, everywhere it is falling except in Western and Central Africa. Now, if you correlate this, see the 2 targets SDG is, one is reduction in deaths, second is no new HIV infections. They follow a pattern. What is the pattern is, if you see the 1990 to 2019 data, so the alcohol use, wherever it is increased along with the illicit drug use, use is different, disorder is different. People may use alcohol, but once it becomes a disorder and is equal to the illicit drug use, like in Latin America versus Asia, alcohol use is high, but it is more than the illicit drug use. Here, it is approximately equal. What happens when illicit drug use becomes equal to alcohol drug disorder? More number of deaths in NCD. So we are discussing about alcohol, liver disease. We are also discussing about the other things like which caused because of alcohol, cancers. So the entire NCD spectrum becomes increased. So that is what is happening in this 10 years data. Now let us go further. Analyze the patterns of use in these countries. If you take South America, which we are talking about Latin America, it is more of cocaine. As sir has told, cocaine, what it does is, it causes more cardiovascular disease, more mortality, more hypertension, increase the deaths from NCD. I'm not telling morbidity, deaths are increasing from the, so this is a pattern in America versus Asia. Asia, it is more of cannabis and less, so the mortality is less. You can see the mortality is less, but morbidity is more. So this is the source of the data is from the GH, Global Burden of Disease. So if you take Latin America, drug use, if you see alcohol use disorders, we are not talking about use. Tobacco, if you see, is the highest. As sir was telling, tobacco is the highest risk factor, 4,45,000. But nobody uses tobacco alone. Somebody who takes tobacco also uses some other substance like alcohol. Now that is the thing which we need to concentrate. So when somebody is using tobacco, he or she may be using some other substance. It may be alcohol, opioid. So wherever alcohol use disorders and illicit drug use is high, that is associated with increased mortality, as we see from Latin America. So this is the history and the lesson we learned. So if you take East Africa, you see that drug use disorders and alcohol use disorders, drug use disorders are very high, meaning illicit drugs are more available. Now this is a situation we cannot allow to happen in India or in Tamil Nadu in particular. What happens is if illicit drug use increases, then the mortality with the NCD will increase. And our NCD, SDG goals, what is the NCD? We are going to see that that will not be attained. In fact, our HIV goals also needs to be attained. So if you want to achieve that, our substance use need to be controlled. So this is the ODC pattern in Africa, where it is more of cannabis in East Africa. So 3.5 is a sustainable development for so strengthen the prevention and treatment of substance use, including narcotic drug abuse and harmful use of alcohol. This is one of the SDGs. Now, let us, looking at the problem now, what is the solution? What do we have? We did something called National Mental Health Survey in 2015 to 16 to find out what is the prevalence between Tamil Nadu and India. So we got the suicide rates, especially if you see alcohol use disorders, it is 5.9. If you see national average, our suicide rates was very high at that time. The gap, alcohol use disorder, the gap, treatment gap is 97.5. Now, after post-independence, this is the first survey which was done by household survey. It was done across 8 states, and in Tamil Nadu, we used 3 pilot districts. This was conducted by NIMHANS, and the study result shows there is 97.5% gap in treating alcohol use disorder and 96.3% gap in depressive disorders. So unless we fill up this gap, this NCD goals, SDG will not be reached. So we will define the problem further. So SDG goals will be HIV, even HIV SDG goals will be cut by substance use. What is the NCD goals? Our NCD goals sets that we need to reduce by 1/3 what is the preventable cause, premature deaths in NCD. So that can be achieved only when you reduce the substance use. So madam was, the previous speaker, WHO speaker was the 5, tobacco use, physical inactivity, harmful use of alcohol, unhealthy diets. All these increase the risk of dying from NCD. So if you see 50% tobacco use, harmful use of alcohol, and unhealthy diets, more than 60% will contribute to worsening early death. So unless we address this, the deaths are going to increase. Now, let us see disability versus number of deaths. If you see the disability, drug use disorders, 24% is a disability. If you see the number of deaths, it's reflected as plus 71%. The cocaine use, the opioid use disorders, more the mortality. So more the disability, meaning more use, more mortality, NCD. So what is the so the priority area is to concentrate on this. In fact, the drug use disorder, the other also increase, cirrhosis, liver cancer, HIV, self-harm. Self-harm is suicides. So everything increases because of this problem. So if you address this one problem, cancers will reduce, the other problem will be able to, so a single point of attack, we can reduce all other things, including liver cancer, chronic hepatitis, everything is related to this. Now let us go into the solutions. So what is the possible solutions? Is it prohibition? So prohibition, many states have tried, but what happened is it has met with failure. We can see for Tamil Nadu experience, a lot of huge tragedies happen. So because of that, we had to go for this. So prohibition may not be the solution, because if you don't have in Tamil Nadu, they're going to go to Pondicherry or Kerala. See, Kerala tried with prohibition and it has failed. So treatment gap. See, we discussed about the National Mental Health Survey. The treatment gaps are there. So as sir said, capacity building, filling up those treatment gaps for depression as well as for alcohol use disorders will be the answer. Second is pricing. Many of the speakers have discussed about how you price alcohol and other substance use or disincentivize use. That may be one of the solutions. An important thing is the illegal drugs, if it is made available, what happens is it increases mortality. So we need to, UNODC has recommended, Organized Crime Act should be applied. So applying a set of measures, including this, whether you use treatment filling gap, demand supply control, and using legislation. We already have the NDPS Act, but most important thing is Organized Crime Act, where the entire team is done as recommended by ODC. Strong political will is needed for this. So these are some of the possible solutions which we thought we'll discuss. So important thing is two things. For HIV, if we want to achieve that, we need to reduce substance use. We need to address the gap for communicable disease. Non-communicable disease, if we want to reach the goals, reduction of 30% mortality in premature deaths in NCD, we need to address the substance use, and especially the use of substance by proper capacity building and training. Thank you.
Thank you, sir. So the common thread through all of it is capacity building and a number of sustainable development goal of 3.5. So I don't know whether we have time for questions, sir. The organizers has to take, we can take one or two questions. Anyone in the audience still there waiting to ask us questions? Lot of arms are up, sir. Yes, please introduce yourself and ask.
My question is to Rana sir. Sir, in GOITS 4, and the prevalence of cigarette smoking and BD smoking reduced more than 50%. But the overall tobacco smoking is not reduced by 1%. So are we fail to address the hookah, like other forms like hookah, electronic cigarette? Why the prevalence of tobacco smoking is not reducing?
Madam.
State?
I'm talking about GOITS 4th round global youth survey report that shows that prevalence of cigarette smoking and PD smoking reduced more than 50%. But overall tobacco smoking is reduced by 1%.
Yes.
That means we are missing out other form of smoking like hookah smoking, electronic cigarette. Are we failed to address that?
No, you see, when we talk about smoking, when we say smoking, all forms of smoking, not only, so there are 7 or 8 types of major smoking. Cigarette, BD, then hookah, then charoots, chillum, reverse charoot. So there are many varieties of smoking which are there. So it's not only cigarette and BD smoking. There are many other varieties which are there.
That's what my question, sir. Are we addressing only cigarettes and BD? We forgot about other forms.
No. In tobacco control, when we say tobacco control, it covers all forms of tobacco. So this is something which now, that is why what I am saying, all indicators are there. What kind of tobacco use is there in state of Tamil Nadu or any other state? That is something which you as a public health professional need to guide your state government. That what are the things which we need to do? What is the main situation, what is the main problem in your state, and what are the additional things which we need to do? For example, smokeless tobacco. When we all started tobacco control under NFHS 3, it was, you see how the things have changed. In NFHS 3, India was having smoking as major tobacco use. But that has reversed. Now smokeless tobacco has changed. So everyone was telling us, let's have a law on smokeless tobacco. But current policies, current IC, current National Tobacco Control Program covers all kind of tobacco. But you as a public health professional, you have 120 indicators. Now please see. Now for example, simple indicator. What percentage of people, tobacco user, were advised by health worker to quit? So this is an important indicator. Many states have seen that health workers advised to a tobacco user to quit, that has gone down. For example, in state of, because of time I could not discuss with you other my concern for state of Tamil Nadu. For example, attempts to quit. What is the situation? Normally, how many attempts a tobacco user makes to quit? Normally 7 to 8 attempts in his lifetime he makes. Now see for state of Tamil Nadu, in GATS 1, 35.8% made a quit attempt in GATS 1. In GATS 2, only 31% people have attempted to quit. Why? When someone quits, when there is such an environment in our society, only then people quit. When there are laws are being implemented, when there is a good IEC program, when there is no peer pressure, only then people quit. So this is a bad indicator for state of Tamil Nadu that people's attempts to quit has gone down, both for smoking form as well as smokeless tobacco. So this is a very important indicator for those who work in tobacco cessation. Again, I am saying no one quits tobacco until unless you keep this thing in mind. Normally, people do not quit tobacco. If tobacco is freely available, accessibility and availability, then normally people do not quit. So please see all the indicators, only then you will be able to understand what are the things where Tamil Nadu need to focus. What is the situation in our rural areas?
Thank you, sir. Thank you, sir. I think that must have answered your question and query. Yes, sir.
Hello. Hello all. Good evening. Myself, Dr. Emmanuel from Banaras Hind University. I'm a third year postgraduate. Sir, actually, unless we close the overflowing tap, we are not going to stop the overflowing. So prohibition is always a question of debate all through the years. But we as a public health specialist to intervene before even the patient has started smoking. Once the patient starts smoking, we are losing our role as a public health specialist. So we can adopt some innovative steps. For example, the CODPA Act is there. It is saying that the smoking is banned till age of 18. But see at the other angle, it is indirectly giving permission for anybody above 18 years to smoke. So it is a, but the country like New Zealand has adopted.
It's an observation, sir. Your observation.
Yes, ma'am.
What's the question?
Exactly. I want to share the innovation by the New Zealand government. What it has did that, it has banned everybody born after 2004 to buy cigarettes. It has banned cigarettes for all those born after 2004. So it means in 18 years they're planning to shut down the cigarette companies. So similarly, we can also adapt just because I saw that question mark in that prohibition part, I want to suggest that there is an innovation followed by this New Zealand, which can be taken up by us also. Thank you.
Yes, sir. Your suggestion taken. We'll definitely post the innovation to the interested organizers.
Good evening, madam. Myself, Dr. Satish Kumar, madam. Some of the countries have legalized cannabis, madam. What are the potential danger we might encounter if get legalized, and what is the system we have to deal with it?
Sir, you want to answer that?
I think countries which have legalized cannabis did for one reason. It was actually spearheaded by United States in a big way, because in a country like this, people who belong to a particular community and ethnicity. One-time use of cannabis also landed them in jails, in the prisons, which is an absolutely unacceptable human right violation. So the police were overburdened, the jails were overburdened because jails were filled with cannabis users. So legislations have to be changed because a strong advocate stating that this is not really done. What is the public health damage done by cannabis versus alcohol, versus tobacco? That was the argument. They argued very strongly and said, since it's not producing so much of a public damage in comparison with tobacco and alcohol, which are legal drugs, why don't you just start to legalize it? Legalization does not mean it is okay to use cannabis. As somebody said, it's legal to use tobacco or buy tobacco beyond the age of 21 or 18, right? We are talking about two different things here. But in a country like India, where, whether you believe it or not, this is a country which has been smoking up for long years. Saints and fakirs have been using it for different purposes. Now, what my worry is, this legislation in a Western society gives a different meaning to our adolescents. They start to believe, because it's legalized in other countries, it's harmless. It is a herb. You can use it. People are wearing Bob Marley t-shirts and then coming and arguing with you and saying that, you don't tell me you don't smoke up. Have you smoked? Do you understand what it is? We know what it is. So the norms of the people have changed, which is a worrying thing. Problem is, when you start legalizing cannabis in a country like this, cannabis products have already found its way in many ways. You can get cannabis products indirectly. It's very difficult to buy cannabis in the illicit market, easy to buy cannabis in the legal market, different forms. So that's going to be a problem. How are we going to regulate it? In countries where they were experimenting with legislation, now we see an increased incidence of cannabis use, which is not a good thing. When it happens to adolescent population, when adolescent population start using cannabis because the brain is unmyelinated, we are going to see significant cognitive damage due to cannabis. And I think I worry about it as a public health person. And I think that's not the best of the things that could happen in a country like India. And I think we should really, really think a lot, entertain public debates before we come up with the knee-jerk reaction based on somebody doing it. We don't have to follow the West all the time.
Thank you, sir.
Thank you, sir.
Good evening, sir. This is Dr. Ponnarasu. So, to the entire panel, my question is, like, in combating challenges to lifestyle diseases and substance abuse, so what is the role of moral education in school levels? We said that delaying onset of a disease will have very good prognosis or we will stop. So, we are discussing everything about capacity building for a health officer or medical officer and everything. But what about moral education at the school level? What is the panel recommendations for this?
To me, moral education might send a different meaning to people and they might misinterpret it. I grew up in the 60s and 70s attending schools where the classes began with moral education. I see certain value to it. I'll tell you something which is scientifically happening at this point in time. I'm part of a group which is actually developing well-being as the goal. And we are talking about mental well-being, we are talking about a positive mental health, which is probably the core for everything. And in order to do that, we need to have a four-dimensional approach. One is strengthening the inner dimension. Second is working on the social dimension of increasing social connectedness with peers and adults. And third is working on an ecosystem which is very favorable for a normal growth. And lastly, a system which is favorable to it. But we really believe that the inner focus is the most important one. I think when we talk about positive mental health, it's not about languishing, it's about flourishing. When people have to flourish, only then they will be avoiding so many things, including managing lifestyle changes, managing substance use, everything. So the inner dimension focus is something we have to learn from the East, not from the West. Because traditionally, we were the ones who were telling the world how to develop an inner self. So I think if you have to be transcending the barriers and the frontiers, if you have to develop the inner self, I think the best way of doing it is a character strength education. I think the different name you give a character strength. We are doing an RCT in children between the age of 12 and 14 in 2 different countries of Chennai, India, and then Kenya in Nairobi. We are looking at the gratitude, which is about past, kindness, which relates to present, and hope, which relates to the future. These 3 dimensions are put together, gratitude, kindness, and hope. You are rolling it in art-based delivery, which means you're not teaching it a curriculum where using folk and theater and storytelling, you're telling it to the students. And it's an RCT trial that's being done in schools as well as in communities. Templeton Foundation has funded it. Probably a year down the line, I'll be able to answer very, very scientifically and say whether character education really impacts on well-being. That considers everything. I think our scales are not only reduction of some of these symptoms, but also looking at well-being indexes. I hope that answers your question to a certain extent.
Thank you, sir.
I am very optimistic that it is going to be the future. I think whether it is through whatever methods, I don't care, but I think strengthening the character is the most important thing, which I think will be the foundational force for strengthening the inner self.
Thank you, sir. Thanks a lot. We are ending with the...
Madam, to add on to that point, see, if we adopt this moral or immoral to call a behavior, then how will you go and explain this sex addiction, food addiction, and internet addiction? Everybody is using internet. So it is preferable to adopt health education rather than moral education. And we need to be aware of the cutoff point, which is a range. And we need to be aware of the impairment and distress involved with that behavior. That's how we can prevent severity of the illnesses.
Okay, sir.
Something called life skills in TANSACS. We have life skills program. Actually, that was the curriculum has been developed, WHO model. We are encouraging everybody in schools to reach. So rather than moral, this has served the purpose. We have red ribbon clubs in schools as well as in colleges to teach behavior as well as teach them life skills to cope up with the challenges of the day-to-day. So that is the thing which has already been established.
It's been conducted by district mental health program psychiatrist in all the schools along with RBSK, the life skill education. Thanks a lot. Due to lack of time, I know there are thousands of questions in your mind considering the topic at hand. I think we did the panel of experts. The injustice was the time allotted to us. So thanks a lot, sir. Thanks a lot.
The subject given was elaborately discussed, and we thank the chair and panel members for the insightful presentation. Thank you. Thank you. Now I request our additional director, our OSD sir to hand over the memento to our chair. I request our Joint Director Vinay sir to hand over memento to the panel members. Thank you, ma'am. Thank you. Thank you, sir. So, thank you one and all. The tomorrow session will start by 9:30. I request all the delegates to be on time. Thank you. Have a good night.